delegates, faculty, stall members, everyone please come in. The program is yet to start. Final announcement, all the faculty, stall members, students, kindly come in. The conference is about to begin. Good morning, esteemed chief guests, respected dignitaries, doctors, faculty members, technologists, our valued industry partners and dear students. On behalf of Society of Dialysis and Technologists Paramedicals, it gives me immense pleasure to welcome you all to the 18th annual conference SDTPCON 2025. We are honored to host this prestigious gathering at Sri Ramachandra Institute of Higher Education and Research Center, Chennai, an institution synonymous with excellence in medical care and patient care. Today is a day dedicated to innovation, learning, excellence in dialysis care and technology. Your participation adds immense value to this conference. Ladies and gentlemen, please join me in giving yourself a hearty round of applause for being here and making SDTPCON 2025 possible.
Before we begin this occasion, let us honor our heritage and seek the blessing of our motherland. May I request everyone to rise up for the Tamil Thai Valtu. national anthem.
माला सुधा कुंभ विबोध मुद्रा विद्या विराजित करवारी जाता विद्या विराजित करवारी जाता अपार कारुण्य सुधांबुराही श्री शारदांब प्रणतोऽस्मि नित्यम् श्री शारदांब प्रणतोऽस्मि नित्यम्
செந்தமிழைப் போல என்றென்றும் வாழும் ஸ்ரீராமச்சந்திரா என் தாயன எண்ணி உன்னை வணங்கிய பாடுகின்றோம் நாங்கள் கற்ற கல்வி பெற்ற பெருமை எங்களுடையார் தந்தது ஒட்டு தொடரும் சொந்தம் இதுதான் ராமச்சந்திரா சொன்னது பெற்ற அன்னை தந்தை போலே எண்ணம் எல்லாம் நின்றது உற்ற நண்பன் சுற்றமெல்லாம் இங்குதானே கண்டது வாழ்த்தி நின்றோம் வணங்குகின்றோம் வாழ வைத்த மையமே கூடி நின்றோம் பாடுகின்றோம் வானம் எங்கள் எல்லையே உலகம் போற்றும் திறமையாலே இன்றும் இங்கு முதலிடம் உயிரை காக்கும் உணர்வுதானே ஒன்று சேர்ந்த ரகசியம் ஆய்வு செய்தோம் சேவை செய்தோம் எதிலும் கண்டோம் மனிதமே ஆய்வு செய்வோம் சேவை செய்வோம் தொடரும் எங்கள் பயணமே ஸ்ரீராமச்சந்திரா வாழ்கவே.
Thank you everyone. Kindly be seated. Ladies and gentlemen, kindly put all your mobile phones in silent mode as we are about to begin. We are excited to announce that today's program is streaming live on YouTube and we also have audience watching straight away from Maharashtra, Punjab and Telangana. It's my distinct honor to invite our esteemed chief guest to join us onto the stage. Your dedication and contribution in the field of nephrology is invaluable. Dr. S. Manigandan, Professor, Department of Nephrology, Srihar. Dr. S. Sendilkumar Sir, Registrator, Srihar. Dr. T.V. Ramakrishnan Sir, Principal, Sri Ramachandra Faculty of Allied Health Sciences. Unfortunately, Dr. Vijay Kumar is unable to join us due to unavoidable commitments. We extend our warm regards to him and proceed with our honored guest. Ladies and gentlemen, please welcome them with a big round of applause. Thank you, sir. Additionally, we are privileged to have the key leaders of SDTP with us. I warmly welcome all the leaders to join us onto the stage. Mr. L. Shivamani sir, Patron, STDP. Mr. R. Sendil sir, Founder and Secretary of STDP. Mr. T. Jayasilan sir, President, STDP. Mr. B. Ruban sir, Vice President, STDP. Mr. Y. Arogya Jas sir, Joint Secretary, STDP. Mr. A. T. Sri Mukund sir, Treasurer, STDP. Dr. T. Jagadishwaran sir, Advisor, STDP.
auspicious beginning of SDTPCON 2025, we now proceed with the lighting of the ceremonial lamp, a symbol of wisdom, purity, and enlightenment. May I request the following dignitaries to kindly come forward and light the lamp. Dr. S. Manigandan Sir, Professor, Department of Nephrology, Srihar. Dr. S. Sendil Kumar Sir, Registrar of Srihar. Dr. T. V. Ramakrishnan Sir, Principal, Faculty of Allied Health Science. I request to light the lamp, sir.
For lighting lamp and being a part of this tradition. May I now invite Mr. Sendil Sir, Founder and Secretary of STDP and Organizing Secretary of STDPCON 2025 to deliver a welcome address. Sir, please.
அனைவருக்கும் காலை வணக்கம். சிறப்பு விருந்தினராக வருகை தந்திருக்கும் டாக்டர் மணிகண்டன் சார், டாக்டர் செந்தில்குமார் சார், டாக்டர் ராமகிருஷ்ணன் சார் அவர்களே வருக வருக என்று வரவேற்கிறேன். மேலும் எஸ்டிடிபி பாடி மிஸ்டர் எல் சிவமணி சார், ஜெய்சீலன் மற்றும் முகுந்த் சார், ரூபன், ஆரோக்கியதாஸ், டாக்டர் ஜெகதீஸ்வரன் அவர்களையும் வருக வருக என்று வரவேற்கிறேன். மற்றும் மருத்துவர்கள், பேராசிரியர்கள், டயாலிசிஸ் டெக்னாலஜிஸ்ட் மற்றும் மாணவ மாணவிகள் அனைவரையும் வருக வருக என வரவேற்கிறேன். இந்த கருத்தரங்கம் சிறப்பாக நடைபெறுவதற்கு உங்கள் ஒத்துழைப்பை வேண்டுகிறேன். மீண்டும் ஒரு முறை அனைவரையும் வருக வருக என வரவேற்கிறேன். நன்றி.
Thank you, sir, for setting the tone for today's proceedings. I cordially invite Dr. Manigandan Sir, Professor, Department of Nephrology, Srihar, to deliver welcome address. Your presence and words of wisdom would greatly enhance the crowd, sir. Sir, please.
Good morning, one and all. It's a great honor in welcoming you all to this 18th annual conference of the Society for the Dialysis Technologists and Paramedicals in our college. Seeing so many passionate professionals in one place reminds us of the great power we have in making real difference in the patients' lives. Together, through today's sessions and discussions, we share knowledge, inspire one another, and also set some great benchmarks in the dialysis practice. This conference is not just a meeting, it's a celebration of our commitment towards excellence, safety, and innovation in renal care. I would also like to especially acknowledge the tremendous effort by the SDTPCON members and the faculties, dedicated faculties of renal and dialysis technology of our college. Without them, this grand event wouldn't have been possible. I wish them all the very best and thank you for the enthusiasm showing. Wishing you all a memorable and a productive dialysis conference. Thank you.
Thank you, sir, for your valuable insight. We now invite Dr. S. Sendil Kumar sir, Registrar of Srihar, to share a few words. He is known for his aversion in medical education and administration. He has been instrumental in the fostering innovation and excellence of Srihar.
Very good morning to one and all present here, respected dignitaries on and off the dais, dedicated dialysis technologists. It gives me immense pleasure to participate in this 18th annual conference of SDTPCON 2025. As you all know, today we have gathered here to recognize and celebrate our invaluable contributions to healthcare. Your expertise and compassion have a profound impact on the lives of patients undergoing dialysis. Your role is more than just a technical, it is a testament to your dedication, empathy, and commitment to improving patients' outcomes. You are the backbone of the dialysis services, ensuring that patients receive the best possible care. My hearty congratulations to the entire organizing team. On this occasion, I would like to express my deepest gratitude for your tireless efforts, often working behind the scenes to provide life-sustaining treatment to those in need. Your work is a shining example of healthcare excellence. I hope this conference will be an academic feast. As we continue to advance in dialysis technology, I encourage you to stay updated, innovate, and strive for excellence. Your expertise will shape the future of renal care. Once again, I congratulate each and everyone for your remarkable work. Your dedication always inspires us. Thank you, one and all.
Thank you, sir, for inspiring words and gracing the audience. Our next speaker is Dr. T.V. Ramakrishnan, sir, Principal, Faculty of Allied Health Sciences, Srihar, a leader dedicated to empowering allied health professionals. He plays a key role in shaping the next future generation. Sir, please.
Thank you. A very good morning to all. It's wonderful to be standing in front of you. This is the 18th conference, mind you, and it's not very easy to have this conference year after year. The Society for Dialysis Technologists and Paramedicals, and I'm so happy that the Department of Allied Health Sciences of Nephrology is so active in having this conference held year after year. And I hear there are more than 1,500 registrations this time, which is amazing. And that also tells you about the quality of education that is happening in our university. There are so many students who come here to benefit from the experience of the excellent teachers that we have. Another good news is we are now having the Council for Allied and Healthcare Professionals. And that has given an impetus for all of us. I'm sure with the advent of this, we will have a common syllabus across all over India, a good infrastructure, and ensuring that we have teachers to teach students, because in some of the colleges where students go, unfortunately the infrastructure and the teaching is not up to the mark. So I think it's very important for us to standardize this at the earliest so that students benefit finally and the standard of education improves, which in turn helps patient care. We can save more lives. I wish you all the very best, and it's a good place for you to talk to each other. Networking is very important. Jobs, this is the place where if you're in the final year of study, you can actually find out from other people about job opportunities and learn the latest that is there in dialysis technology. Thank you again for having invited me.
Thank you, sir, for your thoughtful words. I would like to welcome Mr. L. Shivamani, sir, patron of SDTP, on the stage to share a few words.
சார் எல்லாருக்கும் வணக்கம். இந்த மீட்டிங் 20 வருஷத்துக்கு முன்னே டெல்லியில் வந்து பேசிக்கிட்டு இருந்தோம் அந்த மீட்டிங் ஆரம்பிக்கணும்னு சொல்லி. அப்போது வந்து செந்தில், தாமோதரன், நான் 3 பேரும் அந்த மீட்டிங்கில் பேசினோம். 3 மாதத்தில் வந்து செந்தில் வந்து ஒரு மீட்டிங்கை கூட்டி கோயம்பேடு மார்க்கெட்டில் ஒரு செமினார் ஹால் ஆரம்பித்து அதில் அந்த மீட்டிங் ஆரம்பித்தார். அதிலேருந்து 20வது வருஷம் இது மீட்டிங் நடக்குது. ஆனால் 18 மீட்டிங்கு தான் நடத்தியிருக்கோம். 2 வந்து கொரோனாவுனால நடத்த முடியாமல் போயிட்டுது. அதில் வந்து செந்தில் வந்து அன்னையிலிருந்து இன்னை வரை ஹார்டு ஒர்க்கர், நல்ல ரெஸ்பெக்ட் உள்ளவர். அவருக்கு உறுதுணையாக வந்து 3 பேர் இருக்கிறாங்க. ஒன்று கல்பனா, இந்துஜா. அவங்க 2 பேரும் 3 பேரும் அவங்களுக்கு வந்து பேக் ஃபோன் தான் சொல்லணும். அவங்க 3 பேர் இல்லைன்னா இவரால் இந்த மீட்டிங்கை கண்டக்ட் பண்ண முடியாது. அவருக்கு உறுதுணையாக இருக்கிறவங்க ஜெயசீலன், ஸ்ரீ முகுந்தன். இவங்க 3 பேர் தொடர்ந்து அந்த மீட்டிங்கை நடத்திக்கிட்டு வராங்க. இடையில வந்தவங்க சில பேர் நிறைய போயிட்டாங்க. இப்போ நம்ம செய்ய வேண்டியது என்னன்னு கேட்டிங்கன்னா, மதியானம் சாப்பிட்றோம், போயிடுறோம். 1 மணிக்கு 2 மணி 3 மணிக்கு மேலே என்ன நடக்குதுன்றது யாருக்குமே தெரியுதில்லை. இந்த 4 மணிக்கு வந்து மீட்டிங்னு போட்டிருக்காரு. இந்த மீட்டிங்கில் எத்தனை பேர் இருப்பாங்கன்றதும் தெரியல. தயவு செய்து நாங்கள் என்ன சொல்கிறோன்னா, நீங்கள் மதியானம் சாப்பிட்ட பிறகு கடைசி வரை என்ன நடக்குதுன்னு இருந்து பார்த்துட்டு வெளியே போகிறதுக்கு ட்ரை பண்ணுங்க. வெளியூர்லேருந்து வந்தவங்களாக இருந்தாலும் சரி, உள்ளூரில் இருந்தவங்களாக இருந்தாலும் சரி. அதே மாதிரி பார்ட்டிஷன் பண்ணுறதுக்கு நிறைய பேர் வில்லிங் கொடுத்து வாங்க. நானும் வரேன், நானும் பண்ணுறேன் சொல்லிட்டு வாங்க. ஆனால் அவங்க 3 பேரால் வந்துட்டு 20 வருஷம் நடத்துறது பெரிய காரியம். அதனால் நீங்கள்லாம் இந்த உள்ளூரில் இருக்கிறவங்க என்ன பண்ண, வாலண்டரியாக நாங்கள் கூட ஹெல்ப் பண்ணுறோம், நாங்கள் வந்து பண்ணுறோம். இதே வந்து நம்ம செந்தில் என்ன சொல்லிக்கிட்டு இருக்காருன்னா, 3 வருஷம் 4 வருஷமாக நான் போயிடுறேன் தான் சொல்லிக்கிறாரு. அவரை வந்து இல்லை நீங்கள் கண்டினியூ பண்ணுங்கன்னு சொல்லி உட்கார வச்சுக்கிட்டு இருக்கோம். அவர் மட்டும் எவ்வளோ நாள் வேலை செய்வார்? முழுக்க வந்து அவருக்கு வந்து ஹெல்ப் பண்ணுறதுக்கு வந்து இந்துஜி, அவருடைய டாக்டர். அதுதான் கம்ப்யூட்டர் ஒர்க்கு, கரஸ்பாண்டிங் ஒர்க்கு எல்லாத்தையும் அதுதான் எடுத்து போட்டு செய்யுது. அவர் வந்து பேர் எடுத்துக்கிட்டு இருக்காரு. வேலை செய்கிறவங்க யாரோ. அதனால் இங்கே இருக்கிறவங்க அத்தனை பேரில் என்ன பண்ணுறோம், இந்த உள்ளூரில் இருக்கிறவங்களாவது, மேஜர் ஹாஸ்பிட்டலில் இருக்கிறவங்களாவது, இந்த ஸ்டூடெண்ட்டுங்களை வச்சுங்கிறவங்களாவது நீங்கள் வந்து நான் வரேன் சார் உங்கள் கூட, நான் வரேன் உங்கள் கூட சொல்லிட்டு இன்றைக்கி ஒரு 20, 10, 15 பேருக்கு நீங்கள் வந்து பேர் கொடுத்துட்டு போனீங்கன்னா நல்லாயிருக்கும். யாருன்னா செய்வீங்களா? வேறு ஒருத்தர் தான் சொல்லியிருக்காரு, இவ்வளோ பேர் இருக்கிறோம். நம்ம எல்லோரும் சப்போர்ட் பண்ணால் தான் அவங்க 3 பேரால் நடத்த முடியும். அதனால் எல்லோரும் வந்து யோசித்து நிதானமாக கொஞ்சம் பேர் கோஆப்ரேட் பண்ணுங்கள், ஹெல்ப் பண்ணுங்கள், உதவி பண்ணுங்கள் கேட்டுக்கிட்டு இதோட முடிக்கிறேன்.
Thank you, sir, for gracing the audience. Now, I warmly invite Dr. Jagadishwaran, sir, advisor, STDP, to join us on the stage. Please share your valuable insights, sir.
Good morning to everyone. Respected dignitaries on the dais, off the dais, dear colleagues, and bright young minds of tomorrow. We all agree that dialysis is not just a treatment. It's a bridge between life and loss. Every time we start the mission, we're not just filtering the blood, but we are giving someone more time to laugh, to love, and to live. Today,
marks a historic milestone for our profession. I don't know how many of you are aware that we have National Commission for Allied and Healthcare Profession, which has formally recognized dialysis therapy profession, and we are no more mere support staffs in a dialysis unit, but are a highly skilled and a regulated healthcare professional whose expertise is indispensable to saving lives and ensuring the patient well-being. The recognition plays along with several other allied and healthcare professionals, which acknowledge that our work demands deep clinical knowledge, technical proficiency, ethical responsibility, unwavering education, and dedication to the patient care. This year, the National Commission has released competency-based curriculum. I don't know how many of you are aware, when I was being associated with this university, my teacher and mentor, Professor Sindhu sir, is sitting. We used to go and ask him, sir, we are offering a 4-year program. It is called as BSc Allied Health Sciences. Why not we put it as a BAHS? He used to say, see, the curriculum is not uniform. From Kashmir to Kanyakumari, there is a different curriculum taught by different institutions. But now today, the scenario has changed. As he has visioned up and he has advised, now there is one uniform curriculum from Kashmir to Kanyakumari. It's a 4-year competency-based curriculum. And similarly, the word technician is phased out. Now, anybody who's entering the dialysis profession will be called as a dialysis care associate. And several developments are happening. Now, very soon, the commission is planning to register the professionals. So licensing is going to be mandatory. My previous speaker was highlighting the importance of this conference. I also acknowledge the efforts of the organizing committee who are playing a vital role in organizing this conference year-on-year basis. At present, participation in this conference is voluntary. But once the registration starts, it becomes mandatory because everyone need to carry a credit, then only your license will be renewed after 5 years. So I think this is one key step, and I believe that attending the conference will not only enlighten your knowledge and skills, but also keep your license active. And most importantly, I also want to stress up, as we used to ask our mentor, now the nomenclature has been changed. It's not anymore BSc, it is Bachelor's in Dialysis Therapy Technology, and for Master, it is Master's in Dialysis Therapy. So the career of the dialysis professional has really come a long way, and under the NCHP framework, the education, training standards, and there is a clear defined career pathway and opportunities for professional growth has been clearly documented. But at the same time, we need to remember that it's not just mere recognition, it is also empowerment, accountability, and promise to uphold the highest standard of care to every profession we are entrusted with. To the students, I like to highlight that your journey is not just learning how to operate a dialysis machine. It is beyond that. Your learning should protect human life. You should be able to notice even a small change in the patient condition. You should know how to comfort someone who may be in a pain or a fear. Machines can clean blood, but only you can bring comfort to the patient life. And as you all agree that technology will evolve, now we have a lot of recent advancement, including the online hemodiafiltration. We have advances in extracorporeal therapies. We have home hemodialysis, wearable machines, artificial kidneys, AI in dialysis, so on and so forth. But one thing which will never change is the need for skilled, compassionate hands, sharp and alert mind. So let us work with this pride. Let us serve with empathy. Let us carry the responsibility of our role, not with a burden, but also as an honor. In dialysis, our goal should not be just to add years to the life, but add life to those years. Here, the life I mean is the quality of life. So you need to improve the quality of life of the patient whom we serve. So with this note, I take this opportunity to thank the organizers, Sindhu sir, Jayanseelan sir, and all others for giving me this opportunity, and I wish this program to be a grand success. Thank you.
Thank you for your inspiring speech, sir. As a token of appreciation, we now invite Mr. R. Sendil, sir, founder and secretary of SDTP, to present the memento to our chief guest. I would like to invite Dr. Manikandan, sir, to receive the memento. I would like to request Dr. T.V. Ramakrishnan, sir, to receive the memento.
I now request Sendil Kumar sir to receive the momentum and shawl. I request T.V. Ramakrishnan sir to receive the momentum. Thank you for all the chief guests for your presence and contribution. I now request Ms. Hemalata ma'am, Assistant Professor and Faculty in charge of Renal and Dialysis Technology at Srihar, to deliver a condolence speech to honor the memory of Dr. Ram Prasad sir. Ma'am, please.
Good morning to one and all present here. Before we proceed further with today's session, I would like to take a moment to acknowledge a profound loss to our nephrology community. It is with deep sorrow and heartfelt respect that we announce the loss of Dr. Ram Prasad, who was the professor and HOD of the Department of Nephrology at Srihar. When we began preparing for this 18th annual SDTP conference, Dr. Ram Prasad was with us in good health and spirit, encouraging us, guiding us, and playing an instrumental role in shaping this conference into what it is today. Sadly, he left us on July 4, 2025. It is an immeasurable loss to all of us and the Department of Nephrology at Srihar. Dr. Ram Prasad was more than just a brilliant clinician and distinguished academician. Known for his friendly nature and approachable personality, he built lasting bonds with everyone he worked with. His dedication to advancing nephrology and supporting dialysis technology professionals will be remembered. His presence is deeply missed, but his legacy continues to live on in each of us who had the privilege of knowing and learning from him. Let us now take a moment to honor Dr. Ram Prasad's memory with 1 minute of silence. Thank you all. Please take your seat.
Thank you, ma'am. To conclude the inaugural ceremony, may I invite Mr. T. Jayashilan, sir, President of SDTP, to deliver the oath of thanks.
Very good morning and happy Sunday to one and all. On behalf of Society for Dialysis Technologists and Paramedics, I take this opportunity to thank our chief guest, Dr. S. Manigandan, Professor Department of Nephrology, Ramchandra Institute of Higher Education Research. Thank you, sir. And Professor S. Sendil Kumar, Registrar Sri Ramchandra Institute of Higher Education and Research. Thank you for the invitation. Thank you, sir. And Dr. T.V. Ramakrishnan, the Principal, Sri Ramchandra Faculty of Allied Health Science. I would like to thank Mr. Sindhil, Founder and Secretary of the SDTP, for 18 years organizing this conference. It is noteworthy to mention that only with his dedication and effort, we have been able to expand this conference to other states beyond Tamil Nadu, Kerala, Karnataka, Andhra Pradesh, Pondicherry, Punjab, Delhi, Maharashtra, and Chandigarh. They're watching on live. I would like to thank our patrons, Dr. George Abraham, Senior Consultant, Triple M Hospital, and Dr. Edwin Fernando, HOD, Department of Nephrology, Stanley Medical College, and Dr. V. Chandrasekhar, Director, Institute of Renal Science and Kidney Transplant, MGM Healthcare, and Mr. L. Sivamani, sir, for their valuable support and guidance. Uncoti members, Mr. Ruben, Vice President, and Mr. Y. R.A.K. Das, Joint Secretary, and Sri Mukund, the Treasurer, STTP, and Dr. Jagdishwaran, Advisor, STTP, for their valuable support. Thanks, guys. I'd like to extend my heartfelt gratitude to all the speakers who have taken their time much their busy schedule to be here and share their profound knowledge and expertise with the participations. I would like to express our sincere thanks to the management of Sri Ramchandra Institute of Higher Education and Research for providing us with all possible support towards organizing this event. And my thanks to IT Maintenance, Housekeeping, and Ms. Hamalada, Assistant Professor, Faculty in charge of Renal Dialysis Technologies, Sri Ramchandra, and Netaji Lecturer, for the cooperation and the support. And of course, renal dialysis students, thank you. My special thanks to the executive committee members and organizing committee members of SDTP 2025. I would like to extend my sincere appreciation to all who generously help us make this event together to become a grand success. My special thanks to all the companies for generously sponsoring this education program, and thank for your continuous support always. Finally, I would like to thank the organizers and volunteers making this program resounding success. Thank you all once again.
Thank you, sir, for expressing gratitude on behalf of us. We now move on into our technical sessions without any delay. I now call upon Mr. V. Jayaraman, Deputy Manager of Fresenius Medical Care India Private Limited, to give us insight on the topic high volume HDF, optimum convective dose, and how to achieve it. Please welcome him with a big round of applause.
Okay, good morning. Still I see some people talking. Okay, today's topic is on high volume HDF. What is that? The agenda for today will be what is high volume hemodiafiltration, a little bit on the prerequisites, indication for HDF and prescription. Why you should do high volume, for what reasons, why do it and how you do it. A little bit on the technology, without that I think you can't. And last I give you a free online course. Most of you, if you have already registered, probably it might be an update to you. Here we go. Why I should do high volume hemodiafiltration. Suppose you have already been doing HDF. What is this? Something new? Nothing new, it's the same. But in Fresenius Medical Care, up to 2022, there were around 55,000 patients being dialyzed with HDF. Now, with the present one, it's somewhere around 65,000 patients only in our own dialysis centers. So if you see, after the treatment in India, how do you see the patients walking into the dialysis unit, but when they walk out, what do you feel? How are they? They are weak, feeble? The answer is in your. If you see the slide, lot of countries, even in India, there are patients who walk in after working, they come in the odd hours to do the dialysis session. Sorry about the technical glitch. So what about this high volume HDF? I have been keeping on telling for the last couple of minutes. It's the same time, number of hours you will be dialyzing the patient, but via a machine that is dedicated for certain patients. If you see the slide, Y versus the x-axis, it's the weekly clearance that's happening even in your own centers, but the slide talks about the bridge between the high flux versus the hemodiafiltration. That's somewhere here I'm trying to bridge that. What you do in hemodialysis is more with the diffusion. What I'm trying to emphasize here is, just by doing diffusion, you're not going to justify all the substances that is accumulated for the past 2.5 days. In India, probably 3 days, it's getting accumulated in the patient's body. So yeah, I am here to tell you that there are two principles, which is, the word itself tells HDF. HD is diffusion, F is filtration, which is convection. If you see again here, normally if you see your dialysis machine at the lower part, it's somewhere around 55. This is based on the ml per minute that hits the fibers and back to the patient. Whereas I am going to talk about hemodiafiltration, which is high volume, which is more of a convection. It talks about somewhere around 35 to 40 liters I have seen in my experience. What I am trying to justify here is, you are only doing diffusion, but there is no convection. At the end of the day, say after 3 to 4 years, in one of my slides you will see all that is going to accumulate it, and it will hit few minutes before Dr. Jagdish was talking about quality of life, that is you and they are in your hands. And that is here I am to tell you and walk through that. This quality of life depends mainly not only on diffusion, but also convection. I'm proud to tell you that I was with this gentleman in WCN standing next to him. I took the photo for compliance purpose. I have hidden my photo next to him. He is the man, Dr. Peter Blackstein. 2023, he did his studies in his centers all around the Europe and many parts. There were some other companies also participated. What he's trying to narrow down to that magic number, 2023, he said the convective volume should be 23 liters. 2023, 23 liters, decrease in the mortality rate by 23. So when he came to the stall, I was telling, even his eyebrow raised, I was telling 23, that magic number, you did it in 23 and the decrease is 23%. Amazing figures. So what I'm trying to tell here is, the machine will automatically prepare and deliver based on the effective blood flow rate. You don't need to prescribe anything. You will see my prescription in the slide. The study what Dr. Peter Blankstein did was convinced trial study, which was published in New England Journal of Medicine somewhere in 2023. 677 patients on HD high flux versus hemodiafiltration, which is 683 patients. What he concluded was, with hemodialysis it's only diffusion, whereas with hemodiafiltration it was more of a cohort study, and meta-analysis states that 23 liters, it's not 23 liters of the replacement, it was 21 liters plus 2 liters of ultrafiltration. So I was telling in India, I was telling Dr. Peter Blankstein that in India it is sometimes difficult to achieve this 23 liters. So what we do, the magic figure to get is simple. 18 liters you are able to achieve, plus the ultrafiltration is 4 liters. So try to increase the time by 15 minutes, you will hit this magic value, will hit this magic value. So to conclude, I always keep this person in mind and try to achieve the figure maximum. So now the prerequisites, the challenge in India is, we store it into the tank with 2000 liters or 4000 liters capacity. For hemodiafiltration, your ISO 23500, now 2025, the new one has been released. It states that you need to have CFU of 0.1 less than and endotoxin 0.03 per ml. I see a lot of times when I go as an auditor, I've done a lot of audits, they give no growth. I said no, I will never accept. Even my own units in India, we are online, we still have 0.001. And when you have stored into tank, it cannot be no growth. Probably the testing broth or the medium is an error there. Coming to the next one, the machine that is going to be used, you need to have 1.5 bar, not this bar in the evening. So you need to have that pressure which is approximately 21.7557 psi, and that hits the inlet valve of the machine, it starts functioning. If there is small deviation, this machine will say bye-bye, and this will give you first water alarm. Next is many audits I have done where I have seen there is no hardness report and chlorine chloramine. When you are doing online HDF, a report of the current session should be there. Dry bicarbonate is the only one mandatory to be used. You can't use the liquid bicarbonate, and it's always single use. I know we all love to reuse the dialyzers and the blood lines. So you need to have a dedicated RO. Probably if you can't meet those standards, don't worry, we are there. You can put a portable RO system that will ensure the quality of your ISO standards. And you need to have the endotoxin retention capacity filters, which is mandatory. You can't bypass, like most of the institutions, they bypass it, telling that ours is also imported RO system. So to manufacture that substitution fluid or the replacement fluid, we have two tiny filters at the rear end of the machine. We call it as DiaSafe Plus. And these will ensure the manufacture of the sterile fluid, which is equivalent to your saline. And I would say it is sterile and non-pyrogenic. But you can't use your liquid bicarbonate. Why? The pH of the bicarbonate solution is 7.7 to 7.9. Anything can grow in that medium. That's the reason mandatory you need to use a dry bicarbonate which is in sterile form, online preparation and online delivery. Next is the indication. What is the indication? I'm not going to run and read the slide and bore you all. There will be at least 5 indications, then you choose that patient to push for online HDF. Number one, phosphate, which is intracellular, it cannot be removed. Though many of the companies say mine is having the highest phosphate clearance, all that is all, I'm not going to tell the names of the companies here. To remove the phosphate, it can be done only by a process or a principle called convection, not much of a diffusion. Next is beta 2 microglobulins. In the long run, if you see beta 2 microglobulins get deposited, and that is going to cause amyloidosis. So if you have those type of patients in the long run, long-term dialysis, you need to push them for online hemodiafiltration. Calcium times phosphorus leads to metastatic calcification going above 55. And if you want to make it equilibrium, HDF is the answer. Next one, another two more. Leptin is never removed in hemodialysis because the leptin substance is an Unger syndrome, which is 16,000 Daltons. It can be only removed by a process called convection, and in which dialysis you have modality is hemodiafiltration. So the leptin, when it is more in our body, our kidneys throw, thanks to God. But for a dialysis patient, this cannot be removed unless you use the right membrane, right pore size, right modality of treatment. Last but not least, if you want to minimize or see that no intradialytic hypotension, if you want to minimize that, I think push that type of patients to hemodiafiltration. Now you know what are the indications. Let's go into prescription. Though I have almost 9 prescriptions I have given, simple, you no need to do any prescription, just give the hemodialysis prescription, which is ultrafiltration and QB. Extracorporeal blood flow management, you need to have a very good vascular access, otherwise do not choose the patient on hemodiafiltration. Few minutes before I said, a biofeedback from the effective blood flow rate goes to the substitution pump, and that will manufacture the replacement fluid, which we call it as substitution fluid, and that's going to be the convective volume dose. Dialysis choice, I would say, if you want a high volume hemodiafiltration, my second last slide will tell you, you can't use a normal low flux, even a high flux, you can't use it because the diameters are very, very small, probably 185 to somewhere around 200 micron meters. But you will see in my second last slide what is HDF, high volume dialyzers. You need to have a minimum of 1.6 square meters. To hit those fibers, you need to have a very good vascular access which can deliver 350 ml. If you see the convince trial study, if you have time, go into the Google search it. It says average of 349 ml was for every patient, average. Extracorporeal anticoagulation, there's no change. It's the same HD anticoagulation, there's no. But only when you do HDF, apparent free, you do a pre-dilution, not a post-dilution. Pre or post, post is most recommended when you have a heparin dialysis, otherwise you need to do only pre, otherwise it will clot. Dialysis flow adjustment, the machine is so good with a nice software, it has an auto flow. You only have to program the blood flow, automatically the dialysis flow will calculate. You no need to enter, you only enter the auto flow factor, whether 1, 1.2 or 1.5. Usually for HDF is 1.2, so that the blood will get multiplied with the factor, and then the dialysis flow is automatic. Treatment time is the same. Professor Mani always says 5 hours of dialysis every session is mandatory, because the KT over V, what we set is 1.3, whereas our KT over V is 20.16 per week. So nowhere we hit the bullseye where we need to see that we justify the KT over V. Electrolyte prescription, the dialysate is the same. There is no change in the prescription unless you have somewhere ICU setup, you try and go and see that, then you try to modulate or manipulate with the sodium and other parameters. No need to calculate the CRRT dose, which is 25 ml per kg body weight up to 40. The machine will automatically prepare the fluid, which is the replacement, deliver to the patient and remove automatically. The word auto surplus, automatically substitution fluid, which is replacement, is prepared by acid, RO water and the dry bicarbonate. It goes through diasafe plus, that's the reason the word auto sub plus. Last but not least, no need to program anything, just program the blood flow and the UF. Automatically the machine will deliver the substitution volume and it will also remove automatically. But to end the prescription, without a good vascular access, do not ever attempt to try HDF, because this machine is a magical machine. 5 times it will try to adjust the blood flow. If you have a arterial suck because you don't monitor the artery in your HD, the venous keeps dangling up and down. You go and open the saline line to dilate the vessel which has constricted. This machine is also an intelligent machine. It will stop the pump, rotate anti-clockwise, it will push 1 ml, second time 0.8 ml, 1 ml, 0.8 and 1 ml. Last but not least, 6th time if it is going to suck, it will say bye-bye, it pushes to HDF because of the filtration fraction. Now why you want to do, as Ramakrishnan sir also was telling, Mr. Dr. Jagdish also few minutes before said, QOL, quality of life. If you want the patient to live longer, I think you need to go for hemodiafiltration. HD, I think slowly, there is one country called Portugal, all are on HDF. There was not even one patient on HD, not even one patient. Very surprising. Why to do? Few minutes before also I said quality of life, patients should go back to work. In India, very, very few patients have been working and coming to dialysis unit or dialyze and go to work. So this is a Catalonian Eschol study. I'm not going to bore you with the figures. What I'm trying to say is they also did a study with HDF and they come to a conclusion that this many liters goes into the body and comes out, the better is the survival, or in terms of cardiovascular risk or in terms of mortality, they give the figures. You can see the value. 19 liters, 19 to 23, more than 23. What I'm trying to summarize this, the volume that matters. These all you can't decide. The patient blood flow that hits the fibers and back to the patient, and that is going to deliver the ml per minute. An average patient, I have traveled all over India. Whatever I have seen to my best knowledge, an average of 18 to 20 liters have been delivered to the patient and out without ultrafiltration. Somewhere more than the convinced value, which is 23 liters, I have seen North India, even in South India, I have seen a few patients going above 24, 25 liters. So this is convinced study, which I already, I'm not going to again talk about that, but only one thing is 23 liters every session. That was what their target in the study, that you keep back of your mind. So the latest convinced study results reinforces our original conviction. What is that? Every patient should get the chance to benefit from high volume HDF. If you see most of the patients, even in hemodialysis, they get hospitalized at some point of time. But in hemodiafiltration, I have not seen many, because most of the substances come out, not only diffusion, by the principle called convection. Intradialytic hypotension, I have not seen. There were a lot of doctors who have challenged me when I went for demo. I pulled the lowest blood pressure patient here, because we have a software inside, blood temperature monitoring, which will maintain the blood pressure. And I'm not saying that all patients will sustain that and there is no BP drop. If still the BP drops with this machine, then probably it is the dry weight or probably the pills that is being prescribed is interfering. Cost effective, definitely many people think that HDF water consumption is more. No. More than HDF the water consumption is less. One of my slides will talk about that. So it is very cost effective based on the software that is going to adjust and deliver to the patient. So how to do this? We as FME, Fresenius Medical Equipments, we can cover all this. One, if you have a water system not meeting the standards, I am there, and my division is there to solve the problem. To get the substitution value to hit that value, I am there to support you. Where is the error, I can find out and give you. Technology is there in the machine. It is, the ball is in your court to decide. I know the professor or the purchase manager to decide. Suitable dialyzer should be required. A few days before, there was one guy telling me the TMP is very high. Then I asked, can you send a photo? It was a low flux dialyzer being used. So you need to mandatory use only high flux, not low flux. Technical support, we are 24/7. So end-to-end implementation is there. We as Fresenius Medical Care, we not only give you education, we also there to see that your water quality assurance is on dot. And the disposables are all single use only. Any disposable is single use, you can't do it. The technology is inbuilt. We will see what are those technologies. Do it in the right way, okay, and with the right mission. So we do have a mission with two pumps. One is the blood pump, one is the replacement or the substitution pump. We do have venous access monitoring. There is no kinking of the dialyzer when there is an axial flow because the blood flow is lateral. And then we have the blood pressure monitoring every 10 minutes monitored with the timers. We also have the blood temperature monitoring to see that it minimizes the hypotension. It also gives you the access recirculation. It will also give you CPR, cardiopulmonary recirculation. Last but not least, the economical flow. When you see in most of the 4008 or whichever machine you use, it is a fixed flow, 500. I know you don't reduce it while priming. Whereas this machine starts with only 100 until the blood touches the optical detector. This doesn't trigger to go to 500 or whichever auto flow you set to. Online Plus is automatically manufactured, 1 part of acid, 32.775 RO water, 1.225. Your normal liquid is 1 plus 34 is to 1.83. This is different in this machine. It is 1 part of acid, 32.775 RO water, 1.225. All mixed, it becomes 1 plus 34. And that passes through the endotoxin retention capacity filters where you will try to hit that 23500 part 5, which is the substitution fluid, 0.1 less than per ml, which is CFU, and endotoxin is 0.03. So auto flow, you just program 1.2 for HDF, 1.5 HD automatically, because most of the centers I have seen, they use even 800 dialysate flow with 500. There was not much of a difference because after 2.5 hours, the line, it becomes plateau. That means urea is not removed. No point in pushing that 300 extra and wasting the fluid. So economical, I already said it's at 100. But during this time, do not check your bicarbonate because your bicarbonate will be only 25 because it is saving the fluid. No kinking. Blood temperature monitoring minimizes the hypotension. Auto supplies, it will automatically push into the body of the patient based on the effective blood flow rate and removed automatically. Venous access monitor, this is not available in other machines, even in 4000. This detects when there is a venous pressure drop by 50 mm of mercury, whereas the normal HD machines is 30 drop. That means less blood loss when there is an exsanguination. That pressure is normal one. Normally when there is a blood pressure drop, you go and switch off the UF, you reduce the pump, you give a bolus of saline, you check the blood pressure. I always say, Jesus, praise the Lord. He is there sitting inside, you press it, he does all this. All the 4 done, you only go and put the patient in Trendelenburg position. But the machine doesn't allow, it tells you the UF is off, the UF is off after 3 minutes. And once that bolus is given, it immediately prompts you, whoever is standing before the machine, to return the blood flow back to that original blood flow because it has a biofeedback from year to year. So I told you a few minutes before, the water consumption is less. When I give a factor of 1.2 for HDF, the dialysate flow becomes 1.2 of the blood flow. So I save that and I am utilizing it for convective dose. Okay? But still I see a minimum of 100 only is required, whereas 127 is required for your HD. Amazing software in this machine. So to sum up, even in high volume HDF, you may only require a small amount of dose. When compared to HD, the water consumption is less. Probably a minute I will talk on this. Though it automatically pulls the fluid, goes into the body and pulls out, there are 1,000 dynamic signals from the artery header to the venous header. It keeps checking the stress levels inside the inner fiber of the dialyzer every minute. If that is felt, the biofeedback from this will go to the substitution pump to reduce the substitution rate. Amazing software again. Do it right with the right dialyzer. What do I mean? Normally the dialyzer, the diameter is 200 micron meter. The scientist inside, amazing guy, he has increased the diameter to increase and see that the blood goes into the full fibers. And that is the reason it will reduce the stress levels of the membrane. It reduces. And they have also increased the wall thickness because it has to withstand the turgor pressure. It has to withstand the turgor pressure. And once it is done, you need to have the dialyzer which is cardioprotective, whether it is hemodialysis or hemodiafiltration. If you see, because of the diameter increase, you require a very high blood flow. You can't go and use it in your normal machines, normal HD machines. You will miserably fail because it can clot. And you always have, after 2 hours to 2.5 hours, protein binding or protein polarization. And you can see that will always go in the inner fiber wall and it will see that the efficacy is reduced. But here you will never see that. Bigger diameter, lower resistance divided by the pressure, you will see lower hemo concentration. That means it will have the better efficacy, better removal. Even in this company's own dialyzer, the comparison done in vitro studies, but it is in vitro, but it is with bovine, not bovine blood, human blood, where the sieving coefficient is 0.9. We are going to come soon with one sieving coefficient for beta 2 microglobulins. That means 1 means 100%. This is 0.9. 90% is removed. This is one of the best dialyzers I have seen. Even my own previous director of the clinical team, his own mother was on dialysis, is also going still further, continuing her dialysis. She was shifted from Cordax to this one. And we saw the phosphate maintained, the albumin levels going up. Amazing. Phosphate is also till down. So to ensure that you have the best hemodiafiltration, high volume, you need to see that you have UPDF, ultra pure dialysis fluid. How to manufacture it? Nothing big technology or mind is required. You always have your RO system. Maintain that standard. That will come to the machine. 1 part of acid, 32.775 RO water with 1.2 to 5 will ensure that it delivers a good amount of the dialysate. That will pass through the first endotoxin retention capacity filter, will again go through the second endotoxin retention. These filters are 2.2 square meters and it has a pore size of 0.2 microns. What else you require? And once that comes out, the dialysate fluid, it becomes the substitution or the replacement fluid matching ISO 23500, page number 19, 0.03 endotoxin level per ml. And once you push this, the machine will automatically calculate when to change. Every treatment you end, it will be disinfected. Every treatment automatically rejects or tells that maximum you achieve. So you need to change the endotoxin retention filter. Do it with water assurance. Without the water quality, we do that. If I come as an auditor, I will laugh and I'll just put NC. I'll smile, I'll put NC, non-conformity. Okay? That means you need to have these in place before you kickstart your hemodiafiltration. So high volume is nothing, not big one. You need to increase the blood flow of the existing patient. To increase, you need to see that the fistula is good, increase the needle size. We are there 24/7. Now you all have got the value of hemodiafiltration. Prerequisites I have already given you. select a patient with indication, that is the professor level. Once it is given, I am there to kickstart with a demo. What else? The word quality of life will lead the patient. And once the quality of life, the miracle will happen. The patient is going to send a word of mouth of marketing. Many people will come and throng your place. That was my last slide of the thing. We have an online course. I think I am the first to complete all the AREP models. This was recently. It was 2 days before. I scored all 100. Nothing less than 100. You all can also score that. If you want further information, come to my stall. You will get more about this. And this is not from Fresenius. This is from California Board of Registered Nursing. More than the certificate, to me, the knowledge is wisdom. Whichever you want. You want the certificate, you still have to register. It's free of cost. What prevents you to log in and register, right? We are not forcing. We are just telling you, if you are interested, log in. Any questions? No questions? If no questions, then I leave it to, if you still have, I am there till the end of the day. We do have a quiz program. It's a bit tricky. You will see it. If no questions, then I thank you for your patient listening. Hope it was useful, informative. Thank you very much.
Thank you, Jayaraman sir, for the enlightening presentation. May I invite Mr. Y. Arokya Das, sir, Joint Secretary of SDTP, to present the token of appreciation. Ladies and gentlemen, a warm applause, please.
Thank you, sir. Thank you, sir. Thank you.
Thank you, sir. Our next session take us into the future of nephrology with the topic behind dialysis. Speaker, Mr. Vimal Raj sir and Mr. Sailesh Kumar sir, Nepro Medical Private Limited. Let us welcome them with enthusiastic applause.
Hello, good morning everyone. So warm welcome to SDTPCON 2025. So today I'm going to cover the topic of beyond dialysis. From Nipro to dialysis technician, elevating renal care together. So in the sense of, we are going to elevate the renal care technicians. So I'm going to welcome you, dedicated dialysis technicians. Your expertise and commitment play a vital role in delivering safe, efficient, and composite care to every patient who walks into our organization. As a frontline guardians of a dialysis treatment. You ensure that machine operates flawlessly, water system remains pure, and patient receives therapy in the most comfortable and reassuring environment possible. We are doing it on a daily basis. Together, we are not just maintaining the equipment, we are sustaining lives. Let's continue to work with precision, empathy, and teamwork to make a real difference for every day. Welcome, team, where skill meets composition. So, I'm going to explain about Nipro as a company. As founded in 1954, headquarters as in Osaka, Japan. So global presence, we have 55 plus countries, employees around 30,000 till date. And we have in a business called renal care. We are manufacturing as a dialysis machine, blood tubings, and AVF. So vascular, we are using as a IVS and IVRS machines, and catheters, everything we are doing it in a vascular. So as a pharma packaging, glasses, vitals, ampoules, and cartridges, glass tubings, we are manufacturing in our company. So live longer, live better is the company motto to maintain our brand values. So this is the Nipro Global Network. So here you can see we have a sales office at 61 countries. We are having a 306 offices in the worldwide. We are productioning at 17 countries and 71 factories we have in the worldwide. And we have around 39,000 employees. So this is the Nipro India presence. So Nipro India Corporation is a manufacturing company which is presented in the Pune. And Nipro Medical India is a sales and service company which are optimizing in all 18 states. And we have warehouses at all 18 branches actually, states. So we are proudly say that we are a Make in India product. Machine was just importing from Japan, but as a consumables, dialyzer, blood tubing, AVF, catheters, so we are all making it in a Make in India rules. So Nipro is a total solution provider, renal solution provider, in the sense of we have a tap to patient scheme. For example, if you take RO, we have it in Nipro. If dialysis machines, dialyzer, vascular accesses, blood tubings, AVF, acid concentrates, accessories, process-driven softwares. So everything, one dialysis center, what are the things we needed? All the parameters was in Nipro. So that is why we call it as a tap-to-patient company. So I want to gratitude to you. So you are always doing a good job. But we are ensure to make the patient more safety and more convenient to the patient. That we need to do it by making it work. So RO maintenance is the key point of a dialysis. That is the heart of a dialysis. So as a dialysis technician, always you want to check it on a daily basis that water pressure has to be checked inside the RO plant. Every TDS and TCS has to be checked on the RO plant in a pre-treatment and post-treatment tanks. So you have to log sheet has to be maintained. So how much your now TDS is there, how much is the conductivity is there. So every day you have to make a note of it. Okay, so weekly you have to go for a RO membrane flush as a backwash of carbonate, carbon filters, sand filters like that. So monthly maintenance has to be sanitization and sterilization has to be done for every month. And quarterly and semi-automatically you can change for replacement of pre-filters, post-filters, micron filters, 5 micron, 10 micron, whichever you are using the filters, you can replace it for a quarterly time. And annual maintenance will be the membrane replacement or the membrane backwash of the RO plants actually. So this has to be maintained in a proper way. So this is the Nipro dialysis machine in a comprehensive overview. We have 3 models. So one is the Saddle X, it is an online hemodiafiltration model. And another one is the Saddle 55 Plus, which is a hemodialysis machine. We are using for a general use actually. NC18 is a combination of HD and HDF and as well as a sled. So these 3 machines were kept in a stall. So whenever you get a free time, so you just come to our stall and you can visit the machine and we will care to explain more about the machine and its functions to you on a very detailed way. Okay. So I'm coming to the topic which is a Nipro dialysis machine. So what we have gone through is, so Nipro dialysis machines are more patient-friendly, user-friendly and reliability and flexibility. So you can use it for a patient safety. This machine will have more sensors and more accurate values of sensors. As an user-friendly, it is a standard operation like dialysis flows and self-testers and all. It will be more easy to operate. So reliability in the sense of it is a longer lifespan of a machine, which we can use it for more than 40,000 hours or a lifespan of 8 years. So flexibility, this will be the slimmest and sleekest model in the market. So whether if a female technician or a small lightweight technicians also, they can move the machine very easily and they can shift the machine to wherever they want. So this is the standard flexibility we are using. So this is the model Subtle Footwear Plus. Here you can see it is an user-friendly interface. So like I said, it is a larger, clearer touch display. So easy to navigate and simplified operations. So as a saying a patient safety, we have to ensure this air bubble detector is more sensitive and it will sense more air bubble if it is in case. Accurate venous and arterial pressure monitoring is there. Blood leak detector for real-time monitoring is there. Automated self-test and priming to make sure that easiest of this machine operation. So consistent dialysis quality, precise conductivity and temperature control is there. So these are the main features to use it in a dialysis machine where the conductivity and temperature has to be stable. And integrated ultrafiltration accuracy system is there. That means the reverse ultrafiltration should not happen, or higher or lower ultrafiltration should not happen. So to prevent that, we have a more accurate U of ultrafiltration assembly as a sensor-based pumps actually. Okay, so time-saving features like quick rinse and disinfection cycles, automatic arc-centric disinfection option, fast setup and shutdown reduce to technician point of view. So compact design, like I'm saying, compact, lighter space in the machine. So this machine will come around 70 to 80 kgs, so which easily movable and accessible. And we have a profiling of flexible programming for the individual therapies. So according to free flexibility is there. So reliability and durability, you can know the Japanese invention is beyond the limit we are using. So that kind of engineering standards we are maintaining. Minimal breakdowns and lower maintenance cost. So as a C, you can see it is the minimum maintenance cost. As a C, cut filters are there. We have an endotoxin filter, which comes around 200 treatments or 180 hours of treatments. So this will be the longer running hours for endotoxin filters. So cleaning and disinfection program. So this we are going to maintain like that. Why it is important is we are not using giving rinses for the machine for 10 minutes. So we are thinking that the time was saved. But what will happen to the machine or the patient is the machine will get frequent failures or the patient will get more complications in that because of the 10 minutes rinses was skipped. So please make sure that the rinse will not be skipped, and we are maintaining the machine as of it will be not as a bypassed option. So rinse is a mandatory thing that has to be done. So this is a startup test. So startup test also is a mandatory one. It is also not able to bypass. Here you can see all the self-test parameters has to be passed. If even one parameter is not passed, then the dialysis will not be started. So this is also the main thing to make sure the patient is safe and we are doing it for this own good. Okay, so this test will include as a extracorporeal function test, internal hydraulic checks, negative pressure, positive pressure, blood leak test, ultrafiltration functions, sensor parameters. So everything will be checked under in the self-test parameters. Ultrafiltration profile, sodium profile, and bicarbonate profile. So in patterns, each profiles will have a 6 different customizable therapy we have. So in this, you can manually edit according to the patient condition. So we don't have a standard profiling, but you can mention it as if the patient is sustainable, you can increase or decrease the profiling times and lengths. So we can simultaneously use EOF and sodium profiles can be applied together in the same time. Okay, so whether if you want to on EOF as well as you want to add sodium profile also and bicarbonate profiles also, this machine is having a provision for that. So clinical benefits, profiling allows better hemodynamics management of the patient, reducing risk like hydrocollotic hypertension and improving treatment. It has this much, optimize the outcomes of the treatment. So hydraulic of the to be transferred here from that mixed in a real-time patient treatment, and prevents treatment delays and improve operational efficiency. Treatment parameters. Maker password, which is used for benefits, will be prevent 300. So can go up to 300 to 800 ml per minute with an incremental of 50 ml per minute. So the benefits of appropriate flow description.
Thank you, sir. It's time to reach sharp. Panel discussion. Panel discussion. Panelist Dr. K.N. Sriraksha, Dr. D. Arjun, Dr. S. Sudhagar. I warmly welcome all the panelists and moderator to join us onto the stage. Everyone kindly maintain silence and be seated. Please put all your
The mic. Hello. No, the slides hasn't come. Slides hasn't come. Slides வரல. No slides.
அதுதான் பார்த்துட்டு இருக்கோம். சுதாகர், இங்கேருந்து ஆப்ரேட் பண்ணுற மாதிரி சொல்லலாம். நம்ம இங்கேருந்து ஆப்ரேட் பண்ணுற மாதிரி. இல்லை, நம்ம இங்கேருந்து ஆப்ரேட் பண்ணுற மாதிரி சொல்லிடலாம். இங்கே இருந்து ஸ்லைட்ஸ் இங்கே இருக்குது. இல்லை, முன்னாடி வந்துச்சு. எப்படி வந்துச்சு? வரல, அவங்களுக்கு சொல்லுங்க. டிஸ்பிளே வரல. Good morning, one and all. At the outset, I want to thank Dialysis Technologists Association for giving us this opportunity. So today, along with me, we have three of our panelists, Dr. Arjun, Dr. Sri Raksha, and Dr. Sudhakar for this discussion. So straight away, we will go to the இப்போ வந்துச்சு. So today's topic is patient safety in dialysis unit. What is the role of dialysis technologists in this? So the subheadings to be discussed today are introduction and how common is the infection in dialysis population and what do the guidelines and recommendations tell us about these infection control and how do we treat, diagnose central venous catheter infections and fistula infections and what are all the bloodborne infection acquired in the dialysis unit and how do we maintain this water standards in our dialysis unit and what are all the vaccine preventable infections which we encounter and we have to these infections and monitor all these infections to avoid the recurrence. This patient has high risk of infection and they also have a frequent access to the bloodstream. Weekly 2 times or 3 times they have an access to the bloodstream and prolonged exposure of the water also through the vascular access with contaminated water and they are also at risk of contact with us also healthcare. Being a healthcare workers, we are also act as a source of infection to the dialysis population and moreover they are all regularly they receive treatment in close proximity to the other patient. Transparent non-occlusive dressing, if the occlusive dressing is there we may not able to identify the infection and when the patient has staphylococcus aureus, nasal carriage and the old risk factors like age, diabetes mellitus, cardiovascular risk factors and we in a dialysis unit give high doses of iron, even that may be also at a risk of infection. And coming to the catheter related factors, site of infection. The site of insertion. We all know that femoral catheter has highest risk of infection because of the site, increased moisture and prolonged duration. If the femoral catheter is more than 5 days or 7 days and if the jugular catheter is kept more than 2 to 3 weeks, all this predisposes to infection and sometimes there will be a colonization of the catheter via the skin flora and there may be a hub colonization with the infection and the patient may be having some other infection. That infection can seed into the catheter and lack of aseptic precautions, breach in the aseptic precautions and hemodialysis procedure related is when the dialysis happens with a contaminated dialysate, inadequate dialyser reuse, all these factors may collectively contribute to increased risk of infection and individual factors in the dialysis population. So why do we need to know all these things? Why it is very important to control the infection in our dialysis unit is there are 4 reasons. One is these patients are very vulnerable to the risk of infection. They are very prone to risk of infection and they have high mortality and morbidity. In order to reduce these mortality and also to reduce the recurrent hospitalization, financial burden because they may admit for an episode of catheter related bloodstream infection, they may have pneumonia which can be transmitted. So for each and every admission, it impacts a great financial burden over the patient and their family in order to reduce that. And the one more most important is to reduce the transmission of infection to other patients. So these are all very important factors for which we are controlling the infection in end-stage dialysis populations. So the infection is nothing but when the infection occurs, when the pathogen overwhelms a person's immune system, they may cause illness and tissue damage. They are caused by bacteria, viruses, fungi and parasites. So when these infection happens in our dialysis patient, how do they happen? So these 3 things are So when we see, for example, when we see this patient Hagados. So when we see, for example, when we see this patient getting a dialysis through her fistula within dialysis machine in our unit, there may be multiple sources of infection like this patient fistula itself, the skin itself can be a source of, and this bed and linen can be a source of infection, and this bicarbonate tank that is dialysate, bicarbonate container having a dialysate can be a source of infection, and this drip chamber, when there is an air clogging in that, what we do, we will put a syringe and we will try to aspirate. When this syringe gets used with other patient, it may be also a source of infection, and this infused saline line can also be a source of infection. So we have to take utmost precautions, aseptic precautions, and avoid all these infections in many possible ways. So usually this dialysis patient will manifest with an infection and sepsis. They are usually symptomatic. In the dialysis unit, they will be having a fever, chills, rigors, and if the infection is not attended, diagnosed properly early, they may go in for hypotension, shock also. There may be an overall deterioration of the health. So coming to the causes of fever in dialysis unit, whenever a patient in dialysis unit has a fever, as a nephrology team, usually what we will think is vascular access related and dialysis unit related. These are the 2 common infections which we commonly encounter in the dialysis practice. But I emphasize you to consider other sources of infection also apart from these 2 reasons, because our CKD population is also more commonly vulnerable to this urinary tract infection, which commonly happens in polycystic kidney disease, obstructive kidney diseases, stone diseases, and respiratory infection, which we saw previously, like flu, pneumonia, tuberculosis, COVID, and multiple other infections also there, and GI infection. So we have to keep in mind there are other sources of infection also apart from our vascular access related and dialysis unit related infection. So how to prevent all these infections? Standard precautions. The standard precautions should be carried out in every healthcare facility, not alone in the dialysis unit, in all levels of healthcare facility we have to carry out by all level of healthcare workers. And second one is, which is pertaining to the dialysis unit, is dialysis specific recommendations. So what are all the recommendation and practices tell us? There are several national resources and international bodies which explain about these recommendations, guidelines, what are all the practices we have to follow in our dialysis unit, among which most important are WHO guidelines, which tell about hand hygiene, CDC guideline about safe injection practices, and there are other nephrologists transforming dialysis society in association with American Society of Nephrology. I would insist you all to Google online this and can see the what are all the recommendations and practices which are given all in all these expert bodies. So coming to the standard precautions, there are 7 elements of hand hygiene we have to follow in our dialysis unit. First one is the hand hygiene. This is the utmost first important thing which we all should follow. Second is wearing personal protective equipment. Third is respiratory hygiene, how to wear mask, where to wear mask and where to wear N95 masks and all. And cough etiquette, how to cough, how we have to advise the patients also to cough. And the fifth is how to prevent ourselves and the patients also from injection needle injuries and other sharp needle injuries. And how to clean the environment, how to disinfect the environment between the dialysis and during the dialysis time. And finally, how to segregate and how to dispose all these waste through the biomedical waste management. So how do we follow hand hygiene practices? I would like to invite Dr. Sudhakar for this.
No, not yet finished. இன்னும் இருக்கு, அவங்களுக்கு கொஞ்சம் வெயிட் பண்ணுங்க, அவங்க மறுபடியும் வந்து பேசுவாங்க. சி இஸ் அ மாடரேட்டர். ஓகே, ஸோ எல்லாருக்கும் காலை வணக்கம். ஸோ வாட் இஸ் ஹேண்ட் ஹைஜீன்? ஹேண்ட் ஹைஜீன் எவ்வளோ முக்கியம்னு ஃபஸ்ட்டு நம்ம சைல்டுஹுட்லேருந்தே தெரியும். ஒரு மதர் ஒரு சைல்டுக்கு சொல்லி கொடுக்குற ஃபஸ்ட்டு குட் ஹேபிட் ஹேண்ட் ஹைஜீன். கை கழுவணும், கை கழுவணும், கை கழுவணும். பிஃபோர் பிளேயிங், பிஃபோர் ஈட்டிங், ஆஃப்டர் பிளேயிங், கை கழுவிட்டே தான். ஸோ அதே தான் நம்ம கொஞ்சம் ஸ்ட்ரிக்டாக ஃபாலோ பண்ணுறோம். ஸோ இது எவ்வளோ ஃபாலோ பண்ணுறோன்னா நம்மளுக்கு மட்டும் இல்லை, சுற்றி இருக்கிற பேஷண்ட்ஸு, நம்ம பார்க்குற பேஷண்ட்ஸுக்கு, நம்ம பேஷண்ட்ஸோட ரிலேட்டிவ்ஸ் யாருக்குமே எந்த தொந்தரவும் வரக்கூடாது. அந்த ஒரு ரீசனுக்காக தான் மெயினாக நம்ம ரொம்ப ஸ்ட்ரிக்டாக ஃபாலோ பண்ணுறோம். ஸோ இந்த பர்சன் ஜஸ்ட் ஹிஸ்ட்ரி ஆஃப் ஹேண்ட் ஹைஜீன், எப்படி ஹேண்ட் ஹைஜீன் ஸ்டார்ட் ஆச்சு, எப்படி நம்ம மெடிக்கல் ஃபீல்டுக்குள்ள ஹேண்ட் ஹைஜீன் வந்துச்சு. ஸோ பிஃபோர் தட் நம்ம ஆன்சியன் டைம்ஸில் பார்த்தோம்னா எல்லாரும் ரிச்சுவல்ஸ் ப்ரோக்ராம்ஸ்க்கு, வீட்டில் நல்ல விசேஷம், அந்த மாதிரி இதுக்கு மட்டும்தான் ஹேண்ட் ஹைஜீன் யூஸ் பண்ணிட்டு இருந்தாங்க. எப்போ இந்த மெடிக்கல் ஃபீல்டுக்குள்ள இவ்வளோ இதுவாக வந்துச்சு அப்படின்னா, ஸோ இவர் தான் இக்னஸ். ஏன் இதை நான் சொல்கிறேன்னா, ஒரு முக்கியமான கோட் இருக்குது, சொன்னது யாருன்னா நம்ம வைகை புயல் வடிவேல், வரலாறு மிக முக்கியமாக வச்சரை. ஸோ வாட் ஐ சே இஸ் தட் இக்னஸ் அவர் என்ன பண்ணார்னா, ஆக்சுவலி 2 வார்டு இருந்துச்சு அவர்கிட்ட. ஒரு வார்டில் வந்து டாக்டர்ஸும் ஸ்டாஃபும் ஃபாலோ பண்ணிட்டு இருக்காங்க, இன்னொரு வார்டில் வெறும் ஸ்டாஃப் மட்டும் ஃபாலோ பண்ணிட்டு இருந்தாங்க. அந்த 2 வார்டும் அவர் மேனேஜ் பண்ணுறதுல ஒரு வார்டில் மட்டும் ரொம்ப சிக்னிஃபிகண்ட்டாக இன்ஃபெக்ஷன் இருக்குது. அதாவது சைல்டு பெட் ஃபீவர் அப்படிமோ, அதாவது பெர்பியூரல் செப்சிஸ். மதர்ஸ் வந்து ஆஃப்டர் பர்த் மதர்ஸ் இறந்துகிட்டு இருந்தாங்க. ஸோ அவங்க கம்பேர் பண்ணி பார்த்ததில் கண்டுபிடிச்சாரு, இந்த சைடு இருக்க மிட்வைஃபரி அதாவது நர்சஸ் மட்டும் மேனேஜ் பண்ணுற வார்டில் அவ்வளோ டெத் ரேட் கிடையாது. சைல்டு பர்த்துக்கு அப்புறம் மதர்ஸ்லாம் டிஸ்சார்ஜ் ஆகி வீட்டுக்கு போயிட்டு இருந்தாங்க. ஸோ இதை அவர் கண்டுபிடிச்சது என்னன்னா, இட்ஸ் நாட் லைக் டாக்டர்ஸ் ஆர் நாட் ஹேண்ட் வாஷிங் தர் ஹேண்ட்ஸ், இது வந்து வெறும் ஹேண்ட் வாஷ் மட்டும் கிடையாது. ஸோ சம்திங் இஸ் டிஃப்ரெண்ட். அப்போ தான் அவர் கண்டுபிடிச்சாரு, இட்ஸ் அ குளோரினேட்டட் வாட்டர் தட் நர்சரிங் சர்வீஸ்லாம் அவங்க யூஸ் பண்ணுறது குளோரினேட்டட் லைம் வாட்டர். தட் இஸ் அ டிஃப்ரெண்ட், நாட் ஒன்லி சோப் வாட்டர், தட் இஸ் அ குளோரினேட்டட் லைம் வாட்டர். அதனால தான் இப்போவும் அந்த ஹேண்ட் ஹைஜீன் அவ்வளோ ஸ்ட்ரிக்டாக ஃபாலோ பண்ணுறோம். ஹீஸ் அ ஃபாதர் ஆஃப் hand hygiene or hand washing technique. So and I'm sorry, my ancient times start another. Second, again 19th century groundbreaking discovery of this Ignis, that hand hygiene with chlorinated water. And second one is Lupe Hernandez. He is the founder of that sterilium that what we are using. It's a hand sterilizer. And again COVID-19 launch full and full number hand sanitizer is a part of our regular regular packet thing. So as per the WHO படி பார்த்தோம்னா இதுதான் ஒரு not only for dialysis unit, எங்க ஒரு வார்டுக்கு போனாலும் எந்த ஒரு பேஷண்ட்டை பார்த்தாலும் ஈவன் அந்த பேஷண்ட் வீட்லேயே இருந்தாலும் அந்த பேஷண்ட் வார்டில் இருந்தாலும் சரி ஐசியூவில் இருந்தாலும் சரி இந்த ப்ரோட்டோகால் தான் நம்ம ஃபாலோ பண்ணணும். ஸோ இது மோஸ்ட்லி எல்லாருக்கும் தெரியும். பட் அதே சேம் டைம் நம்ம ஹேண்ட் ஹைஜீன் ஃபார் டயாலிசிஸில் என்ன பண்ணலாம்னா prior to touching patient and prior to any procedure like fistula cannulation or whatever it is, prior to any aseptic procedure, and again once during the after the procedure, after touching the patient, again you hand wash பண்றோம். அடுத்து after the fluid exposure, any kind of fluid exposure, and after touching the patient surroundings also we would like to wash our hand. So what are the steps? So usually we know how to hand wash. It's not like நம்மள குழந்தைங்க கிடையாது, எல்லாருமே hand wash பண்ண தெரியும். But there are certain steps so that we will not miss any part in our hand, so that all of our hand till the wrist is covered by our hand washing technique. So first one is palm rub பண்றது, second one palm உள்ளங்கை rub பண்றோம், second one back of the hand rub பண்றோம், third one again interfacing the fingers in between the fingers or website ஏதாவது website இருக்கிறத க்ளீன் பண்றதுக்கு. அடுத்தது back of the fingers, next thumb, specifically thumbக்கு ஒரு நம்ம ஒரு specifically 1 or 2 seconds spend பண்ணனும். அடுத்து rub the fingertips on the palm of both hands, fingertips க்கு, then followed by both wrist in the both hand. This is a routine of 7 steps of hand hygiene by the WHO guidelines. And hand gloves, of course hand gloves நம்ம எல்லாரும் போட்டுற dialysis இல்ல, just இது சொல்றது மட்டும் தான் சொல்றேன். So when contact with the blood or எதுக்கு நாம wear பண்றோம், any contact with the blood or potentially infectious materials touch பண்றப்ப when should not leave same gloves for more than one patient கண்டிப்பா யூஸ் பண்ணக்கூடாது, just like our syringes or needles. If the care is shifted from the contaminated to the clean side, and when to remove at the time of removal after contact with the patient or surrounding environment, make sure the patient procedure is completely over, then we can remove. So how to do the hand hygiene with the chlorinated water, that whatever we are using in our dialysis unit, if the hands are not visibly soiled, use alcohol-based hand rub. If the hands are visibly soiled with blood or any other body fluids or the dialysis system, wash with soap and water. Hands should stay wet at least for 20 seconds. Hand wash பண்ணிட்டு உடனே துடைக்கவும் கூடாது. Just we have to wait for at least 20 seconds. So wear glove always. And the PPE procedure most of the time நம்ம கோவிட் வரதுக்கு முன்னாடி அவ்வளோ பாப்புலரா இல்ல. Once the கோவிட் வந்ததுக்கு அப்புறம் தான் இந்த PPE kit ரொம்ப ப்ராப்ளம் ஆச்சு. பட் நம்ம யூசுவலா நம்ம PPE kit எப்ப யூஸ் பண்ணணும் அப்படினா ஈவன் HPV patients, HCV patients, HIV patientsமே இது ரெக்கமெண்டட் தான். And the patient with a respiratory infection or TB patient நம்ம பார்க்க போறோம், ஒரு isolation ward ஒரு patient பார்க்க போறோம், it's use இந்த மெயினா நம்ம அதுக்காக தான் PPE யூஸ் பண்ணிட்டு இருந்தோம். பட் கோவிட்-19 வந்ததுக்கு அப்புறம் இன்னமும் ரெகுலரா ரொம்ப அக்ரெசிவா நம்ம யூஸ் பண்ண ஆரம்பிச்சப்ப it's very good only. So AJKD guidelines பத்தி பார்த்தோம்னா, so there are 3 precautions we used to have. One is contact precaution, one is droplet precaution, another one is airborne precaution. All these precautions can be easily followed by separating the patient at least 3 feet. If you see in all these things will have more than 3 in a single patient room or more than 3 feet spatial separation. At least 3 feet distance most of the time in the all precautions we follow பண்ணிரலாம். Second, using the PPE appropriately. And this is airborne precautions. Whenever you are suspecting airborne any infections, like during the influenza time, during the COVID time, during the when the patient is having a TB or tuberculosis exposed, these kind of patients isolated in the airborne isolation room, separate room for those patients. This is order that we have to follow the same precautions before doing all the procedures. So these are the isolation protocol for the infective patients alone. Just to add on to my hand hygiene slide, this is the designated area should be there, and the patient should be negative pressure ventilation of rooms with negative pressure ventilation, which is airborne infiltration room, which has minus 2.5 pascals pressure and difference for avoiding the droplet infection. This need for isolation, again I am just emphasizing those things I have said. This is any bacterial pneumonia or viral pneumonia like influenza during the influenza season time, and the sputum positive tuberculosis, herpes zoster infection, varicella, measles, these are all to be very isolated in that infective room. Okay, thank you so much, and thanks for the opportunity. SDTPCON, thank you so much. Please wait, don't clap, no, we will finish our presentation. 3 more members are there, we will finish it up, wait.
So coming to safe injection practices, the next element of hygiene is safe injection. So So this is a CDC recommendation with the theme we should explain these also to the patients, and we should also follow the same thing. Last one is how to segregate the hospital waste. This is as provided by the HICC guidelines in CMC Vellore. We have kept in each and every area of waste segregation place. This material has been kept. So we dispose all the, what all we have to dispose, all anatomical waste, apron, IV cannulas, everything has to be disposed in the red bag. Obviously sharp container in the sharp container system. So this is the, these things we have to keep in mind. We have to follow each and every step. Related infection in the dialysis unit. So coming to the dialysis access related infection, it could be fistula or central vein catheter. When coming to the central vein catheter, the risk of infection is higher for the venous catheters, and higher mortality occurs. Around 12 to 25% of the mortality occurs. If it is not properly treated, it may lead to metastatic complication. Infection can spread from the bloodstream to the other organs also. It can lead to myocarditis can happen, it can spread to there. And we have to, second is a listen. Listen is we have to listen to the patient's words, that patient is having any fever, or whether compared to the previous dialysis patient is feeling any difference today. These are all the things which you have to listen to the patient. You have to talk to the patient. The final thing is feeling. When you are opening the dressing and you are doing cleaning process and all, when the patient is feeling pain, we have to encounter that, why the pain is there, if there is any pus on pressing on the exit site, or if there is any warmth, we have to be very careful, and these things to be informed to the concerned doctor or the nephrologist. So this exit, what is the difference between exit site and tunnel infection? Exit site infection is erythema or induration that occurs within 2 cm of the exit site. It need not be, patient may need not, redness alone is suffice. So this is a CDC guideline, exit site infection definition. Tunneled infection is if the tenderness erythema happens more than 2 cm from the catheter site along the subcutaneous tract without concomitant bloodstream infection. This is known as tunnel infection. So as a dialysis technologist, we have to be familiar in diagnosing the infection, and we have to be also prepared for the treatment. How to diagnose this? Only by paired cultures from the catheter. One is from the catheter, one is from the peripheral vein. And we have to also start empirical antibiotics after the culture is drawn. That empirical antibiotics, what we generally follow is injection piperacillin, tazobactam and vancomycin, which will cover gram-positive, gram-negative infection. Initially, we have to start with. After the culture sensitivity pattern, definitely treatment has to be followed at least for 2 to 3 weeks, depending upon the organism. And when the patient is having recurrent infection, if it is not settling, we can consider also role of antibiotic logs like heparin we can give, and 4% sodium citrate can be considered. And when these infections happen frequently in our dialysis unit, we have to go monitor and revisit the hand washing technique, how is it happening by other junior therapists, and how the sterilizing techniques and all is happening, that we have to go and revisit and monitor. So how to prevent all this infection? Always prevention is better than cure. So earlier we have to refer patients to nephrologists for further diagnosis and the treatment, and we have to reduce the number of central venous catheter by constructing vascular access, definitive access like AV fistula, by through the vascular coordinators and multidisciplinary teams. And we have to advise for the thing, and if the patient is having very poor vascular access, we should not allow the patient to keep the catheter like more than 6 months, a year also patient will be keeping, so that we have to avoid. And we have to advise them for other modes of dialysis like peritoneal dialysis. So coming to the preventive strategies, how to prevent these? First one is we have to prevent the microbial spread among the patients through the central vein catheter, because many infection can happen through the central vein catheter like MRSA infections, other bloodborne infection can be spread, and we have to avoid hepatitis B, C, HIV infections also to spread from patient to patient, staff to patient, and vice versa also we have to avoid. And the third is we have to maintain the water quality standards within the microbiological standard as per Army guidelines. So coming to the microbial spread among patients with a CVC as an axis, I would like to call Dr. Arjun to present this.
Hello, good afternoon. And what's the name? Video play on TV. ನೀವು ವಿಡಿಯೋ ಪ್ಲೇ ಮಾಟಿಂಗಿದೆ ವಿಡಿಯೋ ಪ್ಲೇ ಮಾಟಿಂಗಿದೆ ಹೆಂಗೆ
ಪಾಯಿಂಟರ್ ಆಪ್ಷನ್ಸ್ ಪೋ ಸ್ವಿಚ್ ಆಫ್ ಇಡ
So I'm here to tell you about how to connect a temporary or a tunnel catheter. Okay, I'll play in video. So before remove the dressing of the catheter, and catheter side should be examined, and then you should perform hand hygiene. Put a new pair of gloves, wear a mask, and then apply antiseptic solution of chlorhexidine with syrup, more than 0.5 alcohol, around the catheter site in a circular motion from inside to outside. Then you should wait for around 1 minute for it to dry, and you should keep the sterile towels around the area, and then you should ensure that all the parts of the catheter are cleaned. Then after ensuring that all the parts of the catheter are cleaned and it's dry, then you should clean the hub and and remove the cap, and you should clean the hub also in circular motion, through type motion, and then you will check the flow by a sterile tunnel syringe, venous followed by arterial, and after ensuring the flow, you can connect the lines. And after ensuring proper connection, you can you should remove the gloves and do the hand hygiene again. Here we are connecting the catheter. Continue the line, dialysis line. Arterial followed by venous. And after that, you are supposed to remove your gloves and do the hand hygiene again. Regarding catheter disconnection, we will do the steps in reverse. We should perform hand hygiene before and after the disconnection, and the things to be taken care of that you should remove the dressing after each session of dialysis. Then perform hand hygiene, wear gloves, ensure that you are wearing a mask. You clean the area, then you apply mupirocin ointment at the sick site, and wear and transplant non-occlusive dressing. Then apply the tegaderm. Ensure the hubs are cleaned in screwing motion. Attach the tip. And then dressing is done. It should be dry, non-occlusive. So we should examine the things to ensure that we should examine that the catheter site is examined properly before we cannulate, and we are supposed to change dressing after every hemodialysis, and we should apply the dissolution with a dry gauze, and after disconnection you are supposed to remove the dressing, change the dressing, and before at this site you are supposed to put mupirocin ointment, and you should clean the hub with screwing motion, and you are not supposed to expose the lumen tip to air for a prolonged period of time. And to prevent the catheter-related infection, you should reduce the bacterial virulence by avoiding biofilm formation and use antibiotic judiciously to avoid antibiotic resistance. Regarding dialysis, you should convert as much as patient you are having into a dialysis, you undergoing dialysis through fistula, rather than them undergoing dialysis through tunnel catheter for prolonged period of time or temporary catheter. You are supposed to use excisite mupirocin ointment at the exit site after every section of dialysis, and it is preferably advised to avoid reuse of dialyzer, to use single dialyzer and discard it, and you should ensure the water quality of the dialysate. Regarding the patient, he should be administered ensure that hepatitis B vaccine, influenza vaccine are administered at the correct time. Ensure that he is receiving adequate nutrition, and his hemoglobin is checked and he is not anemic. So, regarding from the patient perspective, he is supposed to, you should teach the patient also to how to examine. So yes, he is supposed to, on non-dialysis days, he is supposed to look at his catheter site in the mirror. He should ensure that it's clean, dry. If it is, if the dressing is not covering the catheter properly, whether if it is wet, dry, or he is able to see blood or pus on the dressing, he is supposed to contact the dialysis care team. He is supposed to feel also, without removing the dressing, of course. So he should ensure that it's dry and he doesn't have any pain while feeling the catheter. If he seems that the catheter dressing is wet, or he has pain, or something feels different, or he is developing fever, he is supposed to contact the dialysis team at the earliest. Regarding cannulation of fistula. So before cannulation, the patient is supposed to wash his hand with soap and water over the fistula, and then he will come to bed. Ensure that his hand is dry, and then before you cannulate, you are supposed to locate and palpate the AV fistula, where you are going to cannulate, whether the dialysis site is okay, fistula is okay, fistula is okay, and then you perform hand hygiene. You perform hand hygiene, wear mask, wear a new pair of gloves, clean the area, and use sterile towels in circular motion from inside to outside. You're supposed to clean the area, allow it to dry, then cannulate using aseptic technique. After cannulation, you're supposed to remove the gloves and perform hand hygiene again. Regarding decannulation, it is the same. You perform hand hygiene, wear a mask, new pair of gloves, and remove the needles one by one using aseptic technique. And you should ensure that you are using a clean gauze to compress the site while doing decannulation of the fistula. So patient education is important. Then you should be using a screen glancer. If you are using 70% alcohol rub, you are supposed to keep it contact time of 1 minute. If you are using 10% powder time, contact time is around 2 to 3 minutes. And you should ensure that you are cleaning in a circular rubbing motion from inside to outside. Always ensure standard universal precaution while cannulating, whether it is fistula or temporary catheter or tunnel catheter. We'll move to vaccine preventable infections.
The next is vaccine preventable infections like hepatitis B, HIV, and other infections, bloodborne infections also we will see. And what are all the challenges and lapses we encounter in the bloodborne infection in the dialysis unit, how do happen frequently? When we prepare injections in the contaminated environment, as I said you earlier, and whenever we use injection vials, when we use mobile cart to the transport supplies and medication to a patient area, and whenever there is an inadequate cleaning and disinfection of the surfaces, whenever we fail to perform hand hygiene properly, and whenever there is hurries in changeover process between the shifts, and whenever we encounter low staff to the patient ratio, these are the factors where we have more bloodborne infections like hepatitis B, C, HIV, and other MRSA-related infections, and how to prevent all these infections. I'll call Dr. Sriraksha to speak about this prevention of the transmission.
Good afternoon, everyone. Dialysis unit is actually a very, we are exposed to a lot of blood products and blood tubing, so it's very important to prevent bloodborne pathogen infection transmission. So specific infection control measures that we have to carry out in the dialysis unit is safe handling of dialyzers, the needles, the tubings of dialyzers. We have to separate the clean environments from contaminated areas in the dialysis unit, and we have to also clean and disinfect the dialysis station, the dialysis machine, the surfaces in between patients, between the shifts of dialysis as well. So the routine disinfection protocol that we follow is we have to discard all the single-use supplies such as the blood tubings and the supplies that we use, the sterile supplies. Disinfect reusable supplies like cuffs, tourniquets, and clamps that needs to be reused on the dialyzer. The dialyzer surfaces should be cleaned with dicyn solution or 1% sodium hypochlorite solution. After cleaning, the surfaces should be visibly wet. We have to allow sufficient contact time of this cleaning solution, and we should allow it to air dry. We should not start disinfection until the patient has left the station. So Indian data shows that the prevalence of hepatitis B in the dialysis unit is anywhere between 2 to 42%, and hepatitis C is between 4% to 45% prevalence in the dialysis units. So in these kind of patients who are seropositive, we should always emphasize a fistula first policy. If we find that these patients are viropositive, we should always encourage them to create preemptive fistulas. And patients also should be counseled about CAPD, in which the exchanges can be done by themselves, so infectivity actually comes down, and we should always encourage them to go for CAPD as well. And we should ensure that all patients who are undergoing dialysis in the dialysis unit should be tested for hepatitis B, HIV, and HCV, preferably by the ELISA method, except in dire emergency situations like hyperkalemia, acute pulmonary edema, where you have to start dialysis immediately, but we can wait for the reports to come before that. Mandatory hepatitis B vaccination and periodic boosters should be given for all patients. We should aim at 100% vaccination in the dialysis unit, and also periodic monitoring of anti-HBs titers. That should be done every 6 monthly or every year based on institute protocols. And patients who do not have adequate titers should be revaccinated with boosters. We should also ensure that all the healthcare workers who are working in the dialysis unit should be vaccinated for hepatitis B, and they should also be tested for anti-HBs titers, and then periodically they should receive boosters as well. We should also have separate dedicated area for dialysis of patients who are virus positive. We should not rotate staffs, like the staff should not move from virus positive area to a negative area to perform dialysis. So we should have dedicated staff who do dialysis for patients who are seropositive, and they should follow all standard universal precautions, and we should ensure that they are also vaccinated. We should encourage single-use dialyzer, limit reuse of dialyzers, and we should have separate dedicated machines for hepatitis B positive patients, because the hepatitis B virons can actually cross the dialyzer membranes. So especially for hepatitis B, we need to have separate dedicated dialysis machines, and we should always monitor. Even though patients who are seronegative can actually seroconvert into positivity, so we'll have to periodically monitor for hepatitis B, hepatitis C, or HIV status in all these patients. Every year, every 6 months to a year, we'll have to monitor. We should also ensure that all the healthcare staff, that I'm emphasizing again, that we have to ensure that all healthcare staff who are working and handling blood products should be vaccinated against hepatitis B. Surface disinfection is very important in preventing the infections. Microorganisms actually can live for varied periods of time in the environment. It's been documented that MRSA can live for up to 38 weeks in dried blood, as HPV, HCV can also survive for up to 1 week or 3 weeks respectively in dried blood. So it should be internally as well as externally cleaned and dried after each dialysis. it should be, you should take care to clean the control panels, and we have something called transducer protectors which can be used to prevent blood spills and blood contaminations. So the surface cleaning should happen with alcohol-based solutions. Hot or cold rinse should be performed to disinfect the dialysis lines, the dialysis machine between each treatment. The dialysis machine should be disinfected using 1% bleach or citro-sterile. And if we have blood spillage, every hospital has a protocol of using 1% sodium hypochlorite solution, which has to come in contact with the blood spill for up to 15 minutes before cleaning of the spill. MRSA surfaces as well as cords to prevent MRSA infection should be cleaned with 7% Lysol, or linen that is supposed to be infected should be soaked with 1% Daikin for 30 minutes before sending to the laundry. The blood from infected patient should be transported to the lab via biohazard plastic cover. Already it is emphasized that we should not recap the needles. We should be very careful while handling needles in patients who are viropositive. A small talk on dialyzer reuse in India. So basically reuse happens because of economic considerations. A lot of patients are not affordable, so studies show that reuse of dialyzers actually reduce the cost anywhere between 20 to 50% per dialysis session. But reusing dialyzers also comes with a risk of infection and potential health hazards. Some centers are also using 4 to 6 sessions by using the same dialyzer before being discarded. So dialyzer reuse, we have different techniques of dialyzer reuse. One is the advanced and manual reprocessing. Advanced is automated systems which actually enhance safety and efficiency. So if you are going to reuse the dialyzer, it's always preferably to use the advanced automated systems which use the Renalin based cleaning agents which are effective biocidal, which kills HPV, HCV, staph, mycobacteria as well. And it can be used for up to 30 days storage with certain sterilants. And automated reuse processing techniques actually give us a printed, this thing ensures quality as well of the reuse dialyzers. Waste segregation should be performed as per the color coding for each institute, and at the end of the day, the dialysis unit should be cleaned with 7% Lysol. All the non-disposable items should be transferred in a red bag for sterilization to CSSD. Gloves, apron should be discarded in red plastic bags, and all the soiled gauze pieces, and if we have cotton items, that should be discarded in yellow bags. Even though the dialysis unit is a very high risk area for infection, it doesn't mean that the patient can get infected only inside the dialysis unit. There are also other areas where the patient can get infected. One could be even the weighing scale, where there can be some touch contamination, contact infection that can happen in the waiting room, where transmission can happen between patient relatives and in between patients as well. Surface infections from computers, wall boxes and containers. So it is very important for us to clean these areas as well. And mandatory vaccinations for patients include hepatitis B vaccination, which include 4 doses of double dose that we give, and we have pneumococcal and influenza vaccination which has to be done annually. And mandatory vaccination for healthcare workers include annual influenza and hepatitis B vaccination. Again, re-emphasizing and ending my talk saying that all healthcare workers should be vaccinated against hepatitis B. Thank you.
So the final thing is the mode of infection which happens in the dialysis unit, right from the tap water to the RO plant to the tanks, filters, and bicarbonate dialysate cans and dialysis machines. And what can be the sources of infection in the dialysis unit? Or first one is the feed water, RO treatment plant, and there can be a stagnation in the tank water. Water distribution piping system can also be a source, and bicarbonate dialysate whenever we are preparing and storage, and dialyzer reuse when it is not done properly, it can also be a source of infection. Finally, the machine. So coming to the preventive strategy and how to maintain the water quality within the microbiological standards as per Army guidelines. As per Army guidelines, we have to see 2 things. One is colony forming units of bacteria, that is done by microbiological cultures. Second is endotoxin units, that is colony form, that is endotoxin units per ml. For a pure standard water, we have to maintain less than 100 colony forming units per ml, and endotoxin is less than 0.25 endotoxin units per ml. When we have to take an action is when the colony forming unit is more than 50 and endotoxin unit more than 0.125. These are all the targets which is set by the Army guidelines to treat appropriately and to act appropriately. And this is an example of our water standard report. We follow fluorescent endpoint assay to see the endotoxin units, and this assay is very sensitive. This can detect even 0.005 endotoxin. It can detect up to 5 endotoxin units. It is approved by the FDA in alternative to LAL assay, that is limulus amoebocyte assay. We use this assay for our water standards. For example, we have multiple areas where the water sample is being sent, and we see the endotoxin levels at each point of time, and we will also check whether these levels are under the Army standards and whether they are below the action limit. And how we follow our disinfection protocol here is we have 24 hours water circulation system. We have to be very careful in maintaining this loop system, that it should be a continuous unidirectional water. There should not be any non-return valves, and we also should be we are also having double pass RO system, one at the terrace and one at the unit level itself, and we maintain TDS, that is total dissolved solids, less than 10 parts per minute. And we regularly do chemical and heat disinfections. Chemical disinfection is done once in a monthly using hypochlorite 1% solution. We do heat disinfection every weekly, all the stainless steel pipelines with the water of 80 degrees Celsius for about 30 minutes each week. And we maintain the standard quality of water by seeing these 3 parameters, that is TDS, endotoxin levels and microbiological cultures. If any of these water contamination is suspected, we have to inform the lab about this, and we all also should suspect other slow growing organisms apart from the normal organism which we expect, and we should also await the result for about 7 to 10 days to diagnose other rare organisms like Burkholderia and Stenotrophomonas. And bicarbonate tank also should be kept in mind. There should be a daily cleaning of bicarb tank. We have to drain out all the bicarb remaining solution the next day, and we have to treat it with rinsed water and hot water after finishing each shift. So there are some clues to detect the source of infection in the dialysis unit. When the patient develops a fever in the dialysis unit, they do not have fever at home. And when more than one person in a single shift develops fever, we have to keep in mind that it is not patient related, it is dialysis related. And when a shift patient, in a particular shift patient develops fever, we should think about the bicarbonate preparation. And when patient comes to HT after a week or so, we have to think about dialysis reuse could be a problem. And when the center is doing infrequent dialysis in ICU, water can be a source of contamination. So we have to keep in mind some clues to detect the source of infection. So finally, how to survey and how to check the quality monitoring of the patient as a team only. As a dialysis team, together everyone always matters. We have to engage everyone in the dialysis facility team, that is nephrologist, senior therapist, charge nurse, vascular access coordinators. Everyone should act as a team. We need this dedicated team and resources at each dialysis unit. We should have our own formulated written policies for the prevention of infection-related complications. What do these dialysis teams should show? Which they should do, facilitate identification of infected-related complication as soon as possible. We have to monitor the CRBSA rates and how much hospitalizations of these infections are happening, how much death is happening, mortality rate, everyone has to be kept in mind. And we have to give actively periodical meetings and quality assessment performance meetings to assess these dialysis proceedings, and we have to also access and surveillance and monitoring by a trained vascular access personnel. This is just a busy slide which is showing whatever I have told now. We have to survey both the surveillance protocols and also hand hygiene observation should be done periodically for all the dialysis therapists and dialysis nurses, and catheter vascular access observations also, how they are doing dressing, how the catheter being cannulated, everything has to be followed, observed periodically. We have to educate the staffs at a periodical intervals, and patient, most important is patient education and management. That is very important in maintaining the personal hygiene and preventing the infections. And as far as possible, as a dialysis team, we have to be keep in mind to avoid catheter, and we have to do a catheter reduction in order to avoid the infections by allowing them to do as early as possible permanent access placement, and even preemptive fistulas we have to advise them, and catheter removal should be done as soon as possible. And chlorhexidine for skin antisepsis has to be kept in mind, like alcohol based chlorhexidine, povidone iodine, and alcohol should be at least 70% should be there. And catheter hub disinfection should be kept in mind. That is, as Dr. Arjun already said, we have to scrub the hub protocol is very important. That is, we have to do a screwing movement with the cleaning of the hubs, both before connection and after connection, and the application of antimicrobial ointment also plays in preventing these infections. So this is a slide which collectively says about all this hand hygiene, PPE, cleaning, disinfection, how to dispose supplies, what are all the safe practices, what immunization we have to take, how to maintain water treatment, how to survey, how to educate the patient. So we have to keep in mind in infection control in a dialysis unit. So final tip is that we should not forget that infection in the dialysis units are very serious, and still it is preventable. We have to take a holistic care, like a patient-centered care, like access, nutrition, vaccination has to be kept in mind. Staff-centered practices like safe hygiene, handling, hand hygiene we should not forget, and vaccination ourselves and safe practices has to be kept in mind. We have to stick to hospital infection control measures, and we have to have a unit-wise standardized protocols and water standards as per standard guidelines. Finally, I want to say team matters. Infection prevention is every one of us responsibility. So I want you to take utmost care to prevent the infection spread in the dialysis unit and to avoid the transmission of infection from patient to patient and from staff to patient and vice versa. Thank you. Thank you for your patient listening.
That was a very powerful exchange of insight. Let's give a big round of applause to our moderator and the panelists. May I invite Mr. T. Jayashilan Sir, President of SDTP, to present the memento.
Kindly, all the students, please stay in the auditorium. Don't leave. Security over there, please ask the students to stay in the auditorium. Escort, please stay in the auditorium. Don't allow the students outside. So as we continue our conference, we would like to acknowledge our sponsor. A small video of advertisement will be played. Please take a look behind me.
Clinical decision support. Real-time access to patient data. Lab results, vitals, dialysis sessions. Alerts for critical values, misdialysis or complications. Trend analysis for key parameters like urea, creatinine, eGFR, dry weight, PP.
Managing blood pressure during hemodialysis is a delicate balance. This panel will be shared the practical strategies and the clinical insight. Please welcome our moderator and the panelists. Moderator, Dr. N. Nityashree. Panelist, Dr. G. Vijayashree, Dr. Sudarshan Karthikeyan, Dr. Vivek K. Kaushik.
A very good afternoon. Check. Yeah, a very good afternoon to one and all present here. And at the outset, I'd like to thank the organizers for having invited us. I know it's pre-lunch, ellaru romba keen irukkinga to go for it. So we'll keep this session very short and sweet because it's a very practical thing. Neenga ellarum paakra oru vishayam da day in and day out. It's about blood pressure monitoring and management in dialysis. So with me I have three efficient speakers, Dr. Vijayashree, Dr. Sudarshan and Dr. Vivek Kaushik. So naanga vandu blood pressure monitoring, management of hypotension and management of hypertension patti pesa porom. All of you know that optimal blood check. Power off. Check, check. 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 Can you check if that mic is working? If that is working? Check. Check, check. Check, check. Can we continue? Am I audible? Shall we proceed? Is it audible? Yeah? Yeah, without delay, we'll proceed with the first talk. This is about monitoring blood pressure in hemodialysis patients by Dr. Sudarshan. Optimal blood pressure is often the most important thing that we need for adequate and good dialysis. And monitoring blood pressure during dialysis is something every technician should know about. Sudarshan will throw some insight into how do we do that.
Hello.
சரி.
Good afternoon. எல்லாருக்கும் வணக்கம். I would like to thank the organizers for giving me this opportunity. So, dialysis technologists கிட்ட இருந்து actually நான் நிறையா கற்றுருக்கேன். எல்லாருமே என்னோட seniors தான். So, வந்து whatever I am telling, most of you might know. I'll just try to add on whatever is new to you. I'll also like to thank Dr. Nityashi for giving me this opportunity. So, இந்த டாபிக் பார்த்தீங்கன்னா ஆக்சுவலி ரொம்ப ஒரு ப்ராக்டிக்கலான டாபிக். ஹைப்போடென்ஷன் அண்ட் ஹைப்பர் டென்ஷன் நம்ம எப்படி அவாய்ட் பண்ணணும் டியூரிங் டயாலிசிஸ். ஸோ என்னோட டாபிக் வந்து பிபி மானிட்டரிங் பர்சே, ஏதாவது ப்ரோட்டோகால் இருக்கா, ஏதாவது ரேஷ்னல் இருக்கா, என்ன பண்ணணும் அப்படிங்கிறது தான். ஸோ என்ன நான் பேச போகிறேன்னா, ஃபஸ்ட்டு ஏன் பிபி மானிட்டரிங் பண்ணணும் டயாலிசிஸில், what are the factors which are commonly which affect the BP during dialysis, and what are the protocols, என்னெல்லாம் as a technologist, as a doctor என்னெல்லாம் பண்ணணும் அப்படிங்கிறதும் நீங்கள் தெரிஞ்சுக்கணும். And there is a need for something called ABPM, ambulatory blood pressure monitoring. நம்ம நார்மலாக பண்ணுற பிபி மட்டும் பத்தாது, within the dialysis and the interdialytic periodல ABPM பண்ணணுமா, அதுக்கு என்ன ரோல், கைட்லைன்ஸ் என்ன சொல்லுது, டயாலிசிஸ் பேஷண்ட்ஸ்க்கு ஏதாவது கைட்லைன்ஸ் இருக்கா ஃபார் பிபி மானிட்டரிங், அண்ட் ஆஸ் அ டெக்னாலஜிஸ்ட் வாட் இஸ் த இம்பார்ட்டன்ட் ரோல், ப்ராக்டிக்கலாக நீங்கள் என்னெல்லாம் தெரிஞ்சுக்கணும். ஸோ வை டு வி நீட் பிபி மானிட்டரிங் இன் டயாலிசிஸ், ஏன் பிபிங்கிறது இம்பார்ட்டன்ட். ஸோ நம்ம டயாலிசிஸ் பேஷண்ட்ஸுக்கு வால்யூம் கண்ட்ரோலுங்கிறது தான் மோஸ்ட் இம்பார்ட்டன்ட். எவ்வளோ பேருக்கு ஹைப்போடென்ஷன், எவ்வளோ பேருக்கு ஹைப்பர் டென்ஷன் வருதோ, இட் வில் டைரக்ட்லி அஃபெக்ட் தேர் கார்டியோவாஸ்குலர் ஸ்டேட்டஸ். ஸோ அடிக்கடி ஹைப்போடென்ஷன் ஆச்சுன்னா மயோகார்டியல் ஸ்டன்னிங்னு சொல்லுவாங்க. ஸோ ஒரு வாட்டியும் ஒரு பிபி 80-60 ஆர் 90-60 போகும்போதெல்லாம் ஹார்ட் சடனாக அந்த ஸ்மால் மயோகார்டியல் செல்ஸ் வில் கோ ஃபார் ஸ்டன்னிங். தட் மைட் காஸ் லாட் ஆஃப் மார்டாலிட்டி அண்ட் மார்பிடிட்டி லேட்டர். அண்ட் ஒரு தடவையும் பிபி கம்மியாகும் போது ரெசிடுவல் ரீனல் ஃபங்க்ஷன் ஒன்று இருக்குது. வாட் எவர் த பேஷண்ட்ஸ் நேட்டிவ் யூரின் அவுட்புட் ஆர் யூரின் கிட்னி ஃபங்க்ஷன், அது எல்லாமே ஒரு தடவையும் ஹைப்போடென்ஷன் ஆகும்போது கம்மியாகும். அண்ட் உங்களுக்கு காமனாக தெரிஞ்சிருக்கும், நிறையா பேர் ஏவி கிராஃப்ட், ஏவி ஃபிஸ்ட்லா வரும், டக்குன்னு ஹைப்போடென்ஷன் போய் ஃபிஸ்ட்லா த்ராம்பஸ் ஆகிடும், அதுக்கப்புறம் அது திருப்பி நம்மளால் எதுவும் பண்ண முடியாது. ஸோ இதெல்லாம் வந்து யூஸ்வலி ஹைப்போடென்ஷனில் வர ப்ராப்ளம்ஸ். அண்ட் ஹைப்பர் டென்ஷன், ஸோ ஹைப்பர் டென்ஷனுங்கிறது எதனால் பிபி டயாலிசிஸ் பேஷண்ட்ஸில் ஒன் ஆஃப் த காமன் காஸ் ஆஃப் ஹைப்பர் டென்ஷன் இஸ் பிகாஸ் ஆஃப் த வால்யூம் ஸ்டேட்டஸ் இட் செல்ஃப். ஸோ அவங்க கிளினிக்கலாக எப்படி இருக்குது, எடிமாலாம் பார்க்கணும். ஸோ அதெல்லாம் பார்த்துட்டு நம்ம அதுக்கேற்ற மாதிரி வால்யூம் நம்ம அட்ஜஸ்ட் பண்ணணும் அல்ட்ரா ஃபில்ட்ரேஷனில். ஸோ இது எப்படி அஃபெக்ட் பண்ணும், இதே மாதிரி லாங் டர்மாக ஹைப்பர் டென்ஷன் இருக்கவங்களுக்கு கார்டியோவாஸ்குலர் மார்டாலிட்டி ஜாஸ்தி. ஸோ லெஃப்ட் வென்ட்ரிக்கல் ஃபங்க்ஷன் வந்து அஃபெக்ட் ஆகும். சிகேடி இட் செல்ஃப் இஸ் அ ப்ரோ இன்ஃப்ளமேட்டரி ஸ்டேட் தட் வில் ஆல்சோ காஸ் அ லாட் ஆஃப் ப்ராப்ளம்ஸ். ஸோ மெயின் அப்நார்மாலிட்டிஸ் என்ன, நம்பர் 1 intradialytic hypotension, intradialytic hypertension. Other than these two, there are terminologies called pre and post dialytic hypertension. ஸோ இதை பற்றி தான் நெக்ஸ்ட் ஸ்பீக்கர்ஸ் பேசுவாங்க. ஸோ காமனாக நான் சொன்ன மாதிரி ஃபேக்டர்ஸ் ஃபார் ஹைப்போடென்ஷன் அண்ட் ஹைப்பர் டென்ஷன் வந்து மெயினாக பார்த்தீங்கன்னா லைக் ஹைப்போடென்ஷனுக்கு டிக்ளைன் இந்த மோர் அல்ட்ரா ஃபில்ட்ரேஷன் வால்யூம் எடுக்கவே பிபி கம்மியாகும். சம்டைம்ஸ் ரொம்ப அக்ரெசிவ் எடுத்தால் வரலாம். சில பேருக்கு கார்டியோவாஸ்குலர் இஷ்யூ இருக்கும், அவங்களோட எல்வி ஃபங்க்ஷன், தட் இஸ் ஹார்ட்டோட பம்பிங் ஃபங்க்ஷனே கம்மியாக இருக்கலாம். ஸோ அதனால் வரலாம். அதே மாதிரி ஹைப்பர் டென்ஷனுக்கு லைக் ஐ செட் மோர் ஆஃப் வால்யூம், நிறையா வெயிட் கெயினோட வரவங்க, சில பேர் காம்ப்ளைண்ட்டாக இருக்க மாட்டாங்க சால்ட் அண்ட் ஃப்ளூயிட் ரெஸ்ட்ரிக்ஷனில். ஸோ அவங்களுக்குலாம் வந்து இன்னும் சான்சஸ் ஆஃப் ஹைப்பர் டென்ஷன். ஸோ அது அவங்களுக்குலாம் இன்னும் டிஃபிகல்ட்டாக இருக்கும். இதை பற்றி நான் ரொம்ப பேசல, நெக்ஸ்ட் ஸ்பீக்கர்ஸ் வில் டாக். ஸோ எப்படியெல்லாம் பிபி பார்க்கலாம் ஃபார் அ டயாலிசிஸ் பேஷண்ட். நம்பர் 1, ஃபஸ்ட்டு டியூரிங் த செஷன் யூ கேன் செக் எய்தர் ப்ரீ-டயாலிசிஸ் ஆர் போஸ்ட்-டயாலிசிஸ். அண்ட் இன் பிட்வீன் இன்ட்ராடயாலிட்டிக் பீரியடில் பிபி பார்க்கலாம். அண்ட் தெர் இஸ் சம்திங் கால் ஹோம் பிபி அண்ட் ஆம்புலேட்டரி பிபி. ஸோ நீங்கள் பார்த்தீங்கன்னா அந்த இதிலே தெரியுது, பிட்வீன் 2 HD வந்து நடுவில் பார்க்காத நம்ம வீட்டிலே பார்க்கலாம். ஹோம் பிபி யூ அட்வைஸ் தெம் டு சி. இன்னொன்று வந்து ABPM, அதை பற்றி நான் நெக்ஸ்ட் சொல்லுவேன். அண்ட் பிளட் ப்ரெஷர் ஃப்ளக்சுவேஷன்ஸ் நீங்கள் பார்த்தீங்கன்னா பிட்வீன் டயாலிசிஸே ரொம்ப அதிகமாக இருக்கும். ஸோ தட்ஸ் வெரி இம்பார்ட்டன்ட் தட் வி ஷுட் மானிட்டர் பிபி. ஸோ இது ஒரு யூ ஷேப்ட் கர்வ்னு சொல்லுவோம். அப்படின்னா என்னென்னா லைக் 2 டூ லோ பிபியும் கெடுதல், டூ ஹை பிபியும் கெடுதல். இந்த கிராஃபில் பார்த்தீங்கன்னா லெஸ் தென் 110 ஆல்மோஸ்ட். அப்பயும் அந்த ஒய் ஆக்சஸில் இருக்கிறது வந்து ரிலேட்டிவ் ரிஸ்க் ஃபார் டெத். ஸோ மார்ட்டாலிட்டி ஜாஸ்தி ஆகுது ரொம்ப கம்மியாக இருந்தாலும் பிபி. அதே மாதிரி மோர் பிபி பார்த்தீங்கன்னா 170, 180 அந்த ரேஞ்சுக்கு போகும்போது மோர் மார்ட்டாலிட்டி. ஸோ அது ஒரு யூ ஷேப்ட் கர்வ்னு சொல்லுவோம். ஸோ விச் இஸ் த ப்ரிஃபர்ட் மெத்தட்? நான் இப்போ சொன்னது எல்லாத்துலேயுமே ஸ்டடீஸில் என்ன சொல்லியிருக்காங்கன்னா, ஆக்சுவலாக ஐடியல் மெத்தட் இஸ் ஹோம் பிபி அண்ட் ஏபிபிஎம் தான் இட் இஸ் ஷோன் டு ஹேவ் அ சிக்னிஃபிகண்ட் வேல்யூ. இப்போ நம்ம செக் பண்ணுறது வந்து ப்ரீசிஸ்டாலிக், போஸ்ட் டயாலிசிஸ், ப்ரீ டயாலிசிஸ் அண்ட் இன்ட்ரா டயாலிசிஸ்லாம் வந்து ஆக்சுவலாக ஸ்டடீஸ் வைஸ் வந்து மேபி அது ரொம்ப ஃபெலேஷியஸாக இருக்கலாம், அது வந்து கரெக்டான வேல்யூவாக இருக்காது. ஆனால் நம்மளுக்கு வேறு வழி இல்லை, பிகாஸ் அதுதான் ப்ராக்டிக்கலாக நம்மளால் பண்ண முடியும். அதில் என்னெல்லாம் இஷ்யூஸுங்கிறது நெக்ஸ்ட்டு சொல்கிறேன். ஸோ வாட் ஆர் த சைட்ஸ் அண்ட் what is the method of monitoring? So pre-dialysis usually நல்ல ஒரு rested position, நல்ல seated positionல தான் இருக்கணும். பேஷண்ட் ஆங்ஷியஸாலாம் இருக்கும் போதெல்லாம் பார்க்கக்கூடாது. ரெண்டு காலும் வந்து it should be facing down, floor support இருக்கணும், அதெல்லாம் பண்ணணும். அண்ட் நான் ஃபிஸ்டுலா ஆர்ம் ஒரு நான் கிராஃப்ட் ஆர்மில் தான் பார்க்கணும். அப்பர் லிம், லோவர் லிம் அதெல்லாம் பார்த்து தான் பண்ணணும். ஸோ அதிலே வேரியேஷன் இருக்கும். ஸோ ப்ரீ டயாலிசிஸ் அப்படி பார்ப்போம். இன்ட்ரா டயாலிட்டிக் ஆக்சுவலி ஆஸ் சச் கைட்லைன்ஸில் எதுவும் ரொம்ப பெருசாக இல்லை. ஆனால் ஸ்டேபிள் பேஷண்ட்டாக அன்ஸ்டேபிள் பேஷண்ட்டுக்கான்னு பார்த்துட்டு நம்ம அதுக்கேற்ற மாதிரி பண்ணணும். பட் யூஸ்வலி 30 to 60 minutes டியூரிங் த டயாலிசிஸ், எவ்ரி 30 minutes பார்க்கணும். சம்டைம்ஸ் அன்ஸ்டேபிளாக இருக்காங்க, அடிக்கடி ஹைப்போடென்ஷன் போகிறாங்க, அந்த ட்ரெண்டு தான் பார்க்கணும். ஒரு வேல்யூ வச்சுட்டு நம்ம சொல்லக்கூடாது. ஸோ அது அந்த மாதிரி பேஷண்ட்ஸ்க்கு ஈவன் எவ்ரி 15 minutes பண்ணணும். அண்ட் போஸ்ட் டயாலிசிஸ் அகெயின் உட்கார பொசிஷனில் 5 minutes ஆஃப்டர் டயாலிசிஸ் முடிஞ்சதுக்கப்புறம் பார்க்கலாம். சில பேருக்கு நம்ம ஸ்டாண்டிங் பிபியும் பார்க்கணும். ஏன்னா சம்டைம்ஸ் ஆர்த்தோஸ்டாட்டிக் ஹைப்போடென்ஷன்னு சொல்லுவோம், ரொம்ப ஃப்ளூயிட் ரிமூவல் ஆகி டீஹைட்ரேஷன் லெவலுக்கு போனால் அந்த மாதிரி வரலாம். சில பேருக்கு ஆட்டோனாமிக் டிஸ்ஃபங்க்ஷன் இருக்கலாம். டயபெட்டிக்ஸ்க்கெலாம் பார்த்திங்கன்னா ரொம்ப ஒரு ஃப்ளக்சுவேட்டிங் பிளட் ப்ரெஷர் இருக்கும். ஸோ அவங்களுக்குலாம் இந்த ஸ்டாண்டிங் பிபி பார்க்கறது இம்பார்ட்டண்ட். ஸோ அதான் ப்ரோட்டோகால் நான் சொன்ன மாதிரி ஸ்டார்ட் ஆஃப் டயாலிசிஸ் எவ்ரி 30 to 60 minutes டியூரிங் செஷன், எண்ட் ஆஃப் டயாலிசிஸ். ஸோ எப்போ நம்ம அலர்ட்டாக இருக்கணும் அப்படிங்கிறத பற்றி அதுக்கு ஸ்பெசிஃபிக்காக இன்டர்டயாலிட்டிக் ஹைப்போடென்ஷன்னா ஒரு பர்டிகுலர் லெவல் ஆஃப் சிம்டம்ஸ் இருக்கும். ஹைப்பர் டென்ஷனுக்கு அந்த ட்ரெண்ட் பார்க்கணும். அது நெக்ஸ்ட்டு ஸ்பீக்கர்ஸ் பேசுவாங்க. ஸோ வாட் ஆர் த லிமிட்டேஷன்ஸ் ஆஃப் இப்போ நம்ம பார்க்குற இதில் என்ன ப்ராப்ளம்? ஸோ ரெண்டு என்டிட்டி இருக்குது. ஒயிட் கோட் ஹைப்பர் டென்ஷன்னு சொல்லுவாங்க, இன்னொன்று மாஸ்ட் ஹைப்பர் டென்ஷன்னு சொல்லுவாங்க. ஒயிட் கோட் ஹைப்பர் டென்ஷன்னா நம்ம செக் பண்ணும்போது, ஹாஸ்பிட்டலில் வந்து செக் பண்ணும்போது, டாக்டரோ இல்லை நீங்கள் செக் பண்ணும்போது அப்போ மட்டும் பிபி ஜாஸ்தியாக இருக்கலாம், அது வந்து ட்ரூ பிபியாக இருக்காது. ஸோ அதனால் நம்ம அந்த பிபியை வச்சுட்டு நம்ம நிறையா ஃப்ளூயிட் எடுக்கலாம். ஸோ அந்த மாதிரி ஹைப்போ டென்ஷன் போக சான்சஸ் இருக்குது. அண்ட் மாஸ்ட் ஹைப்பர் டென்ஷன்னு சொல்லுவாங்க. அப்படின்னா நம்ம பார்க்கும்போது ஆக்சுவலி நார்மல் பிபியாக இருக்கலாம், பட் ஹோம் பிபி ஆர் ஆம்புலேட்ரி பிபியில் பார்க்கும்போது அது ஹைப்பர் டென்ஷன் ரொம்ப ஜாஸ்தியாக இருக்கலாம். அதனால வந்து நம்ம நார்மலாக இருக்குன்னு நினச்சிட்டு ரொம்ப ஃப்ளூயிட் எடுக்க மாட்டோம். ஸோ ப்ராப்ளம்ஸ் வரும், ஈவென்ச்சுவலி கார்டியோவாஸ்குலர் ப்ராப்ளம்ஸ் வரும். ஸோ இது மூணுத்தில் எது பெஸ்ட்டு? இப்போ என்னெல்லாம் நம்ம நார்மல் டிவைசஸ் என்னெல்லாம் யூஸ் பண்ணுவோம்? மர்க்கரி இப்போல்லாம் யூஸ் பண்ணுறதில்ல. மேனுவலாக பார்க்குறதுக்கு மற்ற இப்போ ஆனராய்ட் ஸ்பிக்னோமேக்னோமீட்டர்னு சொல்லுவாங்க. ஸோ அதையும் யூஸ் பண்ணுறோம். அண்ட் இன்னொன்று வந்து ஆன்லைன் மானிட்டரிங். நம்ம மோஸ்ட் ஆஃப் த மெஷின்ஸ் எல்லாத்துலேயுமே ஆன்லைன் மானிட்டரிங் வந்துருச்சு, அது எல்லாமே ஆட்டோமேட்டட். ஸோ அது பார்க்கணுமா இல்லை வந்து நம்ம மேனுவலாக பார்க்கணுமா? இன்னொரு இருக்குது, அதுக்கு பேர் வந்து கிரிட்லைன், இட்ஸ் கால்ட் கிரிட்லைன் பிபி மானிட்டரிங். அது வந்து கண்டினியூஸாக நான் இன்வேசிவ் தான், கண்டினியூஸ் பிபி பார்க்கலாம். ஃபார் அன்ஸ்டேபிள் பேஷண்ட்ஸ் இட் இஸ் ப்ரிஃபர்ட். அது அவ்வளோ யூஸ் பண்ணுறதில்ல நம்ம. ஸோ நான் சொன்ன ஏபிபிஎம் தான் ஆக்சுவலி கோல்ட் ஸ்டாண்டர்ட். ஆனால் அதில் என்ன இஷ்யூஸ் இருக்குது? அது ரொம்ப லிட்டில் பிட் எக்ஸ்பென்சிவ். அதுக்கு வந்து நிறையா ஒரு ஆப்ரேட்டர் சப்போர்ட் வேணும், அதெல்லாம் தெரிஞ்சால் தான் பண்ண முடியும். ஸோ நான் சொன்ன மாதிரி மாஸ்ட் ஹைப்பர் டென்ஷன் அண்ட் ஒயிட் கோட் ஹைப்பர் டென்ஷன் என்னென்னு எக்ஸ்பிளைன் பண்ணிட்டேன். மாஸ்ட் ஹைப்பர் டென்ஷன் இஸ் when the unit BP appears normal but ABPM is elevated, whereas white coat hypertension is elevated dialysis unit BP but with a normal ABPM. ஸோ 24 hour நீங்கள் பார்த்தீங்கன்னா அந்த கிராஃபில் தெரியுது. ஸோ கீழே எக்ஸ் ஆக்சஸில் பார்த்தீங்கன்னா ஹெச்டி, ஸோ ஹெச்டி டைமில் பிபி வந்து நம்ம பார்க்குறோம் ஓரளவுக்கு ஸ்டேபிளாக இருக்குது. ஹெச்டி முடிஞ்சிட்டு இன்பிட்வீன் ஹெச்டி முடிச்சதுக்கப்புறம் வந்து பேஷண்ட் இஸ் ஹேவிங் அ மீல், அந்த டைமில் பிபி மைட் ட்ராப் விச் இஸ் அ காமன் திங். அண்ட் அதுக்கப்புறம் இன்பிட்வீன் 2 மீல்ஸ் ஆர் டியூரிங் ஸ்லீப், இதில் தான் ஏபிபிஎம் பிகம்ஸ் வெரி இம்பார்ட்டன்ட். ஸோ ஏபிபிஎம்மில் 2 விஷயம் பார்க்கணும். அது தே ஆர் கால்ட் அஸ் நாக்டர்னல் டிப்பர்ஸ் ஆர் நான் டிப்பர். ஸோ நார்மலாக எல்லாருக்குமே வந்து நைட்டில் பிபி ஷுட் ஃபால், அது நார்மல். பட் இன் சிகேடி டயாலிசிஸ் பேஷண்ட்ஸ் இட் டஸ் நாட் ஹேப்பன் பிகாஸ் ஆஃப் லாட் ஆஃப் ரீசன்ஸ். ஸோ இப்போ வந்து இந்த பேஷண்ட்ஸ்க்கு ஆக்சுவலி ஸ்லீப்பில் இட் ஷுட் ஃபால், பட் நிறைய பேருக்கு ஃபால் ஆகாது. ஸோ அதனால வந்து ஏபிபிஎம் இஸ் ஆக்சுவலி இம்பார்ட்டன்ட். அதில் ஃபால் ஆகாத பேஷண்ட்ஸ் வந்து நம்ம பிக்கப் பண்ணலாம். அண்ட் அவங்களாம் வந்து மோர் ரிஸ்க்காக இருப்பாங்க ஃபார் அதர் ப்ராப்ளம்ஸ். ஸோ இதில் பார்த்தீங்கன்னா லெஃப்ட் சைடில் இருக்கிறது நைட் டைம் டிப்பிங் யாருக்கெல்லாம் இல்லை. ஸோ சிகேடி, சிஹெச்எஃப், டயபெட்டிஸ், அப்புறம் இன்சாம்னியா, ரொம்ப ஸ்லீப் டிஸ்டர்பன்ஸ் இருக்கவங்களுக்கு, அவங்களுக்குலாம் நைட் டைம் டிப்பிங் இல்லை. சில பேருக்கு வந்து நைட் டைமில் சர்ஜ் ஆகும். ஸோ அவங்களாம் யாருன்னா ப்ரைமர்லி ஓஎஸ்ஏ, நிறையா ஸ்னோர் பண்ணிருக்கவங்க, கொஞ்சம் ஒபீஸ் பேஷண்ட்ஸ், அவங்களுக்குலாம் வந்து இட் மைட் இன்க்ரீஸ். ஸோ இது எல்லாமே நம்ம ஏபிபிஎம்மில் கேப்சர் பண்ணலாம். ஸோ இது ஏன் இம்பார்ட்டண்ட், ஏன்னா இந்த நான் டிப்பிங் பேட்டர்ன்ஸ் வந்து ஆல்மோஸ்ட் 70% ஆஃப் ஹெச்டி பேஷண்ட்ஸ் ஹேவ் திஸ் பேட்டர்ன் அண்ட் தே ஆர் அசோசியேட்டட் வித் மோர் எல்விஹெச். ஸோ ஹார்ட் ஃபங்க்ஷன்ஸ் ப்ராப்ளமாக இருக்கும், சிவி மார்ட்டாலிட்டி ஜாஸ்தியாகும். ஸோ இதை எப்படி பண்ணுவோம்? ஸோ பிட்வீன் 2 டயாலிசிஸ் செஷன்ஸ் யூஸ்வலி லாங்கர் இன்டர்வல் இருக்கிற செஷன்ஸ் தான் ப்ரிஃபர் பண்ணுவோம். ஸோ ஐடியலி 44 hours நம்ம பண்ணணும். டயாலிசிஸ் முடிஞ்சிட்டு ஒரு 2 hours or 3 hours கழிச்சு ஆரம்பிச்சுட்டு நெக்ஸ்ட் செஷன் வரைக்கும் அது போகணும். அண்ட் அதுவே ஆட்டோமேட்டிக்காக கஃப் இன்ஃப்ளேட் ஆகும் எவ்ரி 20 to 30 minutes. தட் இஸ் ஒன் டிஸ்அட்வான்டேஜ். ஸோ பேஷண்ட்டுக்கு அது இட் மைட் பி அ டிஃபிகல்ட்டி. அண்ட் ஆப்வியஸ்லி வி நீட் அ ட்ரைனிங். யாராவது அதை ரீட் பண்ணுறதுக்கும் ஒரு ப்ராப்பர் ஒரு சப்போர்ட் வேணும் அண்ட் அதை பண்ணுறதும் ப்ராப்பராக பண்ணணும். So cost and availability is also not very great. So these are the challenges. இது ஒன் ஆஃப் த ஸ்டடீஸ் ஆக்சுவலி நம்ம இந்தியன் ஜேர்னல் ஆஃப் நெஃப்ராலஜியில் தான் பண்ணியிருக்காங்க, இங்கே தமிழ்நாடுல தான் பண்ணாங்க. ஸோ இதில் என்ன சொன்னாங்கன்னா, ஆம்புலேட்டரி பிபி பண்ணதில் வந்து அன்கண்ட்ரோல்ட் ஹைப்பர் டென்ஷன் வித் சர்க்கேடியம் ரிதம் வாஸ் வெரி ஹை விச் வாஸ் டிடெக்டட் பை ஏபிபிஎம். அண்ட் நிறைய பேருக்கு மாஸ்ட் ஹைப்பர் டென்ஷனும் கண்டுபிடிச்சிருக்காங்க. ஸோ இது வந்து ஸ்டடீஸ்லையும் ப்ரூவ் ஆயிருக்கு. ஸோ நான் டயாலிசிஸ் பேஷண்ட்ஸ்லாம் நம்மளுக்கு ஆக்சுவலி கைட்லைன்ஸ் இருக்குது. பிபி டார்கெட்ஸ் என்ன, எக்ஸாக்டாக எவ்வளோ இருக்கணும் அப்படிங்கிறது. அமெரிக்கன், யூரோப்பியன் இதில் பார்த்திங்கன்னா நிறையா இருக்குது. பட் ப்ராப்ளம் என்னென்னா, நம்மளோட டயாலிசிஸ் பேஷண்ட்ஸுக்கு ஆக்சுவலி பெருசாக ரெக்கமெண்டேஷன்ஸே இல்லை. தட் இஸ் த ப்ராப்ளம். ஸோ ஏன்னா வந்து இட் இஸ் டோட்டலி இண்டிவிஜுவலைஸ்ட். ஒரு பேஷண்ட்டு ஒரு மாதிரி இருப்பாங்க நம்ம டயாலிசிஸ் பேஷண்ட். ஸோ நம்ம எல்லாருக்குமே ஒரே டார்கெட் பண்ண முடியாது. ஏஜ் பார்க்கணும், அவங்களோட அல்ட்ராஃபில்ட்ரேஷன் ப்ரொஃபைல் பார்க்கணும், எவ்வளோ வெயிட் கெயின் வராங்க அதெல்லாமே பார்க்கணும். பட் ஆர்டிகல்ஸில் என்ன போட்டிருக்கு அப்படின்னு பார்த்தீங்கன்னா, நம்மளோட கேடிகோ, கேடோக்கி இதுதான் மெயினாக நம்ம டயாலிசிஸ் பேஷண்ட்ஸ்க்கு யூஸ் பண்ணுற மெயின், இவங்க தான் மெயின் ஆர்கனைசேஷன். ஸோ அவங்க ஆக்சுவலாக யூஸ் பண்ண வேண்டியது ஹோம் அண்ட் ஏபிபிஎம் தான் சொல்கிறாங்க. அண்ட் ப்ரீ டயாலிசிஸ் ஷுட் பி லெஸ் தென் 140/90, post dialysis should be less than 130/80. But they have also given a note saying individualized targets based on volume, status and comorbidities. So அது ரொம்ப important. KDOKI guidelines என்ன சொல்லிருக்காங்க, target pre HD less than 140/90 and post HD அதே தான். So almost they are all same. And அவங்க என்ன சொல்றாங்க, every 30 to 60 minutes at least நம்ம பார்த்துறணும் during dialysis. So as technologists நம்ம என்ன பண்ணணும்? ஸோ கரெக்டாக பார்க்கணும் பிபி ஃபஸ்ட், அதுதான் இம்பார்ட்டன்ட். மேனுவலாக ஆட்டோமேட்டடாங்கிறது நான் கடைசியில் சொல்கிறேன். மேனுவலாக பார்க்கும்போது பிபி டெக்னிக் ஷுட் பி ரைட். அண்ட் ஒரு வேல்யூ வச்சுட்டு நம்ம சொல்லக்கூடாது. வி ஷுட் ரெக்கக்னைஸ் த ட்ரெண்ட், பேட்டர்ன் பார்க்கணும். இப்போ சடனாக 140லேருந்து 110 or 120 போச்சுன்னா அது இம்பார்ட்டன்ட், அதை இக்னோர் பண்ணக்கூடாது. ஆனால் 140, 134, 130 அந்த மாதிரி போச்சுன்னா தட்ஸ் ஓகே. ஃப்ளூயிட் ரிமூவலோடு அது பரவாயில்ல. அதே மாதிரி ஹைப்பர் டென்ஷனுக்கும் அதே மாதிரி தான் பார்க்கணும். அண்ட் அதுக்கேற்ற மாதிரி நம்ம எல்லாமே இப்போ வால்யூமெட்ரிக் மெத்தட் தான். ஸோ அதனால் வந்து நம்ம யூஎஃப் அதுக்கேற்ற மாதிரி மெஷினில் ப்ரோக்ராம் பண்ணி நம்ம பண்ணிக்கலாம். ஸோ இது ஒரு நிறையா டிபேட் இருக்குது. நிறையா பேர் காமனாக கேட்குறது தான், மெடிசன் அன்றைக்கி காலையில் போட்டுட்டு வரணுமா போடக்கூடாதா, ஆன்டி ஹைப்பர்டென்சிவ் மெடிசன். ஸோ அது வந்து அதை பற்றி வந்து பேசலாம். ஆக்சுவலி நிறையா ஒரு டிஃப்ரெண்ட் ஒப்பீனியன்ஸ் இருக்குது. ஆனால் காமனாக என்ன சொல்கிறேன்னா, ஜஸ்ட் பிஃபோர் டயாலிசிஸ் வி ஷுட் ஸ்கிப் த ஆன்டி ஹைப்பர்டென்சிவ். nighttime dosing is usually preferred to reduce the intradialytic hypotension risk. ஆனால் சம்டைம்ஸ் ரொம்ப லாங்கர் ஆக்டிங் ட்ரக்ஸ் இருக்கும். ஸோ அந்த மாதிரி இருக்கிறவங்களுக்கு நைட் டைம் டோஸ் போட்டு இல்லை ஏர்லி மார்னிங் போட்டால் கூட இட் வில் பிகம் அ ப்ராப்ளம் டியூரிங் டயாலிசிஸ். ஸோ இந்த மாதிரி ஏதாவது எனி ப்ராப்ளம் வரும்போது என்ன பண்ணணும்? ஃபஸ்ட்டு ஸ்டாப் த டயாலிசிஸ். எனி இஷ்யூ, எனி கைண்ட் ஆஃப் ப்ராப்ளம், யூ ஃபர்ஸ்ட் பாஸ் த டயாலிசிஸ் அண்ட் தென் சி வாட் இஸ் அவர் ரூட் காஸ்ன்னு பார்க்கணும். ஹைப்போடென்ஷன்னா ரெடியூஸ் பண்ணுங்கள் அல்ட்ரா ஃபில்ட்ரேஷன் ரேட், ஹைப்பர் டென்ஷன்னா அதுக்கேற்ற மாதிரி நம்ம மேனேஜ் பண்ணணும். ஸோ இது எல்லாமே எதுக்கு இம்பார்ட்டன்ட்னா, பிகாஸ் லாங் டேர்ம் மார்ட்டாலிட்டி எல்லாமே வந்து இட் டிபெண்ட்ஸ். எவ்ரி டைம் நான் சொன்ன மாதிரி ஒரு வாட்டியும் டயாலிசிஸ் பண்ணி ஹைப்போடென்ஷன் போய் சிங்கோப்லாம் ஆச்சுன்னா அதுக்கப்புறம் இட் வில் அஃபெக்ட் த லாங் டேர்ம் ப்ரோக்னோசிஸ். ஸோ அதுக்காக வி ஷுட் ட்ரெயின் மோர் அண்ட் மோர். பிபி டெக்னிக் கரெக்டாக இருக்கா அந்த மாதிரி ஆடிட்லாம் பண்ணி அடிக்கடி பார்த்தா தான் நம்மளுக்கு தெரியும். ஸோ காமனாக ப்ராக்டிக்கல் கொஸ்டின்ஸ் இதுதான் எல்லாருக்குமே ஆஃபனாக கேட்குறது. ஸோ வாட் இஸ் த ஆப்டிமல் ஃப்ரீக்வன்சி ஆஃப் பிபி மானிட்டரிங்? ஆல்ரெடி நான் டிஸ்கஸ் பண்ண மாதிரி தான். ஸோ ஸ்டேபிள் பேஷண்ட்ஸ்னால் 30 minutes ஈச் இஸ் இனஃப். ஆனால் அன்ஸ்டேபிள் பேஷண்ட்ஸ் அந்த மாதிரி இருந்தாங்கன்னா எவ்ரி 15 minutes மைட் பி பெட்டர். அதுக்கு நீங்கள் ப்ரீவியஸ் டயாலிசிஸ் செஷன்ஸில் எப்படி இருந்தது பிபி அந்த ட்ரெண்டெல்லாம் பார்த்துட்டு தான் சொல்ல முடியும். ரொம்ப டயபெட்டிக்ஸ், கார்டியோவாஸ்குலர் டிஸ்ஃபங்க்ஷன் அந்த மாதிரி இருக்கிறவங்களுக்கெல்லாம் அடிக்கடி பண்ணணும். ஸோ மேனுவல் பெட்டரா ஆட்டோமேட்டட் பெட்டரா? ஸோ நீங்கள் பார்த்தீங்கன்னா என்ன அட்வான்டேஜ்? ஆக்சுவலி மேனுவல் பார்க்குறது கோல்ட் ஸ்டாண்டர்ட் தான். ஏன்னா வந்து நம்மளே பார்க்குறோம், நம்மளுக்கு தெரியும் என்ன பிபி எக்ஸாக்டாக இருக்குது அப்படின்ட்டு. இதில் எதுவும் டெக்னிக்கல் கிளிச் எதுவும் இருக்காது. ஆனால் ப்ராப்ளம் என்னென்னா வி ஷுட் பி வெல் ட்ரெயின்ட். இட் இஸ் ஆப்ரேட்டர் டிபெண்டன்ட். கரெக்டான டெக்னிக்கில் பண்ணணும். இன்னொரு அட்வான்டேஜ் என்னென்னா இது வந்து நம்மளுக்கு எப்போ வேணுமோ அப்பப்போ பார்த்துக்கலாம். ஸோ அந்த மாதிரி ஒரு செட்டப் இருக்குது. இதில் என்ன டிஸ்அட்வான்டேஜஸ்? இதில் வந்து ஒருத்தங்க கரெக்டாக பார்த்துட்டு இன்னொருத்தங்களுக்கு வேறு மாதிரி பிபி வந்துச்சுன்னா நம்ம இப்போ எந்த பிபி எடுக்கணும் அப்படிங்கிறத டவுட் வரும். ஸோ அந்த மாதிரி அதில் ஒரு டிஸ்அட்வான்டேஜ் இருக்குது. whereas automated, that is online, அதில் பார்த்தீங்கன்னா it will reduce the workload for the technologist. இப்போ ஒரு டெக்னாலஜிஸ்ட் 2-3 பேஷண்ட் பார்த்துட்டு இருக்காங்கன்னா அவங்களுக்கு வந்து ஒருத்தரையும் போய் இப்படி பிபி பார்க்கறது மேபி டிஃபிகல்ட். ஸோ நம்ம ஸ்டேபிளாக இருக்காங்க, பிபி ரொம்ப அந்த ட்ரெண்ட் வந்து அடிக்கடி இன்க்ரீஸ் ஆகலை கம்மியாகலை அந்த மாதிரி இருக்கிற பேஷண்ட்ஸ்க்கு we can prefer automated. அண்ட் இதில் என்ன இன்னொரு அட்வான்டேஜ்னால் ஒரு எவ்ரி 15 to 20 minutes we can அதிலே மெஷின்லேயே செட் பண்ணிடலாம், அதில் பார்க்கலாம். அண்ட் அந்த ட்ரெண்ட் தெரியும், நம்ம நோட் பண்ணிக்கலாம். ஸோ அது இட் will be easier to monitor. இதில் வாட் இஸ் த டிஸ்அட்வான்டேஜ்? இது வந்து கேலிப்ரேட் பண்ணணும். மெஷினில் வந்து கரெக்டாக எல்லாமே கேலிப்ரேட் பண்ணி இது பண்ணால் தான் கரெக்டாக வரும். இல்லைனா வந்து சம்டைம்ஸ் ஆர்டிஃபேக்ட்னாலையோ இல்லை வேறு ஏதாவது ப்ராப்ளம்ஸ் ஆகுதுன்னா சரியாக ஃபால்ஸ்லி லோ ஆர் ஃபால்ஸ்லி ஹையாக காட்டும். ஸோ இன் சம்மரி ஹைப்ரிட் அப்ரோச் இஸ் பெஸ்ட். இதுதான் பெஸ்ட் அப்படின்னு ஒன்றும் இல்லை. மேனுவலாக பார்த்துட்டு ஆன்லைனாக பார்த்துட்டு சப்போஸ் உங்களுக்கு பேஷண்ட்டுக்கு ரொம்ப ஹைப்போடென்ஷன் போகுது இல்லை அதில் சரியாக உங்களுக்கு தெரியாத மாதிரி இருக்குன்னா மேனுவலாக இப்போ செக் பண்ணி cross check பண்ணிக்கோங்க. அப்படி பண்ணால் இன்னும் பெட்டராக இருக்கும். பட் இன் அன்ஸ்டேபிள் பேஷண்ட்ஸ் ஆல்வேஸ் இட் இஸ் பெட்டர் டு ப்ரிஃபர் அ மேனுவல் மெத்தட். ஸோ இஸ் தேர் எனி ஸ்பெசிஃபிக் டைம்லைன் ஃபார் ஹைப்போடென்ஷன் பர் சே? ஸோ இதுவும் இட் இஸ் வெரி சப்ஜெக்டிவ். சில பேருக்கு டயாலிசிஸ் ஆரம்பித்த உடனே ஹைப்போடென்ஷன் வரலாம். அப்போது நீங்கள் நிறைய விஷயம் யோசிக்கணும். வேறு ஏதாவது டயாலிசர் ரியாக்ஷன் இருக்கா, அந்த மாதிரி ஏதாவது ரியாக்ஷன் இருக்கா அது பார்க்கணும். சில பேருக்கு வந்து மோஸ்ட் ஆஃப் மெஜாரிட்டின்னு சொல்லலாம், ஒரு 60 to 70% ஆஃப்டர் த செகண்ட் ஹவர். இந்த கிராஃப் பார்த்தீங்கன்னா ஆஃப்டர் த மிட் பாயிண்ட், தட் இஸ் செகண்ட் ஹவர் ஆர் தேர்ட் ஹவர், அந்த டைமில் தான் வந்து பிபி மெயினாக குறையும். தட் இஸ் ஆப்வியஸ்லி பிகாஸ் ஆஃப் அல்ட்ரா ஃபில்ட்ரேஷன். நீங்கள் நிறையா ஃப்ளூயிட் எடுக்கிறீங்க. சில பேருக்கு ரொம்ப அக்ரெசிவாக எடுத்திங்கன்னா இன்னும் சீக்கிரமாக கூட வரலாம். பட் ஸ்டடீஸ் என்ன சொல்லுதுன்னா 2 to 3 ஹவர்ஸ்லேருந்து தான் ஜாஸ்தி ஆகும். அண்ட் அந்த ரிஸ்க் ஆக்சுவலி டயாலிசிஸ் முடிஞ்சதுக்கப்புறமும் இருக்குது. ஸோ நம்ம டயாலிசிஸ் முடிச்சுட்டு உடனே பேஷண்ட்டை அனுப்புறது இட்ஸ் நாட் அ வெரி குட் ப்ராக்டிஸ். சம்டைம்ஸ் ஒரு ½ an hour கூட அப்சர்வ் பண்ணி பிபி கரெக்டாக இருக்கா அப்படின்னு பார்க்கணும். நீங்கள் அந்த லாஸ்ட்டில் லைன் பார்த்தீங்கன்னா ஹையர் ரிஸ்க் பாருங்கள், எண்ட் ஆஃப் டயாலிசிஸ்க்கு அப்புறமும் இருக்குது. ஸோ திஸ் இஸ் ஒன் திங் நம்ம நெக்லெக்ட் பண்ணக்கூடாது. தேங்க்யூ.
Thank you, Sudarshan. That was pretty extensive coverage of how to monitor blood pressure during dialysis. I'll sum up all that he said at the end of the session. I'd like to invite the next speaker, Dr. Vijayashree, to talk about management of hypotension in dialysis.
Good afternoon, everyone. I'll be talking about hypotension during dialysis. So, actually, for hypotension during dialysis or IDH, intradialytic hypotension, there are multiple definitions. But the most commonly followed is when the blood pressure drops more than 20 millimeters of mercury compared to the pre-dialysis blood pressure, or when the mean arterial pressure reduces by 10 millimeters of mercury. Along with the drop in blood pressure, the patient should also have symptoms. For example, lightheadedness or dizziness, feeling very weak, and the mari symptoms. With the drop in blood pressure, we call it as intradialytic hypotension. Or when the systolic blood pressure drops to less than 90 millimeters of mercury also, we call it as IDH. So, what are the risk factors? Which dialysis population is at high risk for this IDHs? One is most commonly old age and female sex. Also, the presence of diabetes, and when the interdialytic weight gain between two dialysis sessions is very high. Also, when somebody is on dialysis for longer duration, and when they come to the dialysis itself, their blood pressure is very less, that is low pre-dialysis BP. And the nutrition status, somebody with a low albumin level. So these people are at high risk for developing intradialysis hypotension. These are the risk factors I discussed. Now, what are the medical conditions? What are the underlying problems which can cause IDH? One is the patient is having fever or some form of sepsis infection somewhere. They can develop IDH, or some conditions related to the heart. The heart rhythm is not good. The patient has got atrial fibrillation or an underlying valvular heart disease like rheumatic heart disease and the mari, or some pericardial effusion which is causing a tamponade. Tamponade na it is causing compression madri. And the patient develops myocardial infarction during dialysis, or some complications because of dialysis per se. Nama pandra dialysis nala patient is developing hemolysis or hemorrhage through the fistula needle. Or inadvertent நம்ம ஏதாவது ஒரு போட்டை ஓப்பன் பண்ணி விடுறதுனால patient is developing air embolism or dialyzer reaction. So these are the underlying medical conditions which can cause intradialytic hypotension. So what are the mechanisms which leads to hypotension? When we try to remove the ultrafiltration at a rapid rate, that is more than 10 to 13 ml per kg per hour, that is called rapid ultrafiltration. So at that time the patient may develop hypotension. Or when the prescribed dry weight for the patient, we have set it at an inappropriately low. Patient has gained weight, muscle mass actually, but we have not corrected the weight. So then they can develop hypotension. Otherwise, when the patient is, because of long-standing diabetes or other disorders, the patient may be having something called as autonomic neuropathy. That is, when the BP drops, normal response will be the blood vessels should constrict. But people with autonomic neuropathy, they cannot constrict the blood vessels, so they are prone to develop hypotension. Or the patient's cardiac function, their heart pumping capacity is not good. They've got some amount of LV dysfunction. This can also cause IDH. Or the patient has taken the antihypertensive drugs before the dialysis, and so the blood pressure is less. Also, intake of meal. When they have their food immediately before or during dialysis, what will happen is the blood supply to the gut and other areas, that will increase. So this will lead on to a drop in blood pressure. So what are the symptoms and warning signs of intradialytic hypotension? Symptoms will be like patients will complain of lightheadedness, dizziness. They might say headache, or they can develop muscle cramps, nausea, vomiting, dyspnea, and they sometimes say they feel very tired and weak. And if it becomes very severe, they may even lose their consciousness. What are the early warning signs of IDH? Because of low oxygen in their body, they develop some signs like yawning, sighing, and hoarseness of voice, and some people might develop blurring of vision. So how do you manage this IDH? So once you see the patient developing decreased blood pressure with some signs and symptoms, you should immediately decrease or you should stop the ultrafiltration. And then next will be you have to put the patient in Trendelenburg position. So what is Trendelenburg position? The legs should be lifted up at least 15 to 30 degrees above the head. And this, why this is important is this will increase the venous return to the heart, so that the blood pressure will increase on its own. Still, if the blood pressure is less, you can give a saline bolus, 200 to 500 ml, up to 500 ml you can give. And during hypotension, the patient's oxygenation will be less, so it's better to give oxygen. If with all the above measures still the blood pressure is less, you have to evaluate for underlying medical conditions which I discussed previously. So how do you prevent a patient from developing IDH? So there are patient-related factors and dialysis-related factors. So basically, if you have to reassess the target weight. If the target weight is set inappropriately low, you can reassess it by clinically, by looking at edema, lung signs. But some facilities, some centers may have the facility for doing BCM, bioelectrical impedance spectrometry. If you have the BCM facility, you can use that and assess the dry weight. And in some centers, they even use lung ultrasound. A lung ultrasound will show the presence of fluid in the lungs by B lines, and assessment of IVC size. If the patient, if we have removed too much of fluid from the body, the IVC will be collapsed. With all these, we can reassess the dry weight actually. And as I discussed earlier, if you ask the patient to take food during dialysis, the blood pressure may drop, so avoid food during dialysis. And for specific patients, we also have to avoid giving antihypertensives prior to dialysis. And also, we should instruct the patient to avoid salt intake to avoid too much of salt intake between the dialysis sessions, so that they gain less weight, and we tend to remove less fluid during the dialysis. If some patients, they may be having residual urine output, so what we can do is, if we give them diuretics to increase the urine output, we can remove less, their weight gain will be less, so we can remove less fluid during the dialysis. And for some people, we can increase the duration of each session of dialysis. Instead of 4 hours, we can make it 4.5 hours, like that we can increase. And we can modify our dialysis prescription by giving them a low dialysate temperature, that is cool dialysate. How does this help us? When the dialysate temperature is cool, the body senses it, and there is vasoconstriction. So this will increase the blood pressure. Sodium profiling. The role of sodium profiling is actually very doubtful. So when you do a sodium profile, what you do is, during the starting of dialysis, you keep a higher sodium, for example 150 or so, and towards the end you bring it down to 138 or in that range. So this will try to maintain the intravascular volume, but the problem with this is, the patient will go back with a higher serum sodium. So when the sodium is high, obviously the thirst will increase and they will drink more water, and they can come back with more weight gain. So the sodium profiling is actually questionable. And with all these measures, if somebody has hypotension during every dialysis, then we'll consider giving them drugs like midodrine. This midodrine is a vasoconstrictor. So we can instruct the patient to take the drug 15 to half an hour before starting of dialysis. Also L-carnitine. This L-carnitine is actually needed by the cardiac muscle for ATP production. So if we supplement this before the starting of dialysis, IDH can be avoided. And other modalities, like for example, HDF is found to have less hypotension compared to HD. So if facility is available, we can change to HDF. Or in very refractory cases of hypotension, we can convert them to PD. So what happens if a patient develops hypotension recurrently during dialysis? So if there are recurrent episodes of dialysis, we tend to interrupt the dialysis sessions, so the dialysis efficacy is less, and this impairs their quality of life. Also, as Dr. Sudarshan discussed, every time they develop severe hypotension, there is cardiac muscle stunning. Because of poor blood supply, the poor contractility develops, and ultimately they develop LV dysfunction. Like how heart is affected, similarly poor blood supply can affect the bowel. It can even cause ischemia to the liver. Also, cerebral ischemia, the blood supply to the brain may decrease, which can even cause stroke and loss of white matter. There is something called gray matter and white matter in the brain. This loss of white matter and other things can ultimately even cause dementia, that is loss of memory in a patient with dialysis. Also, recurrent episodes of dialysis can reduce the residual renal function. So their urine whatever minimal urine output the patient has, even that is very significant for the patient to get rid of all the amyloid and other things, preventing them from developing amyloidosis and other main things. But when they develop recurrent episodes of hypotension, the residual renal function may be lost. And as you all know, they may even develop thrombosis of AV fistula or graft. Thank you.
We looked at hypotension, the causes, outcomes and management in patients who are undergoing hemodialysis. We now move on to the other end of the spectrum, which is hypertension. So if there can be hypotension, there can be hypertension as well. Dr. Vivek will now talk about management of hypertension in patients undergoing dialysis.
Good afternoon. I'm Dr. Vivek Kaushik. I'm from Prashant Hospitals, Kolattur. I'm a consultant nephrologist. My topic is hypertension and dialysis, and I'll make it very short. I'll just tell what we need to know about this. So, what is hypertension during dialysis? The first thing is, at what BP should we call it hypertension? When we check a pre-dialysis and post-dialysis BP, or pre-dialysis and during dialysis BP, if there's a change of 10 millimeters, that is, if the BP is gone up by 10 millimeters, at least in 4 to 6 consecutive sessions, then we call it intradialytic hypertension or high BP. So why are we worried about this? So we are worried about this is because it has a high association of hospitalization and death in these patients as shown by studies. So we should be concerned about this particular problem. So why I am called to talk here is because of this scenario, where generally when there is a hypotensive patient in the dialysis unit, all the technologists and the nephrologists are behind that patient. They'll be giving saline, they'll be stopping ultrafiltration, one will bring a kidney tray, they will all be behind that patient. But when a patient is having hypertension, nobody goes near the patient, because we think hypertension is not a big problem, and after a dialysis anyway BP is going to settle, so we are not going to bother about this patient. So that should not be the attitude. The same care what we give to hypotensive patients, we should also give to hypertensive patients. I'll tell you why. So why BP shoots up during dialysis? It's because of multiple factors. One is because of blood vessel wall stiffness in dialysis patients. Second is elderly age. Patients who are elderly undergoing dialysis, because of vessel wall stiffness, they tend to get hypertension during dialysis more than patients who are at a younger age. Third thing is giving erythropoietin-like substances during dialysis will increase the blood pressure and also tend to cause hypertension. So, if you ask me to list the first 10 causes of hypertension during dialysis, the first 8 causes is bad dry weight adjustment. So, dry weight adjustment is the first important thing we need to do in patients with hypertension during dialysis. So, If a patient comes to the dialysis unit without any breathing problem or there is no edema, we tend to think that the patient is dry. And so we think that we should not remove fluid. That is a very common misconception among technologists as well as nephrologists. So this problem will be addressed only if we come to a proper assessment of dry weight of the patient. So dry weight adjustment should be done based on, not only based on edema and fluid overload or breathing difficulty. It should also be done based on BP measurements. Also to be, we have to clinically assess at a stage where patient develops hypotensive symptoms. For patient develop cramps. So we will have to bring down the blood pressure, we will have to bring down the dry weight to a stage where patient start to slightly develop cramps. So that is the dry weight of the patient. The weight just before that is the dry weight of the patient, not when the patient comes comfortably to the unit without any swelling. So this slide is already covered by Dr. Sudarshan. So both ends of the spectrum are bad. Excessive fluid removal and also very less fluid removal, both have their problems. So, but dry weight adjustment forms the cornerstone in treatment of hypertension during dialysis. So, next is checking BP during dialysis. These automated systems which are there in the dialysis machine as well as automated BP machines are validated for patients who are not having chronic kidney disease. So patients who have chronic kidney disease, these methods are not validated. For example, there is a big trial called a sprint trial which assesses hypertension in patients. In this sprint trial, they used a particular apparatus, Omron, which is being used widely for BP monitoring. This particular apparatus itself is not, automated device is not validated in CKD dialysis population. So the best method to check blood pressure in a patient on dialysis is manual method. But because there may be limitations in the form of manpower and other things, we can use automated systems to guide us. But always confirmation should be done by manual method. So this is one important thing. No edema does not mean no removal. So if a patient comes to the hospital with no edema, still the blood pressure is high, you should do removal. This is a study where they saw patients who came with no edema to the hospital, but they still continued to remove fluid for the next 8 weeks to achieve a dry weight. In those patients, the systolic BP reduced by 6.6 over a period of next 8 weeks. So this is very significant. So we should also try to achieve a similar dry weight. Next thing is, we should always advise patients to take less salt in the diet, because taking less salt will definitely cause less problems in terms of hypertension during dialysis. So this is a study where they compared two groups, where one group of patients took less salt and other group took normal salt in their diet. Both groups of people did not have edema or breathing trouble, but we see in the group which took less salt, the blood pressure is significantly less. So next is setting dialysate sodium. So standard dialysate sodium which we set in most machines is 140. Some units set even 142, 144 to make sure that the patient does not go into hypotension. But the problem is, if we set a higher dialysate sodium and if the patient's baseline sodium itself is not high, for example, if the patient's baseline sodium is 136, 138 and we keep setting a sodium of 140, these patients will develop hypertension. In this particular study, we see that they have two groups. In one group, they have set 140 sodium. In another group, they have set the sodium based on the blood test of the patient. If the patient has a 136 sodium, they have set 136, 138, 138. So in that patients whom they have customized according to the patient's sodium, the blood pressure is significantly less. Next is check the prescriptions of patients. there are certain medicines which are removed during dialysis, certain BP medicines. So those medicines are better avoided to be given just before dialysis if a patient has hypertension. So calcium channel blockers like amlodipine, nifedipine, these are very commonly used. These are generally not significantly removed during dialysis. So they can be given safely to bring down blood pressure during a dialysis session. So there is another debate which already was discussed, whether to take medicines or hold medicines before coming to the unit. So don't set the uniform protocol for all patients to not take antihypertensive medicines and come to the unit. It should be decided on patient to patient basis. If a patient continuously has hypertension during dialysis, please ask him to take his medicines and come during dialysis, and make sure those medicines which he is getting are non-dialysable. That the nephrologist will do, but then you should also be aware of what medicines the patient is taking. Last is dialysate composition and high BP. There are certain parameters like sodium. For example, if a patient is receiving a high calcium dialysate, sometimes the patient may develop hypertension, that should be checked. But other things like potassium, magnesium do not generally play a major role in blood pressure control during dialysis. Last is feed water quality. If the feed water itself contains a lot of sodium and calcium which do not meet the ARMI standards, then patient may develop hypertension. In this problem, we will see that all the patients in the unit have hypertension, so we can easily find out by doing a simple water assessment. And also, your work does not end where the patient leaves the unit. You should make sure he checks blood pressure at home as well. So make sure they have a documented blood pressure at home. At least on few occasions they'll have to check blood pressure at home. If a patient has blood pressure problems regularly, a ABPM has to be done. So this is one common problem we see in the dialysis unit. We go for rounds in the dialysis unit. We ask the technologist why the BP is high, why is it 180, 100? The answer is immediately, till 5 minutes back BP was normal, sir. That can never happen. So blood pressure will always increase gradually only. So most of the occasions, around 60 to 70% of the time, the blood pressure increase is gradual. We have missed the blood pressure measurement over the last 2-3 hours, and that's why the BP has gone up now. So always monitoring the patient is the most important thing to do during dialysis to prevent hypertension related complications. Last is, it's a 4-hour dialysis session. You can watch Instagram for a couple of minutes, it's okay. But then please check the patient's BP also once in a while so that he doesn't land up in problems. So your role in managing hypertension is, be diligent, please meticulously maintain a BP chart. Be observant, keep looking for signs of hypertension in the patient. If they complain of giddiness, headache, these are very important measures of BP changes. Next is, teach the patient to take less fluid and less salt during every dialysis session. Last is, along with the nephrologist, please help set the dry weight of the patient and keep a proper ultrafiltration during every session of the patient. Should we stop heparin when BP is high? This is a very standard protocol in most centers where heparin is cut during a high BP. It is not wrong to cut heparin during high blood pressure. When patient has a blood pressure more than 160, it is okay to cut heparin. But then this is generally based on certain score called Has-Blood score. When patient has hypertension, abnormal renal function, see already patient has abnormal renal function, that's why he is on dialysis. That one score is already there. When you check the other score, if he is elderly and if his BP is shooting up now, if the score goes more than 3, you should have a very low threshold to stop anticoagulation during dialysis. That is, when BP shoots up more than 160 itself, make sure you cut down the heparin. Thank you.
Thank you, Vivek. That was a really nice session on management of hypertension among patients who undergo dialysis. I'll just summarize our whole session in less than 5 minutes. I won't take too much of your time. To start with, hemodynamic stability is the key for a patient to have a good, adequate dialysis session. So be it hypotension or hypertension, there will be disruptions in treatment that can in turn lead to reduced adequacy of dialysis. And also blood pressure management is something we often struggle with. We try to keep an optimal blood pressure range, but we end up going to the extremes. If you heard two words very commonly, you would have heard mortality, morbidity, cardiovascular mortality, cerebrovascular morbidity also. So every single patient who undergoes dialysis, his or her long-term health depends on the dialysis technologist who handles that patient. Your role is that important. And then a few things is BP monitoring is very, very, very important. How do you choose to monitor it? Different units can have different methods. Some may use automated, some may use manual. I will leave it up to you. ABPM may be the best, but the practical part is we have to stick to picking up that machine, going to our patient and checking our patient's BP. Number two, how frequently we monitor. 30 minutes is a rough estimate and it's a good time to monitor BP regularly. However, please use your instinct. If your patient does not look okay, check the BP more frequently. Number three, special situations that I'd like to touch upon is somebody who has autonomic dysfunction. Many of you may see patients who are diabetics on dialysis. Something very peculiar to these diabetics is they may have high blood pressure on lying down, but when you make them stand up, their blood pressure drops. So setting your ultrafiltration sometimes may be tricky in this subset of patients. Think about this condition called autonomic dysfunction among diabetics. So even if there is a high blood pressure to start with, they are prone to hypotension. Another situation is patients with multiple vascular access failures. You know, you may encounter patients with a fistula on the right arm and a failed fistula on the right arm, a failed graft on the left arm, and finally, or a perm cath in the thigh area, they may be having dialysis. So in these patients, how do you monitor blood pressure? For all you know, there may be some thrill in that arm. So when you have multiple vascular access failures in a patient, you end up monitoring the leg BP. So many of us will be familiar with monitoring the hand blood pressure, but leg blood pressure monitoring also, when you're in training, it will be a better thing, because leg blood pressure, there are certain things, it will be higher than the hand blood pressure. The technique is also very important. So autonomic dysfunction in diabetics and multiple vascular access failure patients, please be a little cautious. And then Vijayshri beautifully spoke about hypotension and how it's very important to pick it up. Prevention is better than cure. And like Vivek said, blood pressure does sometimes drops suddenly, but most of the times there will be a decremental trend. If we fail to pick it up, it will be very bad for our patients. So letting him go to a state of unconsciousness and then resuscitating a patient is much worse than picking it up early and just stopping ultrafiltration or putting them in a Trendelenburg position, which is very simple. And one more thing, if there is recurrent hypotension, you've done everything. You monitor blood pressure, you talk to the patient, counsel them for reduced interdialytic weight, they are coming on a salt-restricted diet, they have some cardiac issues, they don't tolerate regular dialysis, we can switch them to hemodiafiltration. That's another modality that offers benefits in patients who have recurrent hypotension. And then there was a beautiful cartoon when it came to hypertension that Dr. Vivek showed. We'll often tend to group around patients who drop their blood pressure, but equally important is to go and see the patient who also has a very high blood pressure. Because in no point of time, if we don't turn off the heparin sometimes, they may end up with a cerebral bleed. So again, hypertension is as important as hypotension. Hypotension may be dramatic, hypertension may be asymptomatic, but it is our duty to keep track of both these pressure ranges. And last but not the least, Vivek summarized it beautifully. Please be diligent, please be observant. How keen you are in picking up hypotensions or hypertensions reflects on how good a technician you are. So also be a partner. It is not nephrologist versus the technician, it is nephrologist and the technician, and we work for only one thing, to keep our patients healthy and safe. So we are a team. if you pick up something and bring it to the attention of the nephrologist, it helps much more, because you are like the frontline soldiers. You are there with your patient, talking to your patient, knowing your patient, whereas your nephrologist comes into the dialysis unit and leaves after a point of time. So be diligent, be observant, be a teacher. Teach your patients about how to manage their blood pressure, and be a partner with your nephrologist. Together we work to keep our patients safe. Thank you.
Thank you, ma'am and sir. Now I invite Mr. Ruben, Vice President STDP, to present the mementos to the panelist and moderator. We'll be taking a lunch break now. Please proceed to the dining area and join us back for afternoon session. Kindly come back soon, everyone. Students, kindly assemble inside the auditorium. Everyone, please be seated. All the students kindly assemble inside the auditorium as the next session is about to begin. Once again, I request all the students to kindly assemble inside the auditorium as the session is about to begin. Once again, I welcome you all to the SDTPCON 2025. We'll now begin the post-lunch session. Before we begin, we would like to acknowledge the support of our sponsor. Please take a moment to listen to their message.
I coordinately invite Dr. Sandhya Suresh ma'am, Associate Professor, Department of Nephrology, SRMC, to benefit the audience on the topic of hemoadsorption.
Okay. Good afternoon, everyone. I'm Dr. Sandhya Suresh. I have the unenviable task of presenting to you everyone after lunch. I'm sure all of you will be feeling a little bit sleepy, but I will try to keep you awake for this session. This is an important session because I'm sure all of you must be having very good exposure to hemodialysis and plasmapheresis in your institutes. But not everyone would have been exposed to this hemadsorption or hemoperfusion. This is something which is a little unusual, but as the years go on, this is going to be something which is going to keep evolving. It's going to become a big thing in the future and something that you will be using very commonly. So I think all of you should be aware of it from the beginning itself, so that as the years go on, you will be able to handle patients who are being put on hemoperfusion. So what is hemadsorption? So hemadsorption is a method of blood purification where the blood is actually comes in contact with resins, and whatever toxins and whatever molecules that you want to remove gets adsorbed, or basically it sticks to the resin and it gets removed from the blood. So you're passing it through it's not like dialysis where the blood passes through a filter and it comes out through the filter. The molecule comes out through the filter. Here it's not coming out anywhere. It's just going to get stuck to those beads, and the blood is going to carry on and go back to the patient, while the molecule is going to get stuck to those beads or the resins in the beads. So these are the common extracorporeal blood purification techniques. You already know hemodialysis, hemofiltration, you know about plasmapheresis. Now we have this called hemoadsorption. Here we are only removing the certain molecules which are present in the blood, which are going to get adsorbed to these the resins. We are not going to filter anything out. We are not going to remove plasma like in plasmapheresis. There is no need for any replacement solution. There is no need for any dialysate in this setting. So this is a hemadsorption that you can see the cartridge here. So when we are doing blood purification, how do we select which modality we want to use? It depends upon multiple factors. So the most common factors that we need to know about are the molecular weight. So for dialysis, we know that normal hemodialysis, the regular hemodialysis that we do, will remove small molecular weight solutes like creatinine, urea. So these are going to get removed in dialysis. So these are getting filtered out from the blood, and this is by using something called as a dialysate. Whereas here we are not going to use any dialysate in hemoperfusion. So larger molecular weight substances, either you need to use hemofiltration, you need to use high cutoff dialysis, or we can use these hemoperfusion cartridges for this purpose, especially if they are protein bound. Protein bound molecules are not going to get removed in hemodialysis. So you need some other methodology for that, and hemoperfusion may be one method which will help in removing protein bound molecules. Then the other thing is the half-life of the molecule which is present in the circulation and the volume of distribution. If a molecule is going to be present in the blood only, you can remove it. If it is going to go from the blood and get distributed all over your body, into your fat, into your muscles, in that case it is not going to get filtered out by your any form of extracorporeal therapy, whether you are doing hemodialysis, hemoperfusion, in anything. When the volume of distribution is large, that is when it's not only in the blood, it goes outside the blood rapidly and gets distributed throughout your body, you are not going to be able to filter it out. So there you will have to use other modalities. And of course, the last thing would be clinical experience. We need to know what the studies are saying, so that we will come to later. So So this is the timeline of hemoperfusion. So when you, how many of you have done hemoperfusion? A show of hands, please. How many of you have done? Okay, so it's hardly 10% of the audience has done hemoperfusion. So hemoperfusion, basically you will have a cartridge which is similar to a dialyzer, but inside that there will be a lot of beads. It will be like small pieces of chocolate if you see, that's how it will look like, the beads. And the blood flows through those beads and the molecules are going to get stuck to those beads and removed from the blood. So that is hemoperfusion. So what do those beads contain? Initially they used to use anion exchange resins. Then they use charcoal. Now we have these special resins, microporous resins, which are part of the modern hemoperfusion cartridges. So the initial cartridge that we used was charcoal. So charcoal used to come from, it's very commonly used from coconut shells. So if you heat the coconut shell and then you get the powder from it, so that is how they generate activated charcoal. The disadvantage of charcoal is that it's not biocompatible. So you know that when blood passes through any membrane, it should be biocompatible. Otherwise there will be reactions and the blood cells will get destroyed. So generally charcoal has low biocompatibility. The other thing is pieces of charcoal can come out from these beads and it can go into the circulation and cause embolism. So these are the disadvantages with charcoal. So now we have the second generation resins. So these are usually double cross-linked styrene divinyl benzene copolymers. So these are the modern resins. They are more biocompatible than charcoal, and they form a lot of flexible networks. So the blood can go between the pores of the resin. Come to the next slide. So this is how a cartridge looks like. You can see those small brownish balls. They look like these nutties chocolates that you would have seen. So that's how the ball will look like. It's a little bit smaller than that. And there will be multiple such beads which will fill about 50% of the entire volume of the cartridge. So the blood then goes inside this. So the blood has to go inside this cartridge in between these beads. So when you look at it, you think it looks like a solid mass, but it's not really solid. It looks like a sieve. It's very porous. So the blood can actually go in between the pores of the beads. It's not just going, if you can see here. So the blood has to go inside the beads. It's not working. Yeah. So you can see that these are the beads. The blood is going around the beads. It's going this side, that side, but it's also going inside the beads, in between the pores of the beads. So that's how you get the you get a very large surface area. So even though that the balls are very small, these spheres are hardly about less than a centimeter in diameter, but the surface area for hemoabsorption or hemoperfusion is very large. It's almost 1 meter square, it will be almost 1000 meters square per gram of these polymers. So this is how it looks like. So what are the situations in which you will use it? You will use it in poisoning, because you have to remove certain toxins which will not be removed in dialysis. You can use it in sepsis to remove the cytokines. You can use it in liver failure to remove the toxins which are usually removed by the liver but which are going to accumulate in the body. So these are the conditions where you will need to use these hemoperfusion resins. So this is where how you will connect it in a circuit. So you have the patient, the blood is coming from here, the blood pump. You can connect it in as you connect a regular dialyzer. So here there is the sorbent cartridge is here and the blood returns back to the patient. You can connect it in series with a dialyzer or with a CRRT filter. So the blood comes, it goes to the filter and then goes to the dialyzer or the CRRT filter. You can keep this sorbent either before or after the dialyzer. Suppose you don't want it to be done on the blood, you want it to be done only on plasma, you can connect it to a plasma filter. Whatever plasma is coming out can be passed through this hemoperfusion cartridge, and then that plasma is now returned back to the patient. So normally in plasmapheresis, what do? We remove the plasma and we give extra plasma to the patient. Here, the same patient's plasma can undergo filtration through this hemoperfusion cartridge, and then the same plasma comes back to the patient. So we don't need to give other persons or a donor plasma in these conditions. And this can also be done with a dialyzer or a CRRT filter. So all of these is connected in series with a dialyzer or a CRRT filter. So the first thing would be poisoning. So I'm sure a lot of you would have been seeing some poisoning cases, at least all of those of you who have done hemoperfusion, most of you would have done it in the setting of paraquat poisoning. So in India, most of our poisoning comes in farmers. So all of them take these pesticides which are commonly used, like organophosphorus, paraquat. So all of these normally cannot be removed by hemodialysis. So for this you need special techniques. One of those is hemoperfusion. So this is the HA230 filter that we use for paraquat poisoning, and this has a surface area of 32,000 meters. Can you see this? It's 32,000 square meters, whereas the cartridge is only this small in size. But the pores, but the beads are such that with so many pores that the surface area overall is more than 30,000 meters square. So that can be used for any pesticides, herbicides, any drug overdoses, industrial toxins, heavy metals like thallium, all of these it can be used for. And the efficacy depends upon how long you use it. You can use it for up to 4 to 6 hours. If you use it for more than 6 hours, it loses efficacy because it is already equilibrated, and there is no more, there is a chance that the toxin can get released from the beads. So that is why we use it for only about 4 to 6 hours. What about the blood flow rate? If you keep it too slow, it will get clotted. If you keep it too fast, you are not giving enough time for the molecules to bind to the resins. So you should generally keep it around 150 to 200. And the treatment duration, as I already said, is around 4 to 6 hours. We have to do frequent sessions because the problem with toxins is it will be there in the blood. You will remove toxins, but whatever would have got absorbed would have also have gone into your muscles and fat. So from the muscles and fat, it will come back into the bloodstream. So after 6 hours, there will be again rebound of these toxins. So that is why it may be necessary in many settings to do repeated episodes of hemoperfusion. And what about the side effects? I already told you that there is a biocompatibility issue. Thrombocytopenia can occur in patients with hemoperfusion. You can have anaphylactic reactions, you can have hypotension. So it's important to always monitor the blood pressure even when these patients are on hemoperfusion. And so what about the poisonings that we use it for? Commonly we use it for paraquat poisoning only in our center, but you can use it in others like organophosphorus. Organophosphorus is it binds to the proteins and it causes mainly respiratory failure. There are certain treatments for organophosphorus which are commonly used. Patients can be ventilated. You can give cholinergic agents which would help in treatment of these organophosphorus poisoning. But it has been shown in some studies that repeated episodes of hemoperfusion can help in early recovery of these patients with organophosphorus poisoning. So this is one study where they tried only one hemoperfusion, and in another group of patients they tried 3 to 4 times hemoperfusion over a period of 3 days. And overall both the groups had good survival rate, but the survival rate was around 80% in the single hemoperfusion group, around 100% in the multiple hemoperfusion group. So it was thought that early repeated hemoperfusion can be more efficient than single hemoperfusion in patients with severe organophosphorus poisoning. So in milder cases, mostly the common treatment like atropine might be enough, but in very severe cases, it may be useful to try this hemoperfusion. All of these are all mostly retrospective studies, so we need more evidence, we need more usage of these. It would be helpful in very severe cases where it may help in early recovery from respiratory distress. Then paraquat. Paraquat is a very dreaded word among nephrologists or any emergency physician. The moment we hear paraquat, we should run to the emergency department and make sure these patients are started on hemoperfusion or hemodialysis. If hemoperfusion is not available in your center, at least do the hemodialysis, because the mortality is almost 100%. If you see here, this is mortality data from India. All of these are Indian studies. Most of our, many countries have actually banned paraquat because it is so toxic. But in India, it is a very cheap pesticide and it is commonly available. Almost all the farmers and students and young persons who take this, who take these poisons would be taking paraquat because it is commonly available over the counter. You go and ask in any shop for Puchi Marandu, this is what they will give. They won't ask why they are giving it, whether it is actually for pesticide or whether they are using it to try to commit suicide. But it should be known and it should be told to every person in every farming community especially that paraquat is such a toxic agent. If they even take 5 ml of it, it can be 100% fatal. Whatever we do, the patient would die. One of the modalities which has shown some benefit is the hemoperfusion. We also have hemodialysis and CRRT. Both of these can also remove paraquat to some extent, but all of these will help only if it's done early. So time is of essence. So if a patient with paraquat comes, run to the ER, make sure we secure a line. Don't wait for anything. Don't wait for bleeding parameters. Don't wait for the viral markers. Try to secure the line, get the filter as early as possible. Try to get the, that's why we always keep a hemoperfusion cartridge in our pharmacy. It should be available as soon as such a patient comes. It should be given to us. At that time, we can't be calling and ordering the filter at that time. So it has to be available in every pharmacy. At least one hemoperfusion cartridge should be available. What does paraquat do? It is one of the worst methods of dying that I can tell you, because from first-hand experience of having seen patients, if you see that these patients will be drowning in their own secretions. It is basically causes free radical based injury, causes a lot of damage to the lungs. So the patients will keep on having secretions, then they slowly start going into multi-organ failure. So they'll have liver injury, renal injury, and ultimately the patient would die whatever we do. So almost 100% mortality. This is including our data. Our data from SRMC is almost 80 to 85% mortality. So if you have 100 patients with paraquat poisoning, we would have saved some 10 to 15 patients only. And this is in spite of having the maximum possible treatment, including hemodialysis, hemofiltration, CRRT, everything being available in our center. Apologies, I think there is an issue with the audio visual. So coming back to paraquat. So when do we do the hemoperfusion? As I said, start it as early as possible. Now we do the serial hemoperfusion. Even in our center, we are doing serial hemoperfusion. Once the patient comes, we would try to start it as early as possible. Then we do one more on the same day, and then we repeat it once a day for the next 2 days. So this is how we plan it, and this was a study where they compared hemoperfusion, where they did like what I was saying, 4 sessions over 3 days, compared to hemoperfusion with CRRT, along with, and the third group was no hemoperfusion or CRRT. So they found that, as you can see, all 3 groups survival was less than 50%. So that is a very dismal survival. All 3 groups had less than 50% survival, but it was slightly better, around 10 to 20% better in the hemoperfusion and CRRT arm compared to the arm which did not receive any hemoperfusion or CRRT. And as I told you, time is of essence. So if you start the hemoperfusion within 6 hours, the percentage survivors were 94%. If you started it after 6 hours, the percentage survivors are only 14%. Overall survival in this study was actually very good. 56% is probably a very good survival rate for paraquat poisoning, but that is probably because they had so many patients who presented within 6 hours, and not just presenting within 6 hours. We should be able to start the hemoperfusion within 6 hours. If you don't have a hemoperfusion cartridge, at least start dialysis. You can get the hemoperfusion filter and then do that later also. And what about the tests that we do in case you have a doubt whether the patient has taken paraquat or not? Some patients would just say they took some poochi marundu, but they won't know what it was. And then somebody will have to go find out from the shop, take a picture and come. That will get delayed. So we should always have this bedside test available called as the sodium dithionate test. So it just requires 2 specific chemicals, that is the sodium hydroxide and sodium dithionate. So this can be obtained from our biochemistry labs, and this test can be done in the urine, can be done within 5 minutes, and if that is positive, you know that the patient has consumed paraquat. And as soon as that is positive, you should start the hemoperfusion or hemodialysis if hemoperfusion is not available. And in this study, they found that whenever they did this test and immediately started the hemoperfusion, they had about 40% survivors, which is again a good number. So this is the urine sodium dithionate test. So this is, if it is negative, the urine will remain the usual yellow color. The more blue it is, the more positive it is. So you can see these examples. So this is a negative test. This is again negative. So these are all positive, where you can see that bluish tinge. Even that slightly greenish tinge is also positive. So in our center, what we are doing right now is we keep doing the hemoperfusion till the patient's urine becomes negative. Until we get this light yellow color, we keep doing the hemoperfusion. We repeat the urine dithionate test around 6 hours after the hemoperfusion, because we need it to come. We need the urine, the paraquat to come back into the bloodstream, and then so we give it time to increase in to rebound after the hemoperfusion. So about 6 hours later, we repeat the urine dithionate test. If it is positive, we do one more hemoperfusion after this. So this is how we do the paraquat poisoning, hemoperfusion paraquat poisoning. There are certain things that you have to know. When you get that filter, you should put around 25,000 units of heparin directly into the filter, shake it 10 times, that is just rotate it 10 times, and then keep it on a flat surface for about 30 minutes. So it has to get coated, the heparin, otherwise you would have clotting in the system. And for priming, after about 30 minutes, we should prime it with at least around 3 liters of saline. So these are things that you need to follow. So this itself will take half an hour for you. So as soon as we have a patient with paraquat, we should make sure that the filter is available. And at least 3 to 4 sessions should be done. Max, they say about 8 hours, but we generally don't keep for more than 4 to 6 hours. And we can run it along with hemodialysis. Suppose a patient is in renal failure, we can run it along with hemodialysis. Suppose patient has severe acidosis, hyperkalemia, we should know that the hemoperfusion doesn't correct the small molecular weight solutes. It doesn't correct electrolyte and
acid-base disturbances. So you can connect the hemoperfusion cartridge along with in series with the dialyzer, and you can do hemoperfusion plus hemodialysis or hemoperfusion with CRRT, whichever is required according to the patient's indication. And along with that, we also give steroids and cyclophosphamide. So these are things that should be, this protocol should be available in every emergency department, every hospital of the country, because paraquat commonly is taken by farmers, and many times the patients don't come to tertiary centers like ours first. They first will go to some local PHC, some local community health center, and then only they will come here. So at least this part of the treatment should be initiated. And the other thing is drug overdoses. You know, many drugs are actually dialysable. So you can just do hemodialysis for many of the drugs which are consumed, like carbamazepine, barbiturates, benzodiazepines, common drugs that patients will overdose on. So you can do hemodialysis or hemoperfusion. Earlier they used to say hemoperfusion is better than hemodialysis, but that was all for the low flux dialysis. Now we are having high flux dialysis. So hemodialysis should be as good as hemoperfusion. So don't hesitate to start hemodialysis in these patients. Don't wait for the hemoperfusion cartridge. You can start off the hemodialysis and then do hemoperfusion if you are not finding adequate response. Certain drugs where it may help for hemoperfusion would be, one is methotrexate. Methotrexate has a specific antidote called glucarpidase, but it may not be available in all centers. So for methotrexate poisoning, hemoperfusion would be helpful. Barbiturate poisoning, again hemoperfusion is barbiturate and carbamazepine. These are two drugs where it is thought that hemoperfusion would be better than hemodialysis. So whenever you have a drug overdose patient, we need to look at whether it is dialysable or not, and also whether hemoperfusion in those cases might be more helpful for than dialysis. In those patients, the HA230 filter can be obtained and can be used. Then another setting where the hemoperfusion is more useful than dialysis is wasp sting. I'm sure all of you would have seen a lot of koravis around everywhere, but we don't commonly come across it, but it can be very dangerous. It's a very life-threatening thing. If they have a severe reaction to a wasp sting, it can be life-threatening. So in those conditions, they have found that hemoperfusion is as good as actually plasmapheresis when combined along with CRRT in patients who have severe poisoning. Next thing is snake bite. In snake bite, before thinking of any hemodialysis or hemoperfusion, first, second and third treatment will always be ASV, anti-snake venom. Make sure you give anti-snake venom for all patients. They have to be given adequate ASV. But in certain settings, it may be useful to use this hemoperfusion cartridge. Certain unknown snakes may not be covered by the ASV. So in those cases, in severe cases who are not responding to the ASV, there are some studies which have found that this hemoperfusion can help. So it can be used as an adjunct to the ASV. So this is what they found, and they found that there was not any major side effects of using the hemoperfusion cartridge. So if patients are not responding well to ASV, they have very severe toxicity features, this is something that we can add on as part of the treatment. And this was in heavy metals. I told you already that a lot of heavy metals are there, thallium, mercury. Again, they have their own antidotes, but if they are not getting removed adequately, hemoperfusion can help in reducing the concentrations of these agents. So this is the rule of thumb: start early as early as 4 to 6 hours. It's not effective after 12 hours. So if the patient comes after 12 hours after a paraquat poisoning, you know that the prognosis is going to be very, very poor. Then you have to use at least 3 to 5 cartridges in a patient, and use even 2 cartridges in a day. So don't be conservative. You can use 2 cartridges in a day. And overall, it helps in pesticide poisoning, rodenticide, biotoxins, drug overdose, and try to start 1 to 3 times in a day and as early as possible again. And the next setting where it is useful is sepsis. You know that if you go into the ICU, nearly 50 to 60% of the patients you see would be sepsis. Many of them may not respond to conventional therapy with antibiotics alone. They will be on a lot of inotropes. You will be starting CRRT, and patient will still be doing badly. In those cases, it may be because these patients have a lot of cytokines in their blood. All of you know that cytokines are the ones which are toxic. Cytokines are protective also, but in cases of sepsis, you can have an abnormal inflammatory response, and these cytokines, all the toxic cytokines, what we call as the pro-inflammatory cytokines, start damaging our own body. And that causes a lot of multi-organ failure, causes liver failure, causes kidney failure. So all of these are due to the cytokines which are circulating in the bloodstream. So we need to remove these cytokines. But the problem is cytokines are large molecules. They cannot be removed by regular, the conventional hemodialysis that we are doing. To some extent, they can be removed by large volume hemofiltration, the CVVHF. No? As when we're doing CRRT, if we can increase the replacement fluid component, that can remove some cytokines to some extent. But they can also be specifically removed by these adsorbing agents which are present in these hemadsorption resins. So you can't use the HA230 here, you have to use a slightly bigger cartridge in this case. So as I already told you, so all of the problems in sepsis are mediated by these cytokines. So you have these, on these immune cells and on these microorganisms, you will have these danger associated molecular patterns. Those will be recognized by our own immunity, and our own immune cells will start producing these inflammatory cytokines which will start damaging our own body. So it is called as a dysregulated immune response. So what can we do in patients with severe sepsis? One is you remove the microorganism, you give antibiotics. The next thing that you can do is remove the endotoxins. Endotoxin filters are now available in the dialyzer itself. You would have seen Oxyris and all you would have heard of. So endotoxin filters can be used to remove these endotoxins from the circulation. Then the next thing that you can do is remove the leukocytes. That is difficult because you need the leukocytes as a protective agent as well. And the last thing is to remove the cytokines from the blood, and that is what we are doing through hemoperfusion. So normally, in a normal condition, you will have both pro-inflammatory and anti-inflammatory cytokines. So when you are removing that, you will remove both. So normal conditions, we don't want to remove both the pro and the anti-inflammatory cytokines. Whereas in cases with severe sepsis, where there is a lot of pro-inflammatory cytokines causing damage, you can, when you are doing the hemoperfusion, it will remove more of the pro-inflammatory cytokines because there are more of these cytokines in circulation. So that is the concept behind using hemoperfusion in patients with severe sepsis with a dysregulated immune response. So this is the filter that we use. We use the HA380. This again contains the same the double strength styrene polyvinyl benzene, which is also present in the similar filter called a cytosorb that you would have heard of. It also contains polyvinyl chloride. So these are all just synthetic resins which will adsorb these cytokines. So what are the settings that we have used it in? Sepsis, septic shock, you use it in severe pancreatitis. During COVID, it was very commonly used in patients with severe COVID. These filters, these hemadsorption cartridges were being tried in patients who are not responding to anything else. So when do we need to do this? Because cytokines are large molecules, almost 10,000 to 60,000 kilodaltons. So they can't be removed by regular dialysis, and that is why we are doing these hemoperfusion techniques. So what are the parameters which can improve? Whatever studies we have so far, we have found that it doesn't really improve the mortality that much. When you use a hemoperfusion filters, all of the studies, no real study has shown so far, hasn't shown definite mortality benefit. What it has shown though is improvement in hemodynamics. So the patients on hemoperfusion, the mean arterial pressure improves, their respiratory function has improved, all the cytokine levels have all reduced with hemoperfusion. So far we don't have good mortality data, probably because studies are all very small studies, and it's all being started very late. So probably with early institution of CRRT along with this hemoperfusion cartridges, we may be seeing positive benefits in later dates as we do more and more studies. So this is one of the, there were two major RCTs which were done with the HA380 filter. The first one was in sepsis, and here they found that there was a, you can see that even though that there was no mortality difference, there was a decrease in these cytokines. So I already told you pro-inflammatory cytokines, the cytokines which are bad for us, IL-1 and TNF alpha. So those showed a significant reduction when we did the hemoperfusion compared to conservative management. And they also found better organ function and hemodynamics, improvement in the oxygenation, so the better PaO2, reduction in the PCO2, so respiratory function and respiratory parameters were better after the hemoperfusion. And in terms of overall mortality, there was no difference, but they found there was a reduction in the ICU mortality. So in the hemoadsorption arm, it was 24% compared to 57%. 28-day mortality was also lower. Really, there is no explanation why the overall mortality was not lower, was not significantly different, but probably because there is a lot of, the problem is the patients can't be recruited evenly. All of these are very sick patients. There is no one size fits all. But probably with early institution of hemoadsorption along with CRRT can help, and not till the patient goes on to 2 and 3 inotropes and then we start these therapies. It may not really help in these patients. That's why we are seeing very high mortality rates across both the groups. And this was a second study, again in septic patients. They found again there was a reduction in the IL-6 and IL-8 levels. And in terms of hemodynamics, all of these patients had better mean arterial pressure, better heart rate control, better cardiac index. All of these were better after hemoperfusion compared to conventional therapy. And in terms of ICU outcome, there was the length of hospital stay was shorter in the hemoadsorption group. ICU mortality again was almost 1/3 of that noted in the conventional therapy group. So now we have the Indian guidelines on when to use extracorporeal hemoadsorption technologies. And what they say is, in severe refractory septic shock patients who are not responding to anything else, we need to use these adjunctive therapies. It should be started as early as possible, but at least within a maximum of 24 hours. So within 24 hours, after we start therapy, it should be started. Earlier, in COVID, they used to do this IL-6 levels and then start this hemoperfusion. Now they have told that it's not necessary to wait for IL-6 because it takes time. It may not be available in our labs, so no need to wait for that. And you may need to use more than one hemoperfusion cartridge. You may need to use 2-3 in a day. You may need to extend it for 6 to 24 hours. And you look at the efficacy not just by mortality, you look at whether there is hemodynamic stabilization, whether the respiratory parameters are improved, oxygenation is better, ventilatory requirement is lower, all of these, and SOFA scores. All of these should be better after hemoperfusion. So this is the algorithm that we follow. As soon as patient has septic shock, we start the standard therapy. If there is improvement, then we only continue standard therapy. But if there is no improvement of hemodynamic stability, the patient requires more and more inotropes like vasopressin, noradrenaline, and there is a high IL-6 levels, then you try to start this hemoperfusion, either with cytosorb or HA380, depending upon the cost and the availability in that center. And then we look at the clinical response. If there is good clinical response, then you continue that filter for about 6 hours and then again use new filters. You keep replenishing newer adsorbers. And if there is no improvement at all, then we can consider discontinuing these agents. So this should be used as an adjunct to refractory shock. Next is liver failure. This is the last part of the presentation where we are using it in liver failure. We have used it for one patient in our center so far, but we had good results in terms of reduction in bilirubin. So you know that in liver failure there will be increase in ammonia, bilirubin, bile acids, and generally the liver failure there will again be increase in the cytokines. So these cytokines are the ones which are driving the liver injury. So you need to remove the bilirubin and you need to remove the cytokines as well. So we can do molecular adsorbent system, so that is the MARS system, which may not be available in all centers. So now we have got this double plasma molecular adsorption system, and that uses 2 cartridges. One is for bilirubin and bile acids, and the other is the similar resin cartridge HA330, which removes these cytokines from the circulating blood. So this again, the HA330 is the same styrene divinyl benzene copolymer, whereas the bilirubin filter is basically an anion exchange resin. So you know that bile acids and bilirubin are negatively charged, so you need something which will go and stick to it. Just a moment, where is this? So these are the commonly used ones. You have MARS, which may not be available and which are expensive. Then we also use plasmapheresis. So commonly used thing is therapeutic plasmapheresis and high volume plasmapheresis in patients with liver failure. But here you need to replace that much volume of plasma. For high volume plasmapheresis, you need to use at least 2 volumes of patient's plasma. So that will be roughly 80 ml per kg. So if you are removing 80 ml per kg of plasma, you need to replace that much of, you will need to use at least some 6 albumins, you will need to use around 1 or 2 liters of FFP will be required in high volume plasmapheresis as replacement. So that itself is a very difficult proposition and it's a very costly affair. You can have plasma related adverse effects, plasma infusion reactions. So all of these can happen when we are doing high volume plasma exchange in liver failure. So this is one alternative, which is the DP mass, which where you don't need to give extra plasma, you can just return the patient's own plasma after removing these toxins from the plasma. So this is how it is connected. You have the blood coming through into a plasma filter. Then the plasma gets filtered out. It goes through one sorbent. It goes through the bile acid sorbent and then bilirubin filter, and then it goes into the HA330, which is the regular polyvinyl benzene filter, and then that same plasma goes back into the patient, into the venous line. So you don't need to give any extra plasma to the patient. There is no need for albumin, no need for plasma. So you are saving on the cost of those. So this is how that bilirubin filter works. So it basically attracts the negatively charged bilirubin to the surface. But we need to remember here it is a cation. So this is a positively charged molecules inside. So any negatively charged molecule goes into it, it's going to get attracted to it and is going to get attached to these the resins, and it's going to not be removed from the blood which goes in, not the blood, plasma. Why I am saying plasma again goes into it, because ideally you should not put blood RBCs are negatively charged. So if you pass blood into this filter, into the bilirubin filter, the RBCs will also get stuck to it. So ideally they should not be connected to the blood stream, it should not be connected to the blood line. After plasma filtration, it should be connected to the plasma line which comes out from the plasma filter. So this is how it is connected. So you have the plasma filter. Whatever plasma is coming out has to go into this bilirubin filter and this plasma goes back into the patient's venous line after removing bilirubin and bile acids. So this removes only bilirubin and bile acids, does not remove any cytokines. And this is for the HA330. This will remove the cytokines from the circulation. This can be connected directly to the blood of the patient. So if you only want to remove cytokines from the circulation, that will improve the liver injury parameters, then only this can be used. If the patient doesn't have very high bilirubin levels are less than 10 times the normal limit, then only HA330 can be used. But if the patient also has very high bilirubins, more than 10, then you have to combine both these things. So this is how we do the DP mass. We connect the arterial line to the patient, to the plasma filter. From the plasma filter, plasma is going to get filtered out. It comes through the bilirubin filter. From the bilirubin filter, it goes to the HA330 cartridge, and then it goes back into the venous line of the patient. So how we did this in our center was, you can either do this with a CRRT machine, or you can do this using two dialysis machines. So you'll have to keep 2 dialysis machines so that you have 2 pumps. So one pump for the blood and one pump for the plasma. So this is how we did the DP mass in our center. We kept 2 dialysis machines and we kept a plasma filter, and you need these 2 filters. The overall cost will come to around 1.5 lakhs with all these filters combined. But the advantage here is we are not going to require any extra albumin or free FFP in these patients. So when do we use it? Any acute liver failure, any obstructive hyperbilirubinemia, patients with hepatic encephalopathy, all of these it can be used. Again remember, this is not going to correct acid-base imbalance, not going to correct electrolytes. So in case the patient has severe acidosis or very high ammonia levels, in those cases you may be preferably also adding on a hemodialysis or a CRRT for these patients. So what are the studies which have been done? They have mainly compared therapeutic plasma exchange with the DP mass, And they found that they had comparable efficacy in terms of removal of bilirubin. If we are doing high volume plasma exchange, DP mass is comparable to it, but it is definitely better than the regular therapeutic plasma exchange that we do with the single volume plasma removal. If we are only removing 40 ml per kg of plasma, then the DP mass might remove more bilirubin compared to the regular low volume plasmapheresis. So this is how they compared. They found that the levels of the cytokines and the levels of procalcitonin, CRP, HSCRP, all of these were better with DP mass, less loss of albumin with DP mass compared to plasma exchange. And in terms, as expected, less allergic reactions because with plasmapheresis we are going to give FFPs. FFPs will cause reactions, so that was not noted in DP mass. So both are safe and effective options, and although the therapeutic plasma exchange has overall better, when we are doing high volume plasma exchange, overall it has better cytokine removal and better improvement in inflammatory markers. You need large volumes of FFP, there is risk of plasma allergies, risk of transmission of viral infections. So all of this has to be kept in mind, where the DP mass is better than the plasma therapeutic plasmapheresis. So main complications, again clotting of the circuit, you can have thrombocytopenia, reactions even to the resins which are present. So these are the things that can happen. And of course it will remove some antibiotics, so always make sure that the dosing of the antibiotics is adequate when we are doing any form of extracorporeal blood purification technique, especially in patients with sepsis who require antibiotics. Make sure that you are giving an additional dose of antibiotics along with any of these blood purification techniques. So whenever there is a patient with severe liver failure, the DP mass can help to reduce the bilirubin by around 20-30%. There can be improvement in neurological outcomes in terms of hepatic encephalopathy. There is reduction in the bile acids and bilirubin, so reduction in bile related pruritus. And with the reduction in cytokines, it is expected that the multi-organ failure should improve with improvement in liver and renal function. And mostly you have to remember that all of these are bridges to transplantation. So if a patient with liver failure comes to us and is planned for a transplant, until the transplant we can do these technologies to try to continue the life of the patient and then make them fit for a transplant. Thank you everyone.
Thank you, ma'am. That was powerful exchange of invites. Let us give a big round of applause. May I now invite Mr. A.T. Srimukund, Treasurer, STDP, to present the mementos. Thank you, sir. Thank you, ma'am. Next, we would like to present a message from our sponsor. Please view the following video.
Real-time access to patient data, lab results, vitals, dialysis sessions, alerts for critical values, misdialysis or complications, trend analysis for key parameters like urea, creatinine, EGFR,
Moving on to our next session, technology and innovation are closely intertwined, driving process and transforming industries. Now, I graciously invite Mr. Vishnu, Lardsmark Industries Private Limited, Mumbai, to share your expertise on indigenous innovation in dialysis technology. Sir, please.
வரல
So very good afternoon, everyone. So my name is Vishnu. So I'm the Regional Service Manager South, covering Tamil Nadu and Kerala. And I'm from Lordsmed Renal Care, and today I'm going to present about how Lordsmed Renal Care is going to revolutionize renal care by providing indigenous innovations in dialysis technology. So before going to our solution, first of all, we need to be thorough with what is AI. So here our solutions are purely based on AI. And before going to the solution, let me give an introduction about my company. So Lordsmed Renal Care is a business division of Lordsmark Industries, and we are having various business divisions across IVD, renewable energy, LED business, as well as paper business. And we are having different subsidiaries as well as associates, in which we are having presence of biotech field and microbiotech, defense technology, etc. So we are having a strong presence in both private and public sector, and we are having rapport with different public and private companies, and we are having a strong relation with good MNCs like Philips, Cipla, Braithwaite, and Premier Energies. So now let us move to the solutions offered by Lordsmed Renal Care. So it's a purely indigenous solution, and it's completely AI based. So we are going to cover every aspects of the patient here, or every continuum of the patient, from screening to treatment. So the first thing is a mobile app which is known as Reach. So using this Reach app, a patient can diagnose, or a person can check whether he or she is suffering from chronic kidney failure or not, using a test strips. So once they diagnose with renal failure, they can use the next mobile app which is known as Care app, and it's purely an AI-based platform. So using this, they can manage the disease, and it will give more empowerment for the patient. So it will be very helpful for the patient who is mainly focused on home dialysis. And next one is a continuous monitoring platform, which is a web portal which is known as digital nephrology platform, in which they can monitor the vitals as well as the biochemical parameters as well as the dialysis parameters of the patient during the treatment. And as I already told, so when you're doing continuous monitoring, we need a dialysis machine to do the dialysis. So we are having a IoT-enabled dialysis machine which can be integrated with this digital nephrology platform. So now you can see about the first continuum, or basically first aspect, which is known as Reach app. So using Reach app, a normal person or a person in a rural area, they can screen whether they are suffering from chronic kidney failure or not by using a economical ACR test strips. And it can be smoothly integrated with hospitals, clinics, as well as it can be also integrated with the clinical persons. So it is very helpful for the person who is having a high risk to get chronic kidney failure, basically those who are suffering from hypertension, heart disease, etc. So you can see here, basically you can use this app during medical camps. So you can take your phone, you can install this app, you can do the test, and you can check whether the specific person is suffering from chronic kidney disease or not. And next one is nothing but Care app. So once the patient is identified with chronic kidney failure, they can go for the next platform, which is known as Care app. So using Care app, basically they can manage the disease. So basically it is used for the patient who is suffering from chronic kidney failure. So it will be very helpful, and it will give there is more empowerment for the patient. So it can be connected with the doctors, especially the clinical person, doctors, technicians, dietitians, as well as social workers, clinical coordinators, etc. And as I already told, the person who is undergoing home dialysis, they'll be gaining more benefit from this. So during the treatment, they can do teleconsultation using this app with the nephrologist. And you can manage the medication reminders, lab reports, as well as dialysis schedules using this app. And once the patient is getting any critical clinical alarms, it will send the alerts to the nephrologist. So nephrologists can also access to this app, will be getting access to this app, and they'll be getting instant clinical alerts. Now let us move to the next platform, which is known as a digital nephrology platform. So using this digital nephrology platform, you can mainly check, or you can do the real-time monitoring of the patient who is undergoing hemodialysis. So once the patient enters to the hospital, or once the patient engages with the hospital, the role of the digital nephrology platform starts. And you can see these are the key stakeholders of digital nephrology platform. Who is a receptionist, we are having technician, doctor, nurses, even the dialysis unit owners can access to this app. So all this will be integrated in a cloud. It's a completely secured form of data storage app. And next one is, you can see, it will be very helpful for the dialysis centers which is having a hub and spoke facilities. And you can integrate it with hospital management system as well as care application. So the beauty of this digital nephrology platform is you can integrate, or you can add, or you can remove different modules here. So the main feature is customization. For example, you can add drug and disease databases, teleconsultations, donor management, patient health records, billing and inventory, disease management, dashboards, as well as remote monitoring. Suppose if you don't want 3 of the modules, you can remove and you can add the remaining modules. Or if you want more modules, you can also add the modules. Now you can see the salient features of the digital nephrology platform. So the patient can make smart appointments which can improve the patient's satisfaction, as well as the machine bed management or machine bed allocation will be more flexible, which can reduce the workload of the dialysis technician, and remote dialysis monitoring, which will be very beneficial for the patient as well as the nephrologist. Now next one is a workflow automation, so that it can generate reports, or it can generate the dialysis dashboards, and it will be very helpful for the dialysis technician. And next one is a very, very important feature. Here you can track the dialyzer reuse management. So basically it ensures the patient's safety here. And next one is clinical data management. So they can mainly access, or the nephrology can mainly access to the clinical data of the patient in order to do the clinical research or clinical study. And report generation, and it will be very helpful for the patient if they want to do any claims. So the basic thing is this digital nephrology platform, after the treatment, it generates the reports. And you can integrate this with HIS or hospital information system and third-party manufacturer machine. All manufacturer machines can be integrated with this platform. And it is having a built-in billing feature so that you can generate invoices and you can maintain basically the dialysis consumable inventory. So now let us see our key stakeholders. So coming the patient point of view, so they'll be having less waiting time and easy dialyzer tracking, which results in patient satisfaction and patient safety. And for admins, it will be very helpful, or it will be very beneficial. That is, the main thing is we can go for paperless mode. So it's very cost effective, and we can go for eco-friendly mode. And they can track the machine utilization. They can mainly check the ROI for the machine, and it will be very helpful for hub and spoke centers. So basically in hub and spoke center, they are mainly using paperwork, and it will be very complication. It will cause many complications for the admins to auditing and all the things. So this can be mainly avoided by digitalizing the hub and spoke center, which improves the quality audits. And you can also check the machine maintenance. And this machine, we are having an IoT-based machine which is having a predictive maintenance feature which results in less downtime. Now, coming to the doctor's point of view, as I already told, it's a real-time monitoring application, and using this, the doctor will be getting the real-time alerts or real-time clinical alerts of the patient. And of course, it generates the reports so the doctor can do the research, clinical research, as well as clinical study of the patient. Now coming to the technician side, so it is having an automated workflow which can reduce the workload of the technician. For example, once the patient enters the dialysis center, the technician is responsible for taking the weight of the patient, blood pressure of the patient. They need to enter all the details in a logbook or basically in the report book. So this can be avoided by integrating the weighing machine and blood pressure machine to the digital nephrology platform. And as I already told, it is a paperless mode. So that's all about the digital nephrology platform. Now let us see about our newly launched or our new dialysis machine. So the model name is RXT21, and it's a pure AI-based machine which is completely developed in India, tested in India, and manufactured for Indian markets. So now let us see some features of the machine. Basically, it is having a one-touch step, and basically it is having on-screen guidance. And you can use this machine for flexible treatments, modalities like you can go for a conventional HD, as well as you can see sled operations. And it is more safer, reliable due to the European CE certification, and it is having a CDSCO license. And we can go for personal treatment. Like that, you can go for customization in the clinical treatment. Like you can go for UF profiling, sodium profiling, HD, sled mode. And you can see here the main beauty or the main feature of this machine is Bluetooth and Wi-Fi connectivity. So you can integrate this machine with an SpO2 monitor as well as a blood pressure monitor, and you can connect it via Bluetooth. So once the connection is done, once you take the blood pressure of the patient, all the blood pressure data will be transferred to the machine. And of course, this is having a Wi-Fi connectivity. Using Wi-Fi, you can connect it with the digital nephrology platform. So you don't need any wired connections here. Basically, everything is wireless here. And you can see once you connect wirelessly to digital nephrology platform, as just take a scenario, a dialysis center which is having 10 dialysis machines. So all 10 dialysis machines can be integrated in a single platform which is known as a digital nephrology platform. So once you integrate, you can see all details of the patient who is lying in the 10 beds. And it is very easy to maintain. Basically, as I already told, it's purely developed in India and made for Indian market. And the service cost and the maintenance cost will be very low comparing to the manufacturers. Now coming to other products, so we are also having a dialysis consumer business. So we have tie-up with different Indian manufacturers for dialysis consumer business. So we are having dialysis, which is a low flux, middle flux dialysis, blood tube setting, AVF needle disinfectants, and endotoxin filters. So overall, that's all about the introduction about indigenous innovations in dialysis technology by Lordsmed Renal Care. So if you have any doubts, or if you have any queries, or if you require any demos, you can kindly contact us through this mail, nephrologysales@lordsmark.com. So we are having a stall over there. So we are having a demo dialysis machine. So you can check over the machine and you can have some user experience on that. So once again, thank you. Thank you so much.
Thank you, sir, for the enlightening presentation. I would like to invite Ms. Hemalata ma'am, Organizing Committee of SDPT, to present the mementos.
Thank you, ma'am. Thank you, sir. I now warmly invite Mr. Charan Singh, Director of ASCAT Private Limited, Delhi, to the stage. This session introduces and explains the importance of Indian initiative in dialysis care. I warmly welcome to the stage.
Hello. Okay. Hi, very good evening to everyone. My name is Charan Singh and I'm one of the partner with ASCAT Tech. ASCAT Tech is a company which is registered and it got registered in 2024 April, and we are basically an Indian manufacturer. So I will relate this. My topic is importance of Make in India. Now, to your surprise, so most of you will agree, even today and in fact in dialysis, 80% of the product which you use for your day-to-day dialysis is being imported. So 80% of the consumable in dialysis is being imported from outside. Now the government of India too says that why can't we be self-reliant? So for this, what are the benefit of being self-reliant? So companies, those who do make in India, so they basically are giving more and more employment to the Indian youth. So this is the one major advantage. Now, so today at ASCAT Tech, we have more than 200 staff. We got registered in 24 April, and it's just hardly, you say, 8 to 9 months. We have nearly 200 people in our factory, right? So this is the advantage of Make in India. Now, we got, if I just bifurcate it, so it's not only the complete entire non-skilled manpower. We got 15 sales and marketing people, those who are highly qualified and MBA people. We got 2 quality control guys in our factory. We got 1 production head. We got people for regulatory affairs. So this is the beauty when you make in India. So you are giving the employment to your own people. And we have nearly 200 semi-skilled manpower in our factory. So this is the factory. We are very adjoining to Delhi, which is the capital of India. So the place is called Faridabad. It's in Haryana. This is the factory what we have. We are manufacturing everything as of now in this factory. This is just a baby step. We have planned to build a 4 acres property which is coming again near to Delhi NCR, which is in Jewar. So the government of India is again helping us, supporting us to build this infrastructure. So this property in Jewar is called Medical Park. So we are trying to, we've already bid for it. So we are going for a 4-acre land in that property, and we will be building the entire manufacturing facility there. This is just a baby step. And in this last 8 months, we got ISO certified. We are ISO 13849. And to your surprise, we have all the certification which is required from India government, all the due diligence from CDSO, FDA. We are registered with Startup India. We are registered with MSME. And in MSME also, we are gold certified, right? So the top level certificate from MSME, we do have that. So this is the factory. You can have a look on it. Now, as I said, the government of India is promoting the Make in India. So, again, relating to it, why it is so? To curtail down the dependency on other countries, so that we can make in-house and we can be reliant. Securing our own revenue, which was going outside. And if we secure this revenue here, we build a better economy and a better future for India. Keeping the same vision, at ASCAT Tech, we are trying to build 100% product inside the factory. Of course, we are into developing phase. We are doing a lot of research inside. We are seeking help from other third parties. Even Government of India is helping us to do the R&D also. So we have got some support from the IITians, Delhi. They are working on some of the products for ASCAT Tech. And this has been done only with the help of Government of India. And I don't know whether I have to mention it or not, but yes, we do have plans. Maybe in this new factory which we are trying to build up in Medical Park, Jewar, we are trying to build the first spinning machine in India. Spinning machine is the one which makes the fiber of dialyzer. So as of now in India, no single company makes the fiber. We are trying to build, and with your support, we're certainly able to do that in the coming next few years. We are in that, we are already working on it. We have closed some partial deals. So hopefully by the end of 2026, we'll be able to do it. So that's all. Maybe I have this much. For your information, we not only deal into nephrology, we make the products for cardiac surgery, for nephrology, for cardiology, for general surgery, for critical care. So we are in to put together 4-5 verticals. And we have people associated with us from all these domains with different expertise. So, so this is what, in cardiology, in cardiac surgery also we are doing good. We are making the whole complete custom pack in-house in our factory. We have our own arterial filter. That would be of limited knowledge to you, but yes, we are into this all segments. So I would request and urge all of you to please give at least a chance or a try to the Indian products. We know, we understand there are chances we may not be able to match up that standard which we are being using from quite some time, but nobody becomes perfect in a single day, right? So I would urge, I would request you, if somebody from the Indian company comes out to you, reaches to you, at least give a try, use their products, see, and help us to improvise. We understand there could be some lacunas, there could be some improvement, but with your support we can certainly do it. So I will be looking forward for this support. And in South, this is our first time we are here, and I believe you will help us, you will guide us, teach us. We are ready to accommodate any kind of suggestion if you have, if you want to make any kind of product which is new in dialysis, we are ready. For example, if you want to, I've just recently heard there's pediatric dialysis happening in India, although it is very limited. But for pediatric dialysis, you need a smaller blood line with having a priming volume of nearly 100 to 115 ml. And there's very limited company in India, those who make pediatric blood lines. We are ready to it. Yes, those who are making it, to my surprise, the price is almost sky touching. Whereas the same product, what we can make in the factory is almost half of it, at the half of the cost of what you are getting it today. So this is what we can do. We can innovate the products. If you have anything new in the mind which can help the dialysis patient, you're most welcome. We got a stall outside. You can take my number. You can do the Google ASCAT Tech and give us your input, suggestions. We will certainly try to imbibe and improvise. We are participating in almost all the conferences which are upcoming. Medical Delhi, we are participating. We are participating in Medical Chennai again. We are participating in, Medical Mumbai and Kolkata. We are participating in Arab Health. And there's one conference is happening in September in Delhi, which is again by the government of India to help the Indian manufacturers for exporting their products. So we are participating. It is happening from 4th, 5th, 6th. And we are also participating in a dialysis technician conference happening in Delhi on 20th and 21st September at Amrita Hospital, Faridabad. So we are very much into it, and we would love to hear your feedback, suggestions. Thank you all for your time. I really appreciate it. Thank you so much.
Thank you, sir, for inspiring and provoking presentation. May I now cordially invite Dr. D. Jagadiswaran, Advisor, STDP, to present the mementos. Ladies and gentlemen, now it's time to test our knowledge. It's my pleasure to welcome Ms. Hemalata ma'am as our quiz master for today's competition. Ma'am, kindly take over the stage.
Good afternoon, one and all present here. Welcome to the SDTPCON Dialysis Quiz 2K25. We are delighted to have all of you here for what promises to be an exciting and intellectually stimulating session now. Before we begin, let us briefly go through the rules and regulations of the quiz. Can I invite all the participants to come forward? Can I invite all the participants to come? So can you wait? We will tell you what is what, which team has to be sit in the front and volunteers of SDTPCON, where are you? Please come forward. Volunteers. Team 1 from CMC Hospital, Vellore, James and Sudhakar. All participants should not bring their electronic gadgets. Please hand over the electronic gadgets to your neighbors. Team 2, Ranjana and Usha from Sims College, Vadaparani. Team 2, Ranjana and Usha. Sims College, Vadaparani. Team 3, Aravindan and Martin Francis Raj from Chengalpet Medical College. Team 4, Sam Powell and Praveen Kumar from Srihar. Team 5, Nivasan and Subhashini from Kaveri Hospital, Alwarpet. May I call Nivasan and Subhashini from Kaveri Hospital, Alwarpet. Any other alternative presence from Kaveri Hospital, Alwarpet? Team 6, Rasila Chaitra from Jipmar, Pondicherry. Team 7, Kavya and Monica from Vinayaga Mission, Pondicherry. Team Team 8, Madhumita and Pirai Sudan from Hindu Mission, Tambaram. Team 9, Rajesh and Muhammad Aslan from Sri Balaji Medical College, Krompet. Team 10, Tirupati Raj and Caroline from Kaveri Hospital, Radial Road. Team 10, Tirupati Raj and Caroline from Kaveri Hospital, Radial Road. Team 11, Hemashri and Savita from Hindu Mission College, Tambaram. Team 12, Mahagauri and Nagadarshini from Velamal College, Madurai. Team 12, Mahagauri and Nagadarshini from Velamal College, Madurai. Team 13, Akash and Sujata from Panimalar College, Chennai. Team 14, Mariana, Nisa and Niveda from Savita College, Chennai. Mariana, Nisa and Savita College. Niveda from Savita College, Chennai. Team 15, Sudarshan and Pungodai from CMC, Ranipet. Team 16, Lata Devi and Yuvarani Priya from Sri Ramakrishna Hospital, Kovai. Team 17, Rukmandagaraj Harish Kumar from Narayani Hospital, Vellore. Team 18, Vanishri and Emima from SRM Medical College, Trichy. Team 19, Gayatri and Vivek from ESI Hospital, KK Nagar. Team 19. Team 20, Sophia and Vaishnavi from Apollo Hospital. Team 20. Huh? Team 20, Sophia and Vaishnavi from Apollo Hospital, Vanagaram. Team 21, Gokul Krishnan and Fareen Fatima from Vijaya Hospital, Vadaparani. Team 22, Nityashri and Jennifer from ACS Medical College. Team 22, Nityashri and Jennifer from ACS Medical College. So before we begin, let us briefly go through the rules and regulations of the quiz. So Format and procedure of the quiz is a total of 15 questions will be displayed on the screen. Participants will be provided with the answer sheets which you have now. Only the correct options A or B or C or D should be marked on the answer sheet. Each question has a 30-second timer. Going back to previous questions will not be allowed. Prompt answering is encouraged to complete the quiz within the given time. So, all participants should not bring their electronic gadgets. Before commencing the quiz, each participant will be checked by the concerned organizers and then allowed into the quiz venue. Any form of malpractice or misconduct will result in the immediate disqualification of the team. So the judges for the quiz programs are Mr. Jai Seelan, Ms. Hemalata, Mr. Sandil and Mr. Mukund. The decision of the judges will be final and binding. No queries or objections will be entertained after the evaluation. General instructions: follow all instructions provided by the quiz moderator. Maintain decorum and professionalism throughout the event. Adhering to the rules and regulations ensures a fair and enjoyable experience for all of you. Thank you all. Any queries, you can contact us. Only one response for the questions is encouraged. Multiple answers will not be taken into count. Thank you.
Good evening, team. All the best. Before you kickstart, you will see my slide. It's 50 questions, 30 seconds allowed. You won't go back to, I can't also go back to the previous question. And you have to mark A or B or C or D. We have given you question as well as answer. Are you ready?
We kindly request the audience to maintain complete silence during the quiz to ensure a fair and focused environment for all participants.
Extend port.
சரி நீங்கள் பேசுங்க நீங்கள் ரெடினா நான் ஸ்டார்ட் பண்ணேன் ரெடி பண்ணேன் நீங்கள் கமெண்ட் பண்ணுன்னு சொல்லுங்கள் ரெடினா நீங்கள் ஃப்ரீ ஃபீல் கமெண்ட் பண்ணால் தான் நம்ம ஸ்டார்ட் பண்ணுவோம் ஓகே சார்
Okay, you can see the questions, okay, with the answer. We are going to start.
டைம் உள்ள நெட்டு வேணும்ல
வரோம்
நீங்கள் அதை கேன்சல் பண்ணிட்டு அடுத்த கொஸ்டின் அதான் நான்
30 seconds timer. Please do see the question and promptly answer.
It will come. It was the net connection.
Audience, please do not whisper or give any hints while the quiz is in progress. Thank you.
Wait, boss. Second question. Now okay.
பரவாயில்ல இருக்கட்டும். ஓகேவா? மூணாவது ஓகேவா? ரெடி ஆயிடுச்சா? இதுலேருந்து 30 செகண்ட்ஸ் போட்டோம். எனக்கு டைம் வரலையே.
Automatically it is going.
கொஞ்சம் பாருங்க, டைமிங் பாருங்க.
Time automatically going.
ஓகே, இங்கே ஓடணும்ல, நான் சொன்னேன்ல. தெரியுது. லைட் ஆஃப். அந்த பட்ல ரைட்ல இருக்கு, லைட் ஆஃப். அதான் போகுதுல்ல. 30 செகண்ட்ஸ் ஆகும். நீங்கள் தள்ளாதீங்க, அதான் போதும்.
அதல்ல.
டைமிங் ஏன் வரல? சரிங்களா? எங்கே மிஸ்டேக் பண்ணுறோன்னா அதுதான் தெரியும்.
No, automatically it is going. No need. It will go automatically.
சரி, நீங்கள் பார்த்துக்கங்க. 30 செகண்ட்ஸ் தான் என்கிட்ட வருது. யார் அது?
Audience, you can self-test among yourselves and we can see the results.
போட்டியில் கலந்துக்கிறவங்களை விட மற்றவங்க இருக்குவாங்கன்னா உங்கள்கிட்ட இருக்க ஸ்கிரிப்டிங் பேடில் உங்களே செல்ஃப் டெஸ்ட் பண்ணி பார்த்துக்குங்க. நான் சொல்கிறது புரியுதா உங்களுக்கு? தயவு செஞ்சு இதோட இது கலந்துக்கிறத விட உங்களுக்கு முக்கியம். நீங்கள் உங்களோட பேடில் ஏபிசிடி போட்டு கொஸ்டின் ஆன்சர் போட்டு செல்ஃப் டெஸ்ட் பண்ணிக்கிங்க. தேங்க்யூ.
We are stopping in 20th quiz. If you have any doubts or clarification, can come front and ask. Any doubts? Any doubts you have? Yes? Doubts ஏதாவது இருக்கா?
செக் சார், அந்த கிரீன் கலர்ல ஆப்ஷன் வருதுங்கல்ல, அது தெரியவே மாட்டேங்குது. ஆப்ஷன் வந்து ஸ்லோவா வரதுனால எங்களுக்கு டைமே இல்லை.
அங்க போயிட்டு நிக்கிறான் சைடுல. உங்க கன்சர்ன்ஸ் எல்லாம் மாடிஃபை பண்ணிட்டு இருக்கு. வெயிட் ஃபார் a minute. நெக்ஸ்ட் டவுட்ஸ் ஏதாவது இருக்கா? கிளாரிஃபிகேஷன்? எனி டவுட்ஸ்? ஆன்சர் ஷீட்டில் உங்களோட நேம் அண்ட் ஹாஸ்பிட்டல் ஆர் காலேஜ் அது லெஜிபிளாக எழுதுங்க. ஸோ ப்ரீவியஸ் டீம் மெம்பர்ஸ் சேஞ்சாக இருந்தாலும் இப்போ ப்ரெசண்ட்டாக யார் இருக்கீங்களோ அவங்களோட நேம்ஸ் அண்ட் காலேஜ் ஆர் ஹாஸ்பிட்டல் கிளியராக எழுதுங்க. Audience, please remain silent.
Renal Therapy Information Management System. Clinical decision support. Real-time access to patient data. Lab results, vitals, dialysis sessions. Alerts for critical values, missed dialysis or complications. Trend analysis for key parameters like urea, creatinine, EGFR, dry weight, BP. Streamlined patient management. Centralized patient profiles with dialysis history, comorbidities, medications. Integrated prescription and medication tracking. Improved treatment outcomes. Enables personalized treatment plans based on historical data. Facilitates early detection of complication, fluid overload, anemia. Supports protocol adherence and documentation for clinical audits. Efficient documentation and reporting. Recommends evidence-based interventions based on real-time data from lab reports, patient history, and machine parameters. Empowers nephrologists and nurses with timely insights. Integration with lab, EMR, and imaging systems. Seamless access to lab and radiology result. Integration with EMR, EHR for complete medical history. Better communication and coordination with nurses, dietitians, technicians, and clinical specialists. Shared care plans improve multidisciplinary coordination. Customization for nephrology workflow.
started already.
எது வரக்கூடாதுங்கிறாங்க? இது வரக்கூடாதான். அந்த கேமரா கட் பண்ணுங்க. ஓகே 22 ஓட்டும்.
ஏர்டெல் செல்ல ஒரு கேமரா வருது, அதை ஆஃப் பண்ணுங்க. கீழே இருந்து பார்த்தா தெரியுது. ஆஃப் பண்ணு.
ஓகேவா? என்ன டவுட் இருக்குன்னு சொல்லுங்க.
டவுட்ஸ் ஏதாவது இருக்கா உங்களுக்கு? queries answered ஆயாச்சு. டவுட்ஸ் அண்ட் queries ஏதாவது இருந்ததுன்னா முன்னாடியே சொல்லுங்கள், சீக்கிரமாக கிளாரிஃபை பண்ணிடலாம்.
கால்குலேட் பண்ணி மாற்றுங்க. நீங்கள் கேட்டுங்க. எனி டவுட் இருந்தால் சொல்லுங்கள். இப்போ நான் மாற்றிக்கிறேன்னு நீங்கள் ஒரு வார்த்தை பேசிக்கிறீங்க. அதான் நல்லாயிருக்கும். தமிழில் பேசுங்க.
எதனா டவுட் இருந்தால் எனக்கு சொல்லுங்கள். we will correct it.
சரி ரைட். மொபைலில் இருக்கு.
ఏదైనా డౌట్ ఉందా యూ క్యాన్ గివ్ మీ అ పాస్, ఆస్క్ మీ టు పాస్ ఇట్.
Thank you all. That concludes all the questions for today's quiz. Please remain seated. Mr. Sendil will be collecting the answer booklet from you all.